All right, good morning. Welcome to the Ophthalmic Artificial Intelligence Summit. My name is Rishi Singh. I'm one of the co-moderators for today's program. And we have an agenda that's packed full of really great presentations and sponsor presentations today. So welcome to this meeting. This has been our third Ophthalmic and Artificial Intelligence Summit. We're growing each and every year. We have over 700 people watching today. So thank you all for joining this program. Here is the learning objectives for today, and we're going to discuss some of the basics for artificial intelligence platforms, testing and validation that goes in those platforms. We'll demonstrate the outcomes of these platforms on their impact in clinical care. A lot of the presentations are very practical. It's not, presentations that are so theoretic to the point where you're not going to see them in clinical practice. A lot of our presentations you're going to see in real time in very short periods of time in our own hands. We're going to discuss some of the practice management considerations with artificial intelligence and recognize the potential to tailor therapies based upon different diseases. Even some of the most complex diseases we take care of, like wet macular degeneration, we have a lot of ability to potentially tailor our therapy with some of the artificial intelligence discussions and platforms that we have that can help us better manage our patients better. And we'll also discuss the cons, the limitations, the challenges that we all are going to face with artificial intelligence pathways. Many of us haven't obviously trained in this area, and so there's a lot of education needed, and therefore this webinar really serves as some foundational pieces to help everyone understand the basics for artificial intelligence platforms. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals, and I'm going to introduce my co-directors for this program. We've done this for 3 years now, and we've learned a lot from all of the participants and the abstracts that have been presented here. And it's been just a wonderful experience to work alongside my colleagues, Dr. Ted Lang from the Byers Eye Institute in Stanford, Dr. Jennifer Lim at the University of Illinois in Chicago. And again, I'm Rishi Singh from the Cole Eye Institute in Cleveland Clinic in Florida. And we have faculty from across the world. One of the benefits of having a webinar, especially with this sort of content, is that we can get content experts from across the world and experts in their field to really help us and participate in this. And I'm excited to have all of these people join. You can see some of them here, and I'll introduce them as we go along in today's program. And also, I wanted to thank our abstract submitters. These are people that we've asked to submit abstracts to the program, and they've undergone consideration by a panel, and they've won the ability to present today, which is very unique and allows us again to continually look at the innovation and the cutting edge applications of artificial intelligence through some of these abstracts for today's program. We want to thank our sponsors, because without these sponsorships, we could not do this webinar. We've obviously had great sponsorship for the past couple of years, and this meeting continues to grow exponentially. So we're very excited to have these sponsors that have been able to help us. And you'll hear from some of them during today's program. So thank you again to these sponsors for helping us, again, start this program and continue it for year after year. We're able to take questions. This is absolutely live. So you can put your questions in the Q&A icon, and we're happy to get to them. We have set times during all of this meeting where we have discussion periods where we're going to discuss the abstracts. And certainly no question is too easy or too hard. We're always happy to have our speakers be challenged by some of these discussions as well. So let's get started. I'm going to turn it over first to Dr. Ursula Schmidt-Erfurt, who's going to talk about automated fluid monitoring for optimized real-world management of neovascular AMD. And we'll go ahead and get her started.
Dear Chairman, colleagues, and friends, it's my great pleasure to talk to you about automated fluid monitoring for optimized real-world management of neovascular AMD. So the three most important keywords are automated, fluid monitoring, and real-world. These are the disclosures of all authors. We are already using an automated OCT-based tool which provides central retinal thickness measures. However, a CRT does not correlate with true retinal fluid volumes. And in an analysis that we did in more than 40,000 OCT scans, we found a correlation between CRT and fluid volumes that was below 0.5. So CRT is not great and not a reliable parameter. Nevertheless, CRT has been used in all of the famous durability trials, faricimab, double-dose Eylea, and so on, trying to introduce a very useful concept of personalized treatment intervals, however, based on CRT. This led to variable switching among groups and loss of visual benefit. So we have to start differently, because we have meanwhile learned that compartments and volumes in retinal fluid matter. Fluid in neovascular AMD comes in three compartments: intraretinal, subretinal, and sub-RPE. In our daily work on these gray shade fly-throughs, this is hardly accessible, but the magic mouse click of AI easily provides distinction in the fly-through on these compartments as an on-fuss image, brings accurate numbers for volume dynamics, and an overview on long-term follow-up, which is basically disease biology. Using such volume measurements in large studies has contributed very precious insight. So in the Harbor study, dose and regimen were compared, and the follow-up over time in intraretinal and subretinal fluid offers the real disease dynamic, so to speak, the heartbeat of intraretinal fluid and subretinal fluid. And like a fever measurement, a clear dose-regimen correlation could be established with showing more efficiency with higher dosage and tighter regimen. The study provided another important insight, which is that all volumes are relevant for visual acuity, whether it was in the Hawk or in the Harrier study, in IRF, SRF, or PED. The higher dose seen here in the darker color the higher volume always led to loss in visual acuity. So does this also work in the messy clinical routine? The VIBE study is an analysis of all of our patients in the macular outpatient clinic. It is based on 1,127 treatment-naive patients and includes around 25,000 zeros and 14,000 spectralis volumes. And VIBES clearly reflects what happens in clinical routine over 5 years. Early resolution during the loading dose is then followed by permanent recurrence. This is true for intraretinal fluid and subretinal fluid, and it is true for the central 1, 3, and 6 millimeters. So proving that this type of fluid measurement is very much precise and reflects the real world. Another real world evidence comes from the FRB Fight Retinal Blindness Consortium. So a clear correlation over as long as 48 months shows that it is intraretinal fluid which comes with visual loss if the volume, again the dark line, increases, which is not true for subretinal fluid and for PED. Why is that so? Why do we have such a nice fluid and function correlation? Because photoreceptor damage comes with intraretinal fluid. This is true for photoreceptor thickness, which is reduced with higher volumes of intraretinal fluid. It is also true for the photoreceptor loss area. It is not true for subretinal fluid, where photoreceptors are in a much better condition. So obviously the biological activity matters. A no-brainer, but yes, has to be proven. Here are some examples. A patient with aggressive IRF and continuous activity. In the follow-up curve, you see the injections in black, BCVA in orange, IRF in green, and SRF in blue. There is no visual improvement as long as there are bi-monthly IRF spikes. And remember, this bi-monthly comparison is the benchmarking in all of the interval studies Obviously, not something that comes with ideal visual outcome. Let's see what happens when you switch from bi-monthly to monthly treatment. IRF then is silenced and visual acuity can improve. We said that SRF does not matter so much for fluid. However, this is only true when the volumes are small and not when they are high, like seen here, where visual acuity then will decline nevertheless. And always keep in mind that CRT does not distinguish between the two different compartments, despite the fact that they have such a differential impact on vision and on photoreceptor performance. So, is this a fun toy or is it truly needed? Large-scale analysis highlight the poor outcomes of real-world AMD management. This has been done in Great Britain and also in the US, and the conclusion is very uniform: moderate anatomic and limited visual acuity improvements. We need better registries to understand what is happening on the level of the retina. The socioeconomic need is overwhelming, with AMD incidence increasing, need for injections increasing, OCT imaging increasing, and budget investments into therapeutic drugs increasing. And yet, GA injections have not fully arrived, but they will cause much more workload. AI is the solution for the problem. It provides fully automated and reliable AI-assisted analysis of routine OCT images. It's accessible at any place and any time in real time. Quantitative evaluation eliminates human errors. Optimal treatment parameters can now be established based on true measurements, which will introduce a paradigm shift in trials and real-world practice and will reduce the human resource strain and healthcare costs. Is this available for everyone at every time? Yet it is. So the Heidelberg Engineering Epway platform offers the fluid monitor, which is the only algorithm that is entirely MDR Class 2 certified. It is GDPR and HIPAA compliant. So this is the type of reliability of tools that we need. And yes, it is available for everyone, anytime. With this, I thank you for your interest and wish you the best benefit for your patients in the future. I thank our partners at RetinSight and Heidelberg Engineering, and I'm from the Medical University of Vienna.
Thank you, Ursula, for that presentation. So what a interesting application for artificial intelligence we all are probably aware of, and highlighting some of the limitations, obviously, of our current analyses. So I appreciate that, and we'll get to questions for her presentation in a few moments. I'm going to turn it over to my first presenter. If you could advance the slide, please. Great. And we're going to hear from Dr. Elliot San, who's in Iowa, University of Iowa, talking about AI accelerating neovascular AMD immunogenic phenotyping. Elliot?
Thank you so much, Dr. Singh. It's a great pleasure to be with you. And I couldn't ask for a better introduction than Dr. Ursula Schmidt-Erdford's talk. It's just a perfect segue into what I'll be talking about today with OCT image analysis. So I want to acknowledge my co-authors, first of all. You know, the AI team that I work closely with at Iowa. I'm very fortunate to work with Milan Saka, Kit Lee, Kyung Lee, who's moved on to TopCon, unfortunately, but other great team members as well, including Michael Abramoff here, that helped work on this project. But this is really a kind of multidisciplinary collaborative project, and I'm having a little issue advancing slides. There we go. Okay, so no financial disclosures for this talk. And I'm going to be talking about really automating OCT analysis. And the idea of automation has been around for a very long time. Industrial revolution, computers, robots, even starting with the water wheel. More recently, you know, automated driving and ChatGPT have attracted a lot of attention by society. And these are real evolutions for us. And this graph here shows how close we are to having a true self-driving car. Maybe Rishi already has this available for him, but the Society of American Engineers finds that it's level 3, almost there where we have an autonomous vehicle. So when I looked at my own group's kind of first foray into looking at AI image segmentation. I found this article from 2006 where they were able to use new algorithms to look at the ILM and RPE. And so they were able to do this in the first step towards being automated analysis for scans. And I'd be curious to know how many people could guess the correct number of references that they had for this kind of early paper. Well, it was 9. So 9 references here, not a lot of references. Obviously, this is pretty early work here. And obviously, we've come a long way since 2006. So our Iowa reference algorithms are publicly available algorithms. You can access them on the interwebs, and you can use them to segment human and mouse OCTs. They've been available for quite a while. We started doing a lot of mouse OCT work when we were doing a lot of work with diabetes. And so we published that paper in 2016. But here you can see some of the mouse segmentation and how we had the manual graders really help set up the automated process to be able to see all of these lines without the assistance of a human by this point. So we've now been applying AI to be a tool for AMD as well. And it's really, I think, a breakthrough tool. And Ursula already talked about how this is really important for fluid analysis. So for the fluid analysis for intraretinal fluid, subretinal fluid, PEDs, being able to automatically segment this on OCT was really difficult prior to AI. It could be done, but it wasn't very accurate. But we can use AI in AMD for diagnostics of OCT, fundus imaging, as well as functional tests. I've seen several uses of that as well for psychophysical tests. Treatment decisions, there are now some papers being used to describe this, as well as outcomes, as we've already seen from Ursula's talk. Now, the holy grail, of course, is to be able to predict progression to more advanced stages. We've seen a couple groups start to be able to scratch the surface at this, and we're just at the start of this. But hopefully AI will be able to allow us to do this later. And there's a couple great talks later today that also will start looking at these aspects. So how have we used AI for our research, specifically in neovascular AMD? Well, I'm going to show you first how OCT analysis is helpful for us. There's up to 50% of patients with neovascular AMD who don't respond completely to anti-VEGF injections. And so we really wanted to look at that question, why is that? And I'll show you how AI has helped us to be able to do that. So in 2016, there was a paper by the International AMD Genetics Consortium in Nature Genetics talking about 34 different loci that were derived from this large genome-wide association study for AMD, looking at rare and common variants. And one particular variant, MMP9, matrix metalloproteinase 9, was one that was really kind of highlighted as showing a difference between those with CNVs and those with dry AMD. So we really wanted to look at this in our own cohort, in an independent cohort, to replicate this, because it's very important when GWAS finding is new to be able to replicate in an independent cohort. So we did this in our own group of patients of 1,700 subjects with AMD, some with neovascular and some with dry AMD, and we were able to confirm that there indeed is a signal specific for neovascular AMD compared to dry AMD with MMP9. So MMP9 is a molecule that's also known as type 4 collagenase. So type 4 collagens are present in Bruch's membrane. Also, it's found in the cord, as I'll show you in a moment here. And several studies have showed that increased systemic levels of MMP9 is found in humans with AMD, as well as choroidal neovascular membranes. Knockout mice, when they are lasered to create a CNV, do not really get CNV. So very interesting point there. We've done some single cell sequencing analysis showing that MMP9 really in humans, cadaver eyes, predominantly expresses itself in dendritic cells of the human choroid. So these dendritic cells, of course, being immune cells. We've done some cell culture studies showing that dendritic cell expression is highest for MMP9 compared to other kinds of macrophage cells. So now we're looking at how MMP9 is related to immune status. So we wanted to ask, what is the contribution of high-risk MMP9 genotypes to neovascular AMD in a clinical scenario? And can we see some systemic abnormalities in the immune system in those with high-risk MMP9? So look at the phenotype of patients with high-risk MMP9. We have to do OCT image analysis, and that's where AI really comes in handy. We also looked at injection burden as well as the systemic immune function. So to segment our OCTs, we use an ensemble approach of 3 different kind of unit architectures to simultaneously segment intraretinal fluid, subretinal fluid, and PED in 100 patients using 90 for tenfold cross-validation and a validation data set of 10 subjects. All of these patients were getting anti-VEGF injections for neovascular AMD. So here's a typical result. We have 3 patients. The first one here, the middle is the ground truth. So that's what the graders had come up with in terms of where the PED fluid is. That's in green, and in yellow is the subretinal fluid. And on the right, you can see the automated result. The computer-trained AI algorithm looks very good. It looks very similar to the ground truth. Another patient here with intraretinal fluid in red. You can see the ground truth in the middle. It is delineating all those areas of intraretinal fluid. The automated result using our algorithm was quite good. Not perfect, but still very good at what the ground truth came up with. And then combining all 3 of those in one patient, intraretinal fluid, subretinal fluid, PED, was also very good, as you can see on the far right with the automated result. So we ended up doing this on 98 eyes. There was 100 eyes total. I'll show you why we couldn't get it on a couple of patients. But in terms of subretinal fluid, in terms of the prediction versus the ground truth, the R-squared value of that, so the prediction of that was very good. The correspondence between the prediction and what the manual graders were getting was excellent at 0.95. The R-squared value for PEDs was 0.89, so it's still pretty good. And for intraretinal fluid, it was good, but not quite as good as for PEDs. And subretinal fluid, the R-squared value, as you can see here, was 0.85. So again, this is something that we weren't able to do prior to AI, but we still had a failure of 2 patients here. You can see quite a bit of fluid here. It would be challenging even for a human to be able to really accurately delineate where the fluid pockets are and what they are, but it certainly could be done. So we looked at the characteristics of 17 of these patients. We had an MMP9 genotype already on and getting injections. And I'm just going to highlight here the important thing is down at the bottom, really, is that the level of intraretinal fluid at 1 year after start of injections was high in those in the high-risk MMP9 genotype group compared to the low-risk MMP9 genotype group. So we really used AI here to leverage the ability to look at fluid cavities and now start to make some determination on what's happening at the basic level in these patients with neovascular AMD who are resistant to anti-VEGF therapy. We've also done some immune phenotyping of these cells. I'm using the Cytec Aurora. I'm not going to go into the extensive methodology for this, but we did find, even with 6 patients, 3 in the low risk and 3 in the high risk, some trends of differences of CD4 and CD8 cells in the peripheral blood of neovascular AMD patients. So also very interesting to see that. So in conclusion, we know that now using automated segmentation can offer performance that's really close to the expert. And so we've used this as an important tool in research to overcome barriers in OCT segmentation, because the number of scans that we had here were about 129,000 volumes, and this can do it now in an automated fashion. So the usefulness of AI is directly linked to our ability to diagnose it, which sometimes can be challenging, as I showed you with those 2 patients. So you really do need to have a gold standard physician to be able to give the algorithm the right inputs. I think ultimately, the potential for AI is hampered by our own lack of understanding these important mechanisms in AMD, but AMD will help us be able to make further breakthroughs. Thank you very much for your attention.
Great, thank you for that talk. And so, Elliot, I'm going to have you hang on while we go to the next presentation. Will be by Dr. Nadia Waheed from Tufts University in Boston, We'll be discussing microperimetry data from Oaks and Derby.
Thank you so much, Rishi. And I'm going to be talking about microperimetry in GA trials, the Oaks trial experience, and talk about some of the, I think, more machine learning than AI softwares that we utilized during the course of this clinical trial. So I'll try to highlight some of those. Now, just want to acknowledge Yasin at the Boston Image Reading Center and Eric Molt at MIT, who were responsible for the development and implementation of the algorithms and softwares that we used in this analysis. So we know that functional testing is a requirement for approval in many countries, and microperimetry is one of the few functional assessments in GA that tends to correlate with both GA size as well as GA growth. And so, in the Oaks trial, they were, which was a phase 3 clinical trial, there was microperimetry deployment in over 100 sites for patients who have geographic atrophy. And then we use novel analytical methodologies using computational customization of microperimetry grids in high-risk areas of the retina. It's really interesting in terms of being able to correlate structure to function. And it may find use in future clinical trials of therapeutics for GA, as well as for other retinal pathologies that involve progressive retinal degenerations. So a little bit about microperimetry. So as you guys all know, standard clinical tests to evaluate visual function in patients with GA provide poor anatomical and functional correlation. Some of that has to do with whether there's foveal involvement versus non-foveal involvement of the GA, and whether they're unifocal or multifocal lesions. But visual function tests are important. They're important because they matter to patients, and they're also important because they matter to regulators as we, talk about getting these medications approved. I think they will become especially important as we go forward and have treatments available for these diseases, and especially modeling and machine learning based modeling of patients and potentially vision loss will become important as we counsel our patients and kind of try to identify what patients are best for these treatments. Microperimetry is interesting because it gives you very granular regional data and enables anatomical functional correlation. It's somewhat independent of whether there's fovea involvement or fovea sparing. And of course, recent advances in MP devices, such as the ability to track and the ability to register functional signals with structural parameters really provides us with that additional piece that's missing in many of the other functional testing spaces. Now, I don't want to sugarcoat this. Microperimetry is hard to do in patients. It requires patients sitting there. It requires time. And it takes it requires a lot of attention, and it requires operator skill as well to make sure that patients are focused and attentive and it's moving along. So it's not an easy test to deploy, but it's one of the few that do give us structure and function correlation. So there have been several publications that have looked at microperimetry in patients with various stages of AMD. And what we found is that retinal sensitivity appears to be relatively normal in parts of the retina that are uninvolved, and then tends to drop precipitously right at the margins of the GA lesions. And of the visual function tests, larger clinical trials, such as the Chroma and Spectri study over here, have shown that only microperimetry outcomes are moderately correlated with GA lesion area, as well as the fact that it's one of the parameters that longitudinally correlates with growth or change in GA lesion area. So talking a little bit about pegcetacoplan, the medication that was used in the Oaks clinical trial based on pooled data, we know that pegcetacoplan slows GA progression with both every other month and monthly dosing, with effects increasing over time. And mesopic microperimetry using the Maya microperimeter, as I mentioned, was conducted in the Oaks phase 3 study as one of the many visual function endpoints that were investigated in this study. So I think one of the issues with mean microperimetry results are that they're confounded by the large weight of the dead zone in GA areas, in GA lesions. So if you look at this GA lesion, for example, it's a fairly large lesion. The microperimetry is done over the entirety of the lesion. And so some of the results of the microperimetry are because you're averaging lots of zeros and minus ones, and it's pulling down the overall mean microperimetry in these patients. And indeed, we see that when you look at just the mean microperimetry over the entire foveal grid, you don't really see a difference. between treated and untreated eyes, as you can see over here. However, when we think about it, if pegcetacoplan causes preservation of retinal tissue at the margins of the lesion, this should be reflected in preserved photoreceptor function in the retina near the GA lesion borders. And if the linear expansion of GA lesions is about 100 to 150 microns per year, you should actually be able to see that in perilesional microperimetry. So when we were looking at what kind of post-hoc analysis to do, one of the things that we thought of in our lab was, well, what about if we assess changes in the perilesional zone visual function of retinal cells as measured by microperimetry in subjects undergoing treatment with pegcetacoplan, as well as in the control group that was enrolled in this clinical trial. And so you see that approach over here. So this shows you the GA lesion growing over time in this marginal zone. And you can see exactly where the GA lesion grew over here. And so the goal would be to assess the microperimetry over this blue zone of GA lesion growth to see if it would really bring out the kind of signal that you needed to see. So there are several strategies in which you can do it. You can do lesion tailored grids, but they're really operationally complex, or you can do a custom analysis of a standard grid, which is operationally simple and basically requires basically all that it requires is customization of softwares that will look in that perilesional area of interest. So it does the work of a lesion tailored grid without having to tailor grids per patient, per site, per device. In this study, patients got a 10-2 grid centered on the fovea with a 4-2 threshold strategy performed at baseline at various time points of follow-up. Custom software was developed at the Boston Image Reading Center for structure functional analysis, and basically the GA lesions, the traced GA lesions, were placed into the software. The software did image registration of the fundus autofluorescence image with the microperimetry image, and then, as you can see over here, sorry, the animation is a little bit slow, were superimposed on their respective fundus images and registered with FAF images by the automated software. And for each MP stimulus point, the shortest distance to the GA margin in microns was computed, with negative distances, of course, representing stimuli points located within the region of atrophy. A junctional zone, which is an area within 250 microns of each side of the GA lesion border, was created. And a lesional mean analysis was done in this junctional zone. We also looked at number of scotomatous points. So what happens if you look at these patients, over 500 patients really, and analyze the junctional zone? And what we find is that the junctional zone actually is much better able to bring out the changes that happen between the control group and the two treated groups. As you can see, you're starting to see separation at 12 months, and then the separation becomes really apparent at 24 months, both in the mean threshold sensitivity over this junctional zone, as well as if you look at the number of scotomatous points and the changing number of scotomatous points over time. Here's the take-home message. To summarize functional testing, especially when done, when you're looking at a structure functional analysis, and then using novel analytical methodologies using computational customization, may find use in future clinical trials of therapeutics for GA, but also of other retinal pathologies that are progressive and result in destruction of function. Thank you for your attention.
Great, thank you, Nadia. So we're going to get to questions for you as well as we progress through the webinar. So please feel free to answer. There are questions already coming in, so it's wonderful to see interactions that we're going to have in just a moment. And we're going to turn over to the next presentation, which is going to be by Dr. Anat Lowenstein. She's going to talk to us about artificial intelligence-based spatiotemporal observations in retinal fluid dynamics. Anat?
Thank you very much, Rishi, and thank you very much to you and the other organizer for inviting me to participate in this really very exciting platform. And I think that your introduction actually is very suitable for my presentation that really talks about using AI for the management of our patients in real life. So very relevant to all of us. So I'm going to talk about the use of AI in the analysis of data that comes from the home OCT. And this slide basically explains what happens using the home OCT. The patient acquires the daily OCT scans, as you can see on the upper part of the slide. He self-images himself, and then the AI actually analyzes the data from the home OCT after segmentation and analysis of the fluid, provides a fluid map, like you can see in the middle of the slide, and a trajectory that shows actually exactly what happens to the fluid over time. So you have a very nice analysis of everything that happens to the fluid in each particular patient. And we discussed it many times and presented it from very many aspects, but this time I'm going to explore the characteristics specifically of reactivation and response episodes as seen during home OCT monitoring, and also to evaluate why is it important. It is important to see if it really changes when we are able to produce timely treatment, and try to see the implications of and benefits of incorporating it into the management of our patients in real life. So this specific presentation is talking about reactivation and response from 54 patients and 57 eyes. They were from a study, it's a cohort from a few studies, but most of them are from a study conducted in the United States by Nancy Holcomb. And we are going to see exactly how the reactivation and responses were temporally characterized, and try to establish a connection between treatment timing and results. So when we look at reactivations, here you can see 27 unique reactivations from start of increase to the time of treatment. And you can see that there is relative variability in the way the reactivation occurs. So the statistics show that the mean fluid increase rate was 12 seconds nanoliter per day. The mean fluid volume was 115, and the mean duration from start to treatment was 12 days. Let's take a closer look. Here you can see a patient that has a very rapid increase in fluid volume, and you can see also both office and home OCT, which so it's not exactly the same quality, but you can identify the fluid. And you can see what happens until the fluid starts to appear both in the office and the way that it starts to be seen on the home OCT. Now, this is an example where you see a very rapid increase in fluid volume to a very high quantity of 703 nanoliters, and the response to treatment is pretty lengthy. So when you have a lot of fluid, the response may take a longer time too. And there you can see it side by side with the office and in the home OCT. Now let's look at the response to treatment. So here you can see the variability in decrease rate, response duration, and fluid volume when it resolves. Basically, the mean fluid decrease rate was 8.3, the percentage 91%, and 46% of the respondents had total fluid resolution, with the mean duration from treatment to complete resolution of 11 days. And in parentheses, you could see the standard deviation. If we take a closer look at this patient, you can again see side by side the office and the home OCT, and you can see the large amount of fluid, and you can see what happens how it resolves, the trajectory, what happens. Here you can see, again, an increase in fluid, office and home OCT, and what happens until it resolves. So we wanted to see the relationship, and we considered 1 week as a kind of practical or desired response time to new information about reactivation and until you schedule an office visit. And then we divided, according to this, the cases that we had to two groups by the time gap between the beginning of reactivation and treatment of more and less than 1 week. So you can see in these three graphs that if the treatment was more than 1 week in the darker columns on these three graphs, So if it was more than 1 week, then there was more than 100 nanoliter difference in fluid volume at treatment. There was an average of 10 days longer time to resolution, and it could be calculated to 700 nanoliters days of fluid exposure, something like the area under the curve. So here you can see an example with prompt resolution after prompt treatment, an example of quick resolution after treatment, and a slower resolution after delayed treatment, which can be explained by the amount of fluid that was there, or a slower resolution after a longer delayed treatment. When we think about how to imply it and what are the benefits for patient care, let's look at these two patients. So when you look at patient number 1, he had fluid at visit 1 and at visit 2, and the same had patient 2. And both of them, there is a month between the treatments. However, there is a very different response between the two patients. Patient number 1, most of the time was without fluid, whereas patient number 2 had fluid all along. So you would think that there is a difference between the two patients. In patient number 1, you might want to synchronize the treatment with the reactivation time via home monitoring, and this can improve the response rate, whereas in patient number 2 is non-responsive, and maybe you should think about switching therapy or about another modality of treatment. So to conclude, remote monitoring with the home OCT used with AI that analyzes the data gives new insight to disease dynamics under therapy. And there is a huge variability in patients. And the time for reactivation to treatment has a significant impact on the treatment efficacy in limiting the fluid exposure to the retina. So this is very practical. It can actually give the patients more timely treatment, of course, with the price of putting new demands on timely office visits and treatment for our neovascular macular degeneration patients. Thank you very much for your attention.
Great, thank you, Anat, for that presentation. So we're going to bring all of our speakers on for this Q&A session as well. So really great questions coming in from the audience. I'll start off with the first question for you, Elliot. This is a question from one of our watchers who said, did you apply some prior information to account for in segmentation like probabilistic networks to segment undeterministic due to various degradation of the fluid? Does that make sense to you as far as the question goes? So, obviously, probabilistic networks may be another valuable method of analyzation of these methods. What was the kind of underlying engine that we were using?
Yeah, so great question. We did not use that type of analysis. So we really used a harmony of 3 different kinds of unit architectures to do intraretinal fluid, subretinal fluid, PED. And we found that alone was very good at segmenting the fluid pockets. But yeah, for overcoming difficult challenges like the couple that I showed, I think using other algorithms, and actually we have some other methods that we're working on right now to improve methodology. But so what I showed was kind of the first foray into it, and we realized, wow, this is pretty good, but we can make it better. So we are actually doing a couple of things, including 3D graph implementation, as we've been doing for a long time. I did have a question for Dr. Lowenstein, but I'll let you. Oh, okay, great. So I know that was a great talk. And I think it's really exciting to see that this technology might be utilized for our patients. I was curious, we don't have this obviously available right now. So what we do as physicians, we ask our patients, at what point, what day, what week did you notice that your vision started to tail off a little bit? I was just wondering, were you guys able to ask questions to patients for symptoms, and did that correlate with the recurrence or worsening of fluid when you saw kind of the interval kind of getting towards the end where they needed another injection?
Yeah, Elliot, I think it's an excellent question, and of course, it's really important to see what is the modality that is better shows that gives the data for timely treatment. We all know that there is a disconnect between symptoms and even a formal visual acuity, even done in the office, and the anatomical results. So the accumulation of fluid, when it starts, it's usually before the patient experiences any symptoms. Of course, in order to really show it, we need a very longitudinal trial, and this is actually being carried out now by both pharma and the DRCR-net, and this will show us if really we these multiple long-term trials are going to show us if indeed the fluid is detecting early enough, and that finally the final visual acuity is better or the burden is lower. So in order to really show it, it would need a longitudinal trial, and it's only now being carried out because it's, as you know, it's a very, very expensive trial. So only now that pharma is going to use it, and there is one trial by Bayer, the EXPAND trial, and others by other pharmaceutical companies, and also the DRCR-net.
Yeah, that's great. So I was going to ask a question to Nadia and to you, Anat. I think that both of your studies involved some of the more non-traditional methods, or at least the newer methods of looking at these disease states, right? So what was the most surprising thing that you found? Obviously, we kind of expected the structural functional correlate discord there, but what were the other sort of surprising features of both of your studies that you found in your work? Let's start off with Nadia, maybe.
Yeah, so Rishi, really interesting. I think one of the things that was surprising to me, and this is, I guess, just an observation in terms of functional tests, is that they're very variable, and that sometimes the most robust, repeatable, reproducible things are more valuable than the more sensitive parameters. So, for example, in microbiology, and I never expected this, we just found that looking at scotomatous points, actually, which is a very black and white parameter, is probably one of the most robust things that you can look at in these junctional zones as well as elsewhere. I would have thought that you would see these little nuanced changes in sensitivity, but there's just so much variability around some of the other changes in sensitivity that it's hard to pick those out versus, just the very robust scotomatous points ends up winning out. So for me, that was, and I know we've seen that again and again across different functional endpoints, but for me, that was kind of just really an interesting observation.
And to me, I think there are a few things. First of all, I'm always surprised by the ability of our patients to actually use these technologies, because you would think they have low visual acuity. I have one patient who is 99 that did a test in my clinic, and a very high percentage of the patients can actually operate the technology by themselves. So this is one surprise. The other surprise is the variability between patients, because like the two patients that I showed at the end, when you see them in the clinic, they seem very similar to you because this one has fluid and the other one has fluid. So and it's so surprising to me that the response rate and the fluid appearance and reappearance are so different between patients. And I will take the opportunity and answer this question in the chat. Why do morphology and function, why do they don't correlate? Why don't they correlate? Well, this may be one answer, because some patient has a longer exposure to fluid. Another question that was in the chat, if you'll allow me to answer, was that if it will not impede our physicians, the way we manage our patients. So definitely, this is not intended to replace the physician. It is, and it's not something that you'll go and buy in the supermarket. It's something that will be prescribed by a physician. The physician needs to follow it up. He needs to be reimbursed for every patient that he has on the device, and so forth. So it's definitely not going to make us redundant. It's just going to help us in our work, and on the contrary, see more of the patients that we really need to treat.
That's great. Great comments. Elliot, you talk about MMP9, and I love the genetic utilization for once, because we have not seen that in neovascular AMD, and I guess that you've been able to now look at that a little bit more in detail. How close are we to start to go back and maybe even consider genetic testing in our AMD populations based upon some of your work?
Yeah, that's a great question, Rishi. I don't think we're there just yet. We don't even know what are the functional regions, what is the exact part of MMP9 in that locus or around that locus that is associated with neovascular AMD. So there's a lot more to really figure out, at least for determining why some patients have potentially worse disease with MMP9, but that's to be determined. We know that the big risk factors, genetic-wise, are CFH and ARMS2, And even when you look at those genotypes, you may see some signal with some pharmacogenomic analysis, whether they may respond more better to anti-VEGF therapy, but it hasn't really been borne out in most studies, and we certainly don't use it currently in day-to-day practice. So I think we are getting closer to being able to use genetics for AMD in kind of a more routine basis, but at this point we're not quite there yet. So a lot of important research to be done.
Yep, great comments. All right, and we have one last question about just the explainability of some of these algorithms. So how does somebody who maybe doesn't have a research background, what do we need to provide them so they can kind of understand what's happening? Is it as simple as refresher course or something else, or do we really need to teach them? And this has been a question all along, I think, is the black box nature of some of these algorithms and whether they can put them out. So what would you kind of say you all are educators, I know that, what do you kind of say as far as when we need to start to educate individuals about the underlying algorithm? Do we need to go as far deep as teaching them about the algorithm itself before rolling it out, or do people have a trust in what's happening?
I can start.
Yeah.
So I think it has been researched, this question, and obviously ophthalmologists are not willing to get a black box. They need to know something. They need to understand something about the mechanistics of the AI and understand how is it working. I don't think that we need to go, and I myself don't have the capabilities of going deep into it, but I think that most of us want to know on what it is based. So that was just to start the conversation.
Yeah, great. Yeah.
And I think that it's really, really important, perhaps not as much to have an understanding of necessarily the algorithms around AI, but for the specific implementations that you're using it for, specific questions that you're investigating, to understand what exactly the AI is looking at and how it's coming at the results that it's coming at, because you could fall into various different minefields if you don't do that. And there are numerous instances of that. I think there are ethical minefields that you can fall back into, but also, there'd be numerous funny instances of, the AI algorithm picking up that there's grass behind someone and therefore knowing that it's an animal as opposed to something that's lying indoors, right? So I think it's important to have an understanding of what the AI is looking at in your specific use case and implementation.
Mm-hmm. Great, awesome questions. Great. So thank you all for your presentations, and we're going to go on to the next session, if we might.
Thank you.
Wonderful. All right, and we're going to have Dr. Aaron Lee join us. Aaron, see you on screen in just a moment. He's going to talk about artificial intelligence-based prediction in neovascular AMD. So continuing our theme on this, Aaron, thank you for joining us today.
Yeah, good morning. So I'm going to be talking about using deep learning for AMD biomarkers, and these are my financial disclosures. So a number of years ago, we had published this paper in collaboration with the Carl Zeiss group, and it's a pretty interesting example of being able to use unlabeled data to do something more with your data sets. And so in this particular problem, we had one very large model, a ResNet 50 model that had a pretty reasonable accuracy. And then we had a whole bunch of small lightweight models that we wanted to be able to use. And in the data set, there was about a 10-fold increase in the number of unlabeled examples, OCT B scans in particular, that we had available for doing, for using for research. But of course, they're unlabeled, so there's not much normally that you can do with these. So we used a knowledge distillation approach, and here we took the teacher network, which is the ResNet 50 model that's that had been trained before and had reasonable performance, and we also took the unlabeled B scans, and we trained these lightweight models, the student models, in a sort of an online fashion where we passed through the unlabeled B scans through the teacher network and generated these pseudo labels, and then took the labeled images as well, and then backpropped and adjusted the lightweight models. And by doing this, we were able to show that in all the different families of lightweight models, if you took different percentages of the unlabeled data, so 0% is at the bottom, 25, 50, and so on, you can see that all the families of models sort of increase in their performance as more unlabeled data is used. And so, that was an example of how we were able to leverage unlabeled data for classification. We wanted to then, we were sort of in this, I'll describe sort of the problem area that we were sort of tackling next, and we thought we would try another unlabeled data approach. And so this was a paper that we had published with Phil Rosenthal's group on using vision transformers to do semantic segmentation in order to identify the double layer sign on OCT B-scan images. And that model was trained on the Plex-Elite, which is an SSOCT machine. And we wanted to see if there was some way that we could build a model that works with spectral domain OCT. And one of the problems, as you all know, is that models don't transfer very easily between devices. And so if you take the model that we had trained on the SSOCT and you apply directly to the spectral domain device, you'll find that the performance is not great. If you build a brand new model from scratch, just using the spectral domain data set, you actually perform better than if you just applied it directly. And then the final row is the approach that most people take, which is you start with the model that you had after the swept source, and then you fine tune it on the spectral domain, and you get the best performance. So this is the last row here is usually the approach that people take when they work at this problem. But we wanted to see if there was some way. Again, there's lots and lots of unlabeled spectral domain OCT B-scan images out there in the world. What we don't have is a lot of annotations for those. And so we wanted to see if there was some way, again, that we could take a semi-supervised approach. And so here, on the left, we have the swept source OCTs where we have labels, and on the right, we have the spectral domain OCTs where we don't have the labels. And so usually on the left, we call this supervised learning. And then on the right, if you don't have any labels associated with it and you just try to use those OCT images, you usually call that self-supervised or unsupervised learning. And if you combine these two, then it becomes sort of a semi-supervised learning. So this was a paper that was published in CVPR, which is one of the the best computer vision conferences. It used this approach that we found to be really interesting. So the way that works is that you take, you have the same model, but you initialize it in twice. So you have two different versions of the same model. And during training, whenever you have an image that comes in, you pass it through both of the models, and then when you have the label for it, you just apply it directly to that model. But when you don't have a label associated with it, you enforce that the two models actually behave the same. So you use the result from the first model to train the second model, and the second model to train the first model. So it enforces this behavior that the two models that were initialized differently should behave similarly. And so that becomes the sort of the trick in being able to use the unlabeled data. And so when we took in this semi-supervised approach, we showed an increase in the performance. We did also, these are sort of preliminary results. So one of the interesting things that we tried to do is we tried to look at what would happen if we use smaller and smaller portions of the data. So if you look at the 1/64th or 64th of the data set, there's only 82 B scans that we are using And then we have, 90,000 unlabeled data. And yet the model is still actually able to do, learn to do this task. On the spectral domain side, we have just a small amount of labeled images, and then we have a whole bunch of unlabeled images, and similarly, the model's able to generalize. A better way to look at this is as a graph, and so what's kind of amazing here is that we are using these approaches. You're able to train models that perform, reasonably well. In fact, better than sort of the supervised approach where you use the fine-tuning approach, even with very small amounts of labeled data, which is really exciting because it means that hopefully, this is a method that could be used in order to train models without needing, hundreds, if not thousands, of annotated B-scan images. So I just want to end by thanking Yuka Kihara, who's sort of in the center in the back here in this photo, who did most of this work, and then all my funding sources. So thank you.
Thank you, Aaron. So great presentation. We're going to talk about your presentation in the Q&A session. And in the meantime, we're going to go to our next talk, which is going to be by Amitha Donapalli. She's going to talk about prediction models for progression of geographic atrophy. Amitha?
Thank you. Thank you, Rishi. So we move on from neovascular AMD to GA now. And I have a little trouble progressing. I'm clicking on the mouse, on the keyboard. Okay, there we go. All right.
On the lower left portion of the screen, there's a navigator. You can use that as well. That's faster if that appears for you.
Okay. All right, so this is my most favorite plot from one of Janet Sonis's paper. It shows how the most well-known risk factor for GA, the baseline area, correlates with 2-year enlargement rate, and how it's all over the place. There are small areas of GA that really grow very fast, and there are large areas of GA that absolutely don't budge even after 2 years. And clinical trials are trying to hone in on this particular cohort, which has the perfect growth rate and the perfect baseline area. So how do we get to that target population for clinical trials? Well, clinicians cannot predict enlargement rate because the growth is slow. It's hard to predict looking at an image. So can we use AI to predict geographic atrophy growth? And so this is an image where, 1 year later, you can see there's considerable progression. And there are many ways to approach this problem with AI. The most simplest is to use classifier models, which do fast progressor, slow progressor kind of an approach. A second way is to look at quantitative models, which look at future area. So you show the visit 1 image, train the model on that, and say, okay, what's the future area going to be? And another way where you actually segment the image and say, okay, show me the future segmentation or the mask of GA. And more complex synthetic models where you actually recreate the autofluorescence image of the future. Now we are working on all these areas, but these two are further along. So I'm going to talk about those two. So the binary classifier, the slow and the fast, that's pretty simple, straightforward. You're just classifying based on growth rate. And these are arbitrary because they are not like established cutoffs for a slow and a fast progressor. So you can change this to whatever you want. We chose this based on the data set and general literature. And here are our results. So we use the ERIDS2 data set, 203 training pairs, so 1 year apart, and then about 43 for the testing data set. And you can see that in the slow model, which predicts all these slow progressors, which are essentially used to exclude patients from clinical trials so that you don't have slow progressors in the trial and you have that absolute beautiful cohort. And we have about 6 who would have been excluded in the trial by because of false labels. And so we need to bring that down. And this is mostly for enrichment so that your trial has more of fast progressors. It's not for exclusion, it's more for enrichment. And here we can see that the pickup rate is also pretty good. And here are our metrics, all good. I wouldn't say they're excellent. We are enthusiastic about this, but pretty good on the metrics. So moving on to the segmentation model, which I'm more excited about. But there, what we did is we took the images 1 year apart, aligned, registered, and got the area segmentations done. And so we take the baseline area, we take the year 1 area, overlay them, and generate these maps which show this is the area now, the green, the blue is the progression, and then the red is the non-GA. So the models are trained on these maps. So you do the training model only receives the baseline image and then has to predict, does not receive the year 1 image, but has to predict the map based on just the baseline image. And then of course we compare that to the ground truth, which is drawn by the graders, and the graders have access to all images. Okay, so these are our results, and you can see at visit 1, which is a baseline, the prediction is pretty good. So the model has to predict the current area also. So the prediction is pretty good. Dice coefficients are great. And at visit 2, which is the next visit, prediction of growth and the current area, again, pretty much on target. So very nice predictions. It's able to get both. And so this is an example. This is visit 1, visit 2. The ground truth, the grader has seen this image, drawn the green. The grader has seen this image, drawn the blue. And so the grader knows what these two are, whereas the AI model simply sees this particular image, the baseline, and gives us what the green should be, what is the area today, and what is the growth at next year, so blue. So we're able to see exactly what the predictions are using segmentation masks. So this is an image where the AI missed. So you can see this is the blue that the grader actually saw. There's the growth, but the AI did not predict that region. The AI said there's going to be growth here at the next visit, which there is, and the grader missed that. So there are mismatches on both sides, but it's a pretty impressive prediction, I would say. However, we need to be cautious while predicting these AI models because, you know, who knows, humans are hackable animals, as the saying goes. So maybe there's just the GA currently, and then all the AI model is doing is throwing in an extra square millimeter and shining at the rim of the GA and says, here you go, and we believe that it is prediction. So we need to be cautious in interpreting these. But they are extremely useful for pre-screening enrollment, excluding slow progressors, enriching fast progressors, and they could potentially be very good for assessing the change in the trajectory to natural history. We do need to go beyond just imaging and incorporate much more. Thank you. And here are the super intelligent humans who have helped do the study.
Great, nice presentation. Thank you very much. So we're going to be taking additional questions. Please feel free to put them in the chat. We're getting some really great questions from the audience members. And we're going to have this continuation of the discussion around geographic atrophy by having the next talk given by Daniel Ferrara. Daniela is from Genentech. She's going to talk about prediction of GA growth with clinical and derived imaging features. Daniela?
Thank you, Rishi. It's a pleasure to be here as always. And I will present today one of 2 advances in our line of research using AI in geographic atrophy. I will start commenting on the clinical and derived imaging features that contribute to our progression prediction. And my colleague Neha Anegondi will follow with additional line of research. These are the disclosures from myself and my team members. So the purpose of this project is to evaluate the contribution of baseline clinical and derived fundus autofluorescence image features when we predict the geographic atrophy growth rate. The GA progression prediction model have many uses in clinical trials, and therefore this is an area of extreme interest to our research group, but also to the field at large, as Amita just commented. And we've been using those models in different settings in the clinical trials, including covariate adjustment, as a strategy that's highly encouraged by the FDA. In the future, we also believe those models may be useful for patient counseling and treatment decisions, also in clinical practice. And as Amita and other speakers will discuss throughout the day, the end-to-end deep learning models using especially fundus autofluorescence images have outperformed feature-based models, including those with the running data that we know is a strong predictor. Nonetheless, the imaging features that drive the success of those deep learning models remain unknown. And as a retinal specialist and a clinical scientist, I still struggle to overcome the black box dilemma. So we believe strongly that scientific efforts to bring some explainability to those deep models can improve adoption of those tools. And more importantly, that understanding may also lead to new insights related to the pathological mechanisms of geographic atrophy progression and progress the science in the field at large. So this line of research started utilizing baseline clinical data as well as fundus autofluorescence images of 1,241 patients enrolled in the lampalizumab clinical development program. In that program, the GA lesion growth rate was the primary endpoint across the studies. All lesions that I'm going to present today were segmented using a previously described AI-based algorithm that our team published previously. A nested CV approach was used to tune the model hyperparameters using the inner CV folds for each of the 5 outer folds. And patients were stratified and evenly split across those. 5 modeling strategies that I'm going to present next were used, and the mean R-squared coefficient of determination and the R-squared square-Pierce correlation coefficient were compared across the models. The feature importance was determined for linear models as well as for an XGB model. So as I just described, for the generation of the feature-based parameters, we started with the raw fundus autofluorescence. We applied an AI-based tool to generate the segmentation maps, and then we extracted the shape features that I'm going to comment next. We used GA area, GA perimeter, the number of lesions, as well as ferret max, mean, and the GA circularity. For the clinical features, they're all categories, and we used the demographics that we know are relevant, age and sex, as well as smoking status. We used visual function, including BCVA and low luminance deficit. And as clinical features, we also used imaging assessments extrapolated and graded by human experts, including the presence of reticular pseudodrusen, baseline GA area and lesion contiguity, and GA distance to the foveal center. The SAPE features were extracted as I just described in the previous slide. Once we assessed each one of those feature types independently, we moved towards a combined exercise utilizing both clinical and shape features as a complete data set. When we compare the performance across all 5 models that I described, we can see the performance was relatively homogeneous across all of those. One can argue that LM with no regularization was the highest performing model, followed by XP. But more importantly, across all modeling strategies that I just described, the clinical plus the SAPE feature data set performed the best. Going through similar exercises and taking into consideration the performance metrics, we can also see that the LASSO model performed best, and again, consistently using clinical plus the SAPE data sets for feature extraction. When we wondered which one of those individual features played the strongest role in the geographic atrophy progression prediction, we assessed each one of those independently. Before I go over our results, it's important to note that the general caveat for interpretation of the importance of each one of those variables, it's only relevant within the context of the built models. Therefore, those may or may not be extrapolated to other exercises. What we noticed is that with the linear models, ferret mean, GA perimeter, and low luminance deficit seem to be the features that contributed the most to the prediction of geographic atrophy growth rate over time. When we went through the same exercise for the XB model, again, GA perimeter and low luminance deficit also again seem to be the most predicting features throughout, closely followed by the GA distance to the foveal centered, as well as ferret mean. So in conclusion, when we utilize clinical-based features, combined demographic features plus clinical image features assessed by human graders, as well as shape features extracted using an AI-based segmentation model, the combined data set achieved a greater performance at either set alone. The linear models performed well and were not outperformed by XP. When we went through each feature independently, in those exercises, we observed that GA perimeter, low luminance deficit, GA distance to fovea, and ferret mean were consistently in the top 5 most important features. Again, we remain very excited about the performance and the potential for deep learning models, but we will continue our efforts in bringing explainability to those AI-based tools. Thank you very much. And it was a pleasure to present on behalf of the clinical experts in my group. Back to you, Rishi.
Thank you. Thank you very much, Daniela. And please stay on for questions at the end. We're going to have a Q&A with our group. In the next presentation, I'm going to turn over to Neha Enagandi. She's from Genentech, and she'll be presenting on deep learning to predict future region of growth of GA from fundus autofluorescence images.
Thank you, Dr. Singh. Hi, everyone. I'm Neha Enagandi, and I'm very excited to be here and present our work on deep learning to predict the future region of growth of GA from fundus autofluorescence images. So it's a nice follow-up to the very interesting talk that Amita gave just a few minutes back. So these are my disclosures. So the key clinical question that we are asking here, excuse me, can a deep learning model be used to predict the future region of growth of GA lesions using FAF images? So we all are aware here about GA. GA is an advanced form of age-related macular degeneration. GA progression is relatively slow and varies between patients. So we previously developed deep learning models using baseline FAF images that can predict the GA lesion growth rate in millimeters squared per year. Here, we take it a step further and we develop deep learning models to predict the future region of growth, or ROG, of GA lesions using baseline FAF images. Now, these models are currently preliminary, but once we make sufficient progress, can be used in clinical trials for enrichment, stratification, covariate adjustment, as well as in clinical practice. Coming to the methods, so we performed retrospective analysis of FAF images of steady eyes of patients enrolled in LAMPA trials. Now, the GA lesions were manually annotated on FAF images by a grader and used for model development. The FAF images and the corresponding annotation masks at screening T1, 6 months, T2, 1 year, or T3, and 1.5 years, or T4, were registered using Region Finder software. The imaging data was split at the patient level into training, validation, and holdout, and it was stratified by focality, lesion location, initial GA area, and GA growth rate. We developed 3 different deep learning models based on convolution neural network architecture UNet to predict the GA whole lesion mask at T4 or 1.5 years. Once we had the GA whole lesion mask predicted at T4, we were able to derive the 1-year region of growth mask by taking the difference between the T4 or 1.5 years lesion mask predicted by the deep learning model and the 6 months annotation mask by the grader. The ROG areas were computed in millimeters squared. Now, the performance of the model was evaluated using dice score and squared Pearson correlation coefficient, or R squared, between the true and predicted GA lesion region of growth. So these are the 3 models that we developed to predict the future GA lesion mask. For the first model, we used the T2 FAF, which is the FAF at 6 months, and we predicted the T4 lesion, which is the lesion mask at 1.5 years. For the model 2, we used a combination of both baseline and 6-month FAF images to predict the lesion mask at 1.5 years, or T4. For the model 3, we used just the 6-month FAF images to predict the T3 and T4, that is the GA lesions at 1 year and 1.5 year. Now, coming to the model performance of all the 3 models, the model 2 had the best performance in terms of dice as well as in terms of R squared across the training, validation, as well as the holdout set. And this is not surprising given the model 2 gets information from 2 time points, that is baseline and 6 months, as compared to models 1 and 3, which get only the 6-month FAF images as input. So coming to the ground truth and predicted region of growth overlays for the 3 models. So we were really interested in looking at the outlier case in the validation set to understand what was happening there. And that's the example we are showing here. So from left to right, we have the FAF image at 6 months, at 1.5 years. And then we have the ground truth at 1 year. That is the difference between 1.5 years and 6 months as by the grader. And you see there's this small lesion in the side which just grows in that 1 year, which is nicely annotated by the grader. And then when you look at the predicted mask, the deep learning model struggles to predict that additional part as compared to the grader. Based on our observation, the deep learning models tend to do better in unifocal lesions as compared to multifocal lesions, which is not surprising. Now coming to the example for model 2. So the model 2, which is the best model, at least picks up that there is something happening there. And if you look at the green, the last image, it does show a small growth there, still not as much as the actual growth, but it is still interesting to see that it was able to pick up the growth there, which model 1 was not able to pick up. Coming to model 3 again, so the performance of model 3 was quite similar to model 1, and even this was not able to pick up the additional lesion in the side, which grew in that 1 year. So coming to the conclusions, so these findings, even though very preliminary, still demonstrate the potential for automated analysis using screening and month 6 FAF images to predict the future GA lesion region of growth using CNN approaches. We do need to perform further evaluation on independent test sets to confirm the promising performance. This work is one step ahead of our previous work where we just predicted the GA growth rate as a number. Now, by predicting the actual region of growth, this work can inspire more trust in the adoption of DL models and help support informed decision-making, both in clinical trials and clinical practice. It could also be of interest to see where the GA lesion is growing, as the location of GA lesions has an impact on the visual function. With this, I would like to conclude my talk and thank all the scientists we work closely with who have helped put together this brilliant work. Yeah, thanks everyone. Back to you, Dr. Singh.
Thank you. Thank you very much for your presentation. So we're gonna keep, please put questions in the chat. There's some really great ones coming in, and we're gonna get to them after the next presentation. And the next presentation is gonna be by Dr. Zhixiao Wu. She's gonna, the doctor's gonna speak on instance segmentation of reticular pseudodrusen in AMD with deep learning. Thank you, Dr. Wu.
Thanks very much, Rishi, and thanks for inviting me to this talk. And I'm going to change tracks a little bit from our geographic atrophy talks to slightly earlier in the disease process and look at a specific phenotype called reticular pseudodrusen. I have no financial disclosures. So reticular pseudodrusen, or RPD, is a distinctive phenotype in AMD that is often missed on a clinical examination or color fundus photographs. These deposits are localized to the subretinal space or are above the RPE, which is really in contrast to conventional drusen, which are located below the RPE. Now, numerous studies have reported that RPD are a risk factor for developing late AMD, and that individuals with RPD experience these profound impairments and dark adaptation. And RPD also appeared to be a significant treatment effect modifier in a recent trial of a subthreshold nanosecond laser by us, where we saw that people with RPD seem to respond poorly to treatment, whilst a beneficial effect was seen in those without RPD. So this really shows us how critical it is that we gain a better understanding of the disease mechanisms driving the development of this phenotype and vision loss in AMD. And this could be greatly facilitated by having an automated method for detecting and ideally quantifying RPD. And if we have a look back at the other studies that have kind of delved into this, this one previous study led by the NIH investigators developed a deep learning classification model to detect RPD on color fundus photographs and fundus autofluorescence images. And they reported that the model outperforms ophthalmologists at detecting RPD on both of these imaging modalities. The team at Doheny have also similarly developed a deep learning classification model for detecting RPD on OCTB scans. They also subsequently, in another paper, developed a deep learning model to segment RPD as well. But this model was only developed in 36 eyes with or without AMD and tested in 9 eyes with AMD. And most recently, one of the studies led by the Moorfields group developed a deep learning model to segment RPD from an older Topcon OCT device that was used as part of the landmark UK biobank study. But this model was unfortunately only performed as well as 1 out of 2 human graders. So what we really tried to do in this study is to extend the work conducted today by developing a deep learning segmentation model for RPD on high resolution OCT scans that are typically obtained in clinical practice and which we hope could perform as well as human experts. And to do this, we had a data set where we trained our model that came from 200 eyes of 100 individuals with bilateral large drusen. And these people underwent OCT imaging with the Heidelberg Spectralis. And our long-suffering and superb PhD candidate, Dr. Himesh Kumar, manually reviewed and annotated about 10,000 OCTB scans for RPD after being trained by Professor Robin Geimer and myself. This data set was then split into 5 folds to train an ensemble of 5 deep learning models. These models had a masked RCNN head with a ResNext as the backbone architecture that was pre-trained on ImageNet for training an instance segmentation model. And this is a model that delineates individual objects within the same class, such as different RPD lesions on an OCT scans. And we used this instance segmentation model because previous studies have shown that this approach can provide improvements even for a semantic segmentation task. So we then tested this ensemble segmentation model in a data set that consisted of 140 eyes from 97 people who also had bilateral large drusen, and half of these people had RPD. Now, 2 B scans from each eye were randomly selected for assessment. And from these 280 B scans, 4 retina specialists, Robin Geimer, Aaron Lee, the first speaker of the session, Amy Kahn, and Marley Okada, all of them manually annotated each of these 280 B scans for RPD. We then looked at the pairwise spatial overlap of RPD annotations between each of the 4 graders, where obviously 1 equals perfect overlap, 0 no overlap. And the pairwise dice coefficient between the 4 graders had an average of 0.69, whilst compared to the average agreement between the deep learning segmentation models output with each of these 4 graders, which was at 0.77. So these findings suggest that the model's RPD segmentation was not only similar to interreader variability, but likely represented the middle ground of all 4 graders. So let me just show you one exemplary B scan with annotations from the 4 graders in different colors. Here, the first grader, you can see marked these 6 lesions. The second one marked these 10 lesions. The third one, these 2 lesions over here. And the fourth one marked these 7 lesions. So some degree of interreader variability. And you can see here the deep learning model marked these 6 lesions, which is roughly about the middle ground of all 4 graders. So I'll just run through that again. Here's grader 1, grader 2, 3, 4, and then our deep learning model sitting somewhere in the middle. So given these promising findings, we are now externally validating it in several cohorts globally and comparing the performance against retina specialists for detecting RPD at the OCT volume scan or eye level. And if this is successful, this model could then be used to provide an objective and consistent means for detecting and quantifying RPD. And this really could be really valuable for helping us further understand this critical phenotype in AMD through being used in things like clinical or even genome-wide association studies. And so I just want to finish by acknowledging everyone involved in this project, including our team here led by Professor Robin Geimer, very importantly, Aaron Lee and Yelena from the University of Washington, who led the deep learning model development, the Ophthalmic Neuroscience Unit at CIRA for the annotation software, along with our collaborators Adnan and Roy Moorfields, and Emily Chu from the NEI and our funders. Thanks very much for listening. Back to you, Rishi.
Great, thank you, Dr. Wu. That's great presentation. And so I'm going to have all of our panelists join us for our Q&A. We're a little off time, but we have enough time for a good Q&A session now. And I thought that this question that was posed in the chat is relevant to a lot of you, and I'd love to hear your comments on it, which is that, you know, in the era of showing higher rates of progression or prediction, and you pair this with a therapeutic, what do you think the implications are going to be from a regulatory body? And I know, Dr. Wu, you're in Australia, as I understand, and others are in US, and that would be interesting to hear kind of your perspectives on the differences that may occur. Are we going to see a paired therapy plus an algorithm, or do you feel like these are just totally going to be separated still in the near coming future? I'd love to hear your thoughts on it. How about Daniela? We'll start off with you.
Sure. No, Richie, great question, and definitely top of mind for all of us involved in clinical trials. And I don't think the answer is specific for any AI-based tools. The decision to include or not strategy in a clinical trial design that will become a companion diagnostic is top of mind in clinical trials always. So it's truly a fine balance between the population that's included in a given clinical trial, the biology of the disease, the mechanisms of action of the drug, and how to select that population. And the intent is to design a trial that's restringes the population in a way that we can interpret the data, but on the other hand, allow us to treat the maximum amount of patients that are counting on a new therapy. So again, I think what's going to happen is it depends how it's going to be used in a clinical trial. Our assumption is that if it's used as covariate adjustment or data analysis, it will not become a companion diagnostic, but it's a question mark whether used earlier in the trial design, patient selection, inclusion exclusion criteria, disease treatment decisions could become a companion diagnostic, but great question.
Yeah, and if I can add to that, I think there's two uses of AI in these GA trials. One is the simpler just area prediction, which currently we use Region Finder for, and it's restricted to Heidelberg only. So having an AI model that can just do area itself is going to be a big step. And that is just very similar to the Region Finder, where somebody's supervising and looking at it and confirming that it's right. So that, I think, is a straightforward leap that we can take. We hope we can take in the near future. But the prediction is a whole different game, because that is delivering the unknown, and we need lots more prospective data sets and bigger data sets to be sure that this is not just some sort of, voodoo ball game kind of thing.
Right, right. And I think to your point, the next question, which I think is very relevant, which is also in the chat earlier, what are the needs of researchers like you doing this work? Is it open source data sets? You presented on various data sets today, and I'd love to hear kind of your thoughts on what the biggest need is from a grassroots researcher perspective on making the next greatest algorithm for this sort of work.
I can jump on that, but would love to hear everybody's thoughts too. It's right now, most AI models, I mean, the ones that Genentech has presented and others have done, are clinical trial data sets, which are very specific. They are 2.5 to 17.5 square millimeters, do not have this, do not have that, extrafoveal, subfoveal, all kinds of specific criteria. And they're all Heidelberg and have to be taken with a specific art mean and all that. What we need is the real world GAs. When I think in the ARIDS-2 study, when autofluorescence was included, about half the sites had Heidelberg, only half the sites could participate in the study. And then when we said, go beyond Heidelberg, take any autofluorescence machine you have, take an image, about 90% of the sites could participate. So just expanding beyond Heidelberg, going to, there's Optos autofluorescence, there's any fundus camera autofluorescence. So we need the whole gamut.
Mm-hmm. I agree entirely. Expanding on the technology, the device, but also expanding on the disease stage, as you mentioned, Amita, so a full spectrum of presentation, and then expanding on demographics. Exactly like you said, we know there are many ethnicities that are not fully represented in drug development clinical trials in general. So ideally, we cannot let that happen with AI-based tools. Make sure there's proper representation for the disease demographics, also in those AI-based tools.
Yeah, and even to add to that, the quality of the images in real-world data sets, they certainly aren't as pristine as the clinical trials one. So to have the real-world challenges and the need for robust AI models that can tackle those challenging images would be critical. So start imaging now, and if there's access to electronic health records data and imaging data that could be leveraged to train these AI models, will certainly facilitate the eventual implementation.
Yeah, that's great. And the one question in the chat was funny. You mentioned, Dr. Wu, that Hamesh did a lot of this work. So was it a single grader that did the RPD work? And does that lead to some opportunity there with regards to its predictability ultimately?
Oh, absolutely. Well, we would love for multiple different people to annotate, but convincing other people to annotate 10,000 B scans hasn't been the easiest task. But what we have sought to try and make sure we do is test the validity of this model against other retinal specialists around worldwide. So in that presentation, I show how this deep learning model, which kind of somewhat represents Himesh's mind that was trained by Robin and myself, still agree incredibly well, and in fact represented the middle ground of even other retina specialists elsewhere. So what we really want to see a reassurance of now is testing it in other landmark data sets around the world with other graders elsewhere in the world. And if we can see its generalizability, even if it does represent Himesh's mind trained with our advice, that still would work well, I think.
Yeah, I have a quick question for Dr. Wu, if I can. So the presence of RPD, pseudodrusen, is a known risk factor for progression of AMD, various things. quantification of pseudodrusen is not as established. There isn't enough data that volume or area or whatever makes a difference. What is the purpose of an AI model in this extensive segmentation then?
If we really want to be able to quantify, like you say, there's currently nothing available. What we don't know is if the presence or extent or even the volume, like you said, matters for disease progression, and that's what really motivated and compelled us to do that. And as you might know, the definition of RPD really has varied across different studies. Some people say, like the Alabama group, will require just 1 lesion, others might require 10. And most people require 5 or more. So how much is right? And without being able to quantify and be able to implement this in various clinical studies, and our genetics colleagues are really interested in having a continuous measure in their GWAS to really understand whether that matters as well. So that's really what motivated us to develop a quantitative model.
But Dr. Domopali, that's a great question, because essentially you're discussing what's the clinical utility of all those tools. And I don't think we're going to know beforehand. We need to have the tools available, use them, and then establish the clinical utility. And I love your earlier comment. I think the first wave of benefit for AI-based tools will be what you described, will be automation, reliability, trustworthiness, efficiency. We're going to collect a lot of data. The second step is going to be the future prediction. That's going to be truly transformative, but that's going to be a difficult one to act on and to interpret ahead of time.
Yeah, well, great presentations. Thank you all for the discussion. And we're going to continue the rest of this program with some words from our sponsors. So first, we're going to have a video by Genentech, and next a video by Iveric. Again, thank you for our presenters and also our sponsors for making this program possible.
Waar, Bijs, Mau. We Bijsmau. Sight. It awakens us to the present moment, guides us through essential daily tasks, shows us the road immediately ahead, and a future we can only hope to witness. Sight gives us hope, but retinal diseases can take our sight away, along with the hope that goes with it. At Iveric Bio, we see a world where vision is preserved. Our mission is to deliver transformational therapies for people with retinal diseases so they can live with hope in sight. Hope to keep driving. Hope to stay working. Hope to look into a loved one's eyes and continue to simply say, I see. Iveric Bio. Hope in sight.
Hello, welcome back. We're in session 3 now. Some really exciting talks this morning so far. I'd like to introduce our next speaker, who will be Pierce Keane from Moorfields Eye Hospital, speaking about foundational models in retinal imaging. Pierce.
Thank you, Ted, for the introduction. So let me just start my presentation. Okay, so I'm going to be talking about foundation models in ophthalmology, and particularly with regard to retinal imaging. If anyone would like to get in touch with me, I've got my Twitter handle in the bottom right of the slides there. And also on my last slide, I'll give my email address. So as anyone who has been watching the news recently has seen, there's been some really exciting progress in artificial intelligence in the last year. And it's it's both exciting and also potentially scary that the progress is accelerating so rapidly. And so in July of 2022, The Economist had a full issue dedicated to artificial intelligence's new frontier. And in that article, in that magazine, they talked about something called foundation models. And say huge foundation models are turbocharging progress in artificial intelligence. And then as a subheading, they say, these models can have abilities their creators did not foresee. And that's something I'm going to mention a little bit later in my presentation. So foundation models is a term that was coined by a large group led out of Stanford in 2021. And essentially it's a new term for concepts that have been around for decades. It's the idea that we can create large models, typically trained on huge amounts of diverse and multimodal unlabeled data. And then those foundation models can be fine-tuned for a diverse range of downstream clinical tasks or general tasks, often with only small amounts or no amount of actual labeled data. Now, this has gotten most prominence in recent years with something called LLMs, or large language models. And probably everybody who's listening today is very familiar with ChatGPT and the stunning effects that this has had, and hundreds of millions of users this has had only in a short number of months. We also see foundation models being used in the context of generative artificial intelligence. And there's a number of examples of this. One of the most prominent is also from OpenAI called DALL-E 2. We have other models such as Stable Diffusion, Midjourney, and a number of others. And I can't resist showing some examples of generative AI. Again, I'm sure many of you are familiar with this, but the fact that you can put a text prompt into an API and, for example, avocados dancing, drinking, singing, and partying at a Hawaiian luau, and you get these amazing images and unique images, and you can generate hundreds or thousands of variations on these. I'll show you one more example, an Italian town made of pasta, tomatoes, basil, and parmesan. And in this case, DALL-E was able to generate this image. So in fact, there's now more than 20 million images being generated every day using these foundation models. And they've already begun to reshape many of the creative industries. Now, one of the key aspects about foundation models is that they're typically trained on large amounts of data in an unsupervised way, sometimes referred to as self-supervised learning. And a very nice review article in Nature Biomedical Engineering, which explains the concepts. And so for those who are not familiar, I highly recommend taking a look at this from Eric Topol and others. One of the other big changes with foundation models is that they often use different architectures. And so typically, most of the deep learning that we've talked about in the last decade or so, and particularly for computer vision tasks, has been something called convolutional neural networks. But in fact, most of the work in foundation models has been using a more general type of architecture called transformers. And in the context of computer vision and medical imaging, it's referred to as vision transformers. And the exciting thing about transformers is that they're potentially much more scalable and much more general than convolutional neural networks. Now, an example of that is that we have vision transformers, which have recently been scaled to 22 billion parameters. And then, of course, outside of computer vision, in the context of large language models, we have models that have 500 billion parameters. In fact, there's a recent Chinese model with over 1 trillion parameters. And the reason why people are getting very excited and possibly even a little bit scared is because these models often display what is termed emergent capabilities or emergent abilities. And these are essentially sometimes unexpected abilities that are only seen when the models reach a certain size and are trained on a certain amount of data. So I just want to briefly introduce a foundation model that I've been involved in creating for retinal imaging. We call this RetFound for Retinal Foundation. And this is currently under review, so I'm not going to go into a lot of detail, but essentially We trained a foundation model for retinal imaging on just under 2 million images. Those are multimodal images, so both color fundus photographs and OCTs. We do that with self-supervised learning. And then the exciting thing is that we can fine-tune that for a range of diverse clinical tasks. So in our paper, we showed that this can be used with small amounts of labels for diabetic retinopathy, for glaucoma, for predicting progression of AMD, but also for predicting systemic disease like Parkinson's and heart failure and lots of other cool stuff. And this is work that was led by a PhD student in my group called Yukun Zhou. Now, the type of self-supervised learning that we do in this is called a masked autoencoder. And this is something state-of-the-art self-supervised learning described by the Facebook AI research team in 2021. And essentially what you do is you take the image input, for example, a retinal photograph on the left, you cover about 80% of the image, and then the model has to learn how to reconstruct the image. And so here's an example from our paper using color fundus photographs. And I'll show you another example using OCTs. And it's really kind of amazing to see how you can cover so much of an OCT and the model can predict what the appearance is actually like. We use a vision transformer architecture with about 300 million parameters for this work. And so just to begin to finish up then, what are the next steps? Well, we hope to publish the paper soon if the reviewers can get back to us. Once we publish it, we're hoping to make this model open source. And so we hope that this can be a foundation for many others to improve their own artificial intelligence systems. And we've trained this on just under 2 million images. And so we want to, as a next step, we have over more than 20 million images at Moorfields. And so we want to scale it up considerably. We want to increase the multimodality of the model. And then we want to see how it can be combined with federated learning to greatly increase the size of the data that it can be trained on. So what's really exciting to me is to think about when we massively scale up the number of parameters in these models and massively scale up the amount of data that it's trained on, what will be the emergent capabilities that we begin to see. And so just to finish then, as promised, that's my email address. Please feel free to get in touch. Thank you very much.
Well, it was an amazing talk here. So I definitely have a lot of questions for you, but if any of our audience members do, please use the Q&A function below to populate that, and we will address that in our panel, which will be coming up soon. Our next speaker is Dr. Edward Carote, who is affiliated with Stanford University and is currently based in Michigan. Eddie.
Thank you, Ted. Really appreciate the opportunity to be here. Let me start my video. Says the host has stopped it. Would you guys mind starting? Oh, here we go. Perfect. Thanks for the opportunity to be here again. It's an honor to go after one of my main mentors, Piers Keen. I'll be presenting on robust real-world clinical AI validation, a call to action, and a proposed solution. Let's advance the slide. So it's a little bit of a departure from other talks where I do not have any actual data. We're more talking about a framework to hear and stimulate some good discussion going forward. The most relevant of my disclosures is I'm the co-founder and chief medical officer of Sanro Health, which is developing and implementing some of these frameworks themselves. So today, how do we validate AI? How, why, and when? So currently we have 7 regulatory approved AI models that are being implemented. 6 out of 7 for those in ophthalmology or for diabetic retinopathy screening. 3 of which are autonomous, digital diagnostics, iNuke, and AI. And there's definitely been some challenges with generalizability in deployment of these models. So the current standard is validation on very structured and clean data sets in pivotal trials. So that's the evaluation portion. And also training on pretty clean data sets in labs. And so that entails obvious selection bias of patients for trials. The quality of the photographers in those trials are generally better than other photographers in the real world, as well as lighting conditions and other things. So I like to call this, quote, static and clean training and validation. The current issues with static and clean validation include a lack of guidance for certain performance thresholds in trials. So we obviously have some guidance based on prior approvals of greater than 80% or so for sensitivity and specificity, but there's no guidance on specifics here, no guidance on context-specific recalibration. So when you use the same model from screening to referral centers, for example, and we have to consider the complexity of the different disease states that we see in the real world. And we also have to consider our inability to fully pre-specify data drift a priori when we actually design these models. Some of these drift factors are patient-specific and some of these are image-specific. So patient-specific drift factors include new diseases that we can't specify when we develop these models and can't predict, such as Almiron toxicity, and new presentations of established diseases. And then imaging-specific drifts include software updates. So for example, when Heidelberg went from high X1 to high X2, there was a subtle pixel intensity shift, which no one knew about, but definitely affected some of the performance of AI models my group was working on. And then there's the varying acquisition environments that are seen in the real world. So Aaron Lee, who presented earlier, did some very interesting work on showing approved algorithms performing more poorly in the real world as compared to their pivotal trial and published performance data. Specifically, he evaluated sensitivities at different disease thresholds, and several models performed statistically significantly worse for both moderate DR, severe DR, and most crucially in PDR. So why the need for validation? Again, I just want to reiterate that the performance metrics that are shown for these models when evaluated in a clean lab setting frequently decrease when evaluated in the real world. So here's a paper from Google in 2016 where the original model was developed, and then a 2019 follow-up that showed some real-world validation. And crucially, the operating thresholds were different for different diseases. So from 0.3 to 0.2, going from referable DR to DME. And then the performance evaluation had different gold standards, which it was compared against. So all these things have to be more standardized. And I'll present a proposed way that we can think about this going forward. So if we look at the FDA guidance, in 2019, they published this paper on SAMD and specifically AI. But crucially, this was more of an adaptation of current drug paradigms for AI and not specifically designed for the adaptive environment of artificial intelligence. It did call for some post-deployment validation, but nothing too specific. And then in 2021, they published an action plan that highlighted some select goals, which actually did include providing additional clarity on what real-world validation would look like, and to evaluate the performance to increase robustness and resilience of these algorithms for real-world inputs. So the solution, I like to think of this as anti-static and clean. I argue that validation should be performed on real-world data sets representative of where algorithms will actually be deployed in the real world, so that we can evaluate their performance on different variables such as race and image quality, dilation practices, etc. And this validation should be performed at multiple sites to show the full disease states that are encountered in the real world. So these should be performed and evaluated against varied clinical settings, varied concurrent diseases, and varied purposes. So screening versus referral. So if we think about this structured validation, and we call it validation as a service or VAS, I believe it should be performed by a third party, which is less biased, and they can actually perform the actual validation and the monitoring. And this can include pre-deployment validation on real-world data, which can be distributed and federated, as well as post-deployment, which would enable live quality control. And so one way that this can be done is through a federated evaluation approach, where the model stays at a central site and the devices or the local clinics get the model in a distributed approach and run it on the local data there. So VAS, again, validation as a service, can be thought about as a network of clinics to deploy these models and receive the performance data back. And crucially, this is validation only, so no training. The data stays at the clinic. The outputs are what leave. Privacy is preserved bidirectionally, and there's an option for continued feedback with the models running in the background during the clinic on real data. Thank you very much. I hope this stimulates some interesting discussions going forward.
Thank you so much, Eddie, for these ideas and the call to action. This segues really nicely into our next speaker's talk, who will be Minaj Alam from the University of North Carolina, and we'll be speaking on federated learning. Minaj.
Thanks, Ted. Really appreciate it, and really excited to present some of our work on federated learning. I totally agree with Eddie, and hopefully some of my some of our work will be kind of deployed in real life. So thanks everyone. My name is Minhaj, and today's talk is about federated learning framework for training retinal classification models. In this talk, I'll be specifically talking about some of our OCT applications for multi-class classification. All right. So, just a little bit of background. What is federated learning? So it's basically a machine learning framework that enables multiple parties to collaboratively train a machine learning model without sharing their data with each other. So I think in medical domain, and not specifically in ophthalmology, but any medical domain, this is the main problem on training and deploying AI models, is that we need more and more data. However, the data is based in different institutions. Not one institution have a huge distribution of populations, right? So, so federated learning allows this kind of large-scale, multi-institutional machine learning studies where the data can stay in their corresponding centers, and we can still train them collaboratively. So one example here is basically you have two clients here, and there's a server that's regulating this training, basically. So why federated learning is important? Many different reasons. Compliance, data privacy, because federated learning can protect patient privacy because the data is not leaving the center. Improved diagnosis, because different centers might have different patient population demographics, so different distribution of data, and that only helps your model improve in performance. Reduced costs, improved healthcare delivery, collaborative learning, that all add on to the performance of the model. And the main thing that we want to talk about is the generalizability and deployment of AI models, which is a current challenge in AI research. So that I believe federated learning will massively help in that. So how does this work? So basically, the server initially sends model training parameters and configuration to each device. So here only we show two clients, but there can be multiple clients. And then the clients will have local models, and they will train those local models on their local data. And so this can be optimized, but after the training of the local data, the training weights are shared centrally. And then the server, there are different ways of doing that, but the server will accumulate those weights. The server aggregates those weights and then updates the local models. And there are different theoretical research going on how to best aggregate these parameters. A very common one is federated averaging, but there are different ways of doing that. That's actually an active area of research. So one of our initial work, we just showed this in Arvo in a poster. Basically, we want to just create a framework to kind of look at the logistics of federated learning. So we just take one already available data set from Kaggle. We split that data into two different nodes, kind of simulating the environment that they're housed in two different centers. And then we trained different local nodes on a ResNet architecture and had a global framework that updated the parameters. And we saw that even both of the local models had only access to half the data set. When trained with a federated learning framework, they were still able to, the federated learning model was still able to perform similar to a centralized model. So in this case, the centralized model is basically a model that has access to all the data set, right? So in this case, our main finding was that even when the data are split between different centers and each local model has access to only a portion of the whole data set, it can still perform as good as the central model, which has access to all the data set. So we want to push this forward. This is what we are at currently. We are kind of still, this is ongoing work. So I'm just gonna present some preliminary studies. We deployed this in normal versus AMD classification. And we used 3 available data sets. First one was the Kaggle data sets. And then we had online data set from Duke and OCT 500 data set. So Kaggle is about like 22,000, Duke is 3,000 something. OCT 500 is like about 18,000 or so. And we saw that in the framework, the federated learning model was able to perform very similarly to the centralized model. So although, for example, the distribution is different, the distribution is different, and then there are institutions or there are nodes which has only access to a very small amount of data, like compared to the Kaggle and OCT 500. The Duke only has a portion of the data, but still, when deployed, the federated learning model was still able to perform really well on each individual data set. So that's promising. That's very good for initial study, but I think there are some major challenges in federated learning that, so not only on the data side, but also on the technology itself, because it's still in the very early stage. So we have to tackle some issues. For example, these are the 4 main things that I think we should tackle: unbalanced data and learning contribution. So we need to optimize how the framework, how the training handles data distribution coming from different institutions, and where the different institutions have different amount of data, and how it handles the distribution of weights, which data should have more weight, so that the federated learning model needs to optimize. So differential policy is one of the solutions that we might think about. This policy ensures that output of an algorithm does not reveal information about any individual data point. And this is also a concern that what if during the training, the parameters can be back engineered and the data can be revealed, because especially in ophthalmology, retina data is human information. So that's not Good. So also the domain shift problem, one good thing and one bad thing, right? So in federated learning, we're accessing data from different distribution, but then that also creates a problem that maybe the model will not converge because each center has different domain distribution. So how to align that into the training space, and also adversarial attacks if there's like a hacking going on that can that the data is leaked. So that's always a problem. So these are some of the problems that if you're interested in federated learning research, we should also my conclusion is that we should also focus on theoretical aspects of that. So sorry, there's a lag, I think. That's all from me. Thank you for letting me present, and thanks to our amazing collaborators. We are actively working on collecting new data in different clinical practices and kind of having this federated learning consortium. And if you are interested in joining us or even connecting with me, you can scan my LinkedIn QR code here, and happy to chat further. Thank you, everyone.
Thank you so much for that talk, Manoj. Our next speaker will be Neil Bresler from Johns Hopkins Medicine, speaking about the potential impact of AI chatbots. Very timely topic. Neil. Dr. Bresler has a pre-recorded video, so our team is getting that spooled up right now, so please hang on one moment.
AI Summit 2023. I'd like to discuss the potential impact of AI chatbots and how these may relate to editors, authors, and readers of the peer-reviewed ophthalmic literature. These are my financial and other disclosures. ChatGPT debuted in November of 2022. This is an OpenAI new artificial intelligence chatbot. You tell it to write something, you receive text designed to be as if written by a human. There are a lot of advantages to this. These are simple requests. Oral requests are reported to be available in the near term. The knowledge is based on an algorithm that searches the vast data of the internet with generative AI techniques. It provides proper punctuation, varied sentence structure, and very clear organization. AI chatbots, though, can have disadvantages. They can have factual errors. For example, I asked the AI chatbot GPT-3, what are drusen? And in February of 2023, the chatbot said drusen are small yellow or white deposits that form on the retina of the eye. They're often a sign of age-related macular degeneration, a common condition that affects the central part of the retina and can cause vision loss. Drusen can also be a sign of other eye conditions, such as Stargardt's disease and Best's disease. It's important to visit an eye doctor regularly to have your eyes checked and monitor any changes in the size or number of drusen. On the surface, This may appear to be an excellent summary, but in fact, there are factual errors. Drusen don't form on the retina. They form within the basement membrane of the retinal pigment epithelium below the retina. They're not a sign of other eye conditions such as Stargardt's disease or Best's disease. These have very different phenotypic and pathologic features. These AI chatbots may have disadvantages when these factual errors are associated with someone seeking treatment. I asked the chatbot, how does one treat post-surgical cystoid macular edema? It said appropriately, perhaps, treatment for post-surgical CME depends on the severity of the condition and the underlying cause. It considered topical or oral corticosteroids may be prescribed to reduce inflammation and swelling. True enough, but almost always topical, almost never oral. Non-steroidal anti-inflammatory drugs may also be used to reduce the inflammation and pain. Also true enough, but as topical drops, never as oral non-steroidal drugs. Intravitreal injections of corticosteroids or anti-VEGF agents may be given to reduce the swelling and improve vision. Well, partly right. Rarely, we might consider intravitreal corticosteroids in a chronic case, but we never consider anti-VEGF. Post-surgical CME is not a VEGF-driven process. Then it said laser therapy may be used to reduce the size of the cystoids and improve vision. Well, that's not true. We don't use laser therapy to treat post-surgical cystoid edema. Vitrectomy surgery, which involves removing the vitreous gel from the eye and replacing it with a clear solution, may be necessary in some cases. True enough. And then it said eye drops with non-steroidal drugs or alpha-2 agonists. Well, true enough for non-steroidal drugs, but not to agonists. Can chatbots be authors? Many people have asked this recently. Well, we know that for authors, they each should have participated sufficiently in the work to take public responsibility for appropriate portions of the content. And according to the guidelines of the ICMJE, authorship credit should be based on the following 4 criteria: substantial contributions to the conception or design of the work, or the acquisition, analysis, or interpretation of data for the work. Well, a chatbot could do that. You could ask it to search and provide an introduction, maybe even methods for you. An author should be involved in drafting the work or revising it for critically important intellectual content. Again, you could ask a chatbot to help draft some of the introduction. Final approval of the version to be published. Well, why not upload the entire manuscript and ask the chatbot, does this meet the criteria for the instructions for authors? For example, for JAMA Ophthalmology. But there's one more criteria. Authors have to agree to be accountable for all aspects of the work in ensuring that questions related to the accuracy or integrity of any part of the work are appropriately investigated and resolved. Chatbots can't do that. Since each author should be accountable for parts of the work he or she has done, accountable means a person, organization, or institution required or expected to justify actions or decisions. Responsible. Can a computer be held responsible? Most computer ethicists say a computer, by definition, cannot be held accountable for anything because there's no mechanism to hold it to account, short of turning off the electricity supply or destroying the hardware. Only humans, at this time, can be accountable. In addition, each author should be able to identify which co-authors are responsible for specific parts of the work and should have confidence in the integrity of the contributions of any co-authors. Integrity means the quality of being honest and having strong moral principles, moral rightness. Can chatbots be authors then? Not at this time. Each author should be accountable for the parts of the work he or she has done. In addition, each author should have confidence in the integrity of the contributions of any co-authors. All those designated as co-authors should meet all 4 criteria. Those who do not meet all 4 criteria cannot be accountable or cannot have confidence in the integrity of the co-author contributions, like a chatbot, should be acknowledged in the acknowledgement section. So revisions were made to JAMA Ophthalmology's instruction for authors. Non-human artificial intelligence, language models, machine learning, or similar technologies do not qualify for authorship. If these models or tools are used to create content or assist with writing and manuscript preparation, that's okay. But authors must take responsibility for the integrity of the content generated by these tools. You can't blame an error because you used a chatbot. Authors should report the use of artificial intelligence just as we would report the use of a scientific writer, language models, machine learning, or similar technologies to create content or assist with writing or editing of the manuscripts in the acknowledgement section or occasionally in the methods section if this is part of the formal research design or method. And in an editorial just published 10 days ago, the reasons why a chatbot cannot be an author and the reasons why the instructions for authors changed and why you must explain if you used a chatbot are in this editorial. In conclusion, artificial intelligence chatbots have arrived and they're easy to use, but they can have factual errors. This can be dangerous when seeking diagnosis or management, and therefore should be overseen by a physician who takes responsibility for the content, including its integrity. And an AI chatbot cannot be an author. It can't be accountable for parts of the work the AI chatbot has done. It can't have confidence in the integrity of the contribution, but it can be used by some journals. JAMA Ophthalmology embraces it to create content as long as the authors take responsibility for the integrity of the content and as long as they acknowledge its use. Thank you for letting me share that.
Well, very thought-provoking talk by Dr. Bresler. We have our final speaker, and then that will be followed by a panel discussion. Just a reminder again, please continue entering questions into the Q&A section on your screen, and our speakers will either answer them by typing back, or we will talk about that during the panel. And our last speaker now is Nitin Chowdhury from Toronto, and he will be speaking about AI-based denoising, which is actually a really important topic in ocular imaging. Nitin.
Thanks, Ted. Thanks, Rishi and Jenny, for the invitation for this excellent meeting. It's amazing that 3 years have already passed at this time, and I can see the talks of the caliber and the work that's happening is growing rapidly. So thanks for letting me share this work. Great. These are my disclosures. I consult for a variety of imaging companies, and I'll be presenting some work here that's novel from TopCon Medical Systems. So some of the background here is, we see noise in imaging on a regular basis now in our clinical practices. When we capture images, you can see here on the right, web source image of a patient with PED. And our goal in clinic is always to get the best quality images from our patients and our staff, but noise is noise. And we do see a significant amount of noise and interference when we capture images, often from motion artifacts, from patient movement, media opacity, cataract, vitreous hemorrhage, corneal opacities, incomplete image capture, patients belzing, patients not fixating correctly. And then when you look at the technology itself, we know that web source has a lower signal to noise ratio than spectral domain. So some of those issues are inherent to the technology itself. How have we been circumventing this up to this point? Well, as mentioned earlier, image averaging is the primary way that we've been doing this in order to get the best quality images. And you can see here on the left, there's the original raw scan image of this patient from a web source machine. And then on the right, you can see 128 line scan averaged image, which obviously looks much more cleaner and looks more like what we would like to see in clinical practice. Some of the perils with this approach, though, is that it can be quite time consuming with respect to our clinical practice. Averaging obviously has been used for a number of years. It helps to improve the signal to noise ratio. It's readily available in all devices. And again, it's tunable. Most of us know that we can go into our OCT platforms and adjust how many average lines we want to have in our scans. For example, in the Heidelberg, this is represented by the ART area, and we can adjust it from 9 lines or 30 lines or 100 lines. But one of the things we have noted that as time goes on and more averaging is performed, it does take longer in clinic. Of course, transferring from one technology to another can also be costly. And there's always a risk of over-averaging and potentially getting muddied or blurred images. So this is where AI seems to help us look at the issue from another angle. Here's the same patient. On the left, you'll see the unaveraged raw image. And on the far right, 2 different variations of averaging, 128 line scan average and 16 line averaging. And the quality is quite good, but again, the time required to acquire these images is significant, particularly as you increase the averaging. In the middle is an AI denoised image from this TopCon software that we were using in the study that we're going to present. And you can see the quality comparison is equivalent to 128 lines and definitely equivalent, if not slightly better, than the radial 16 lines. So the question is, can AI do this better? And can it save us time in clinic? And ultimately, does it have meaningful results for us in clinical practice for our patients? So we basically used a denoising algorithm from TopCon, which is an unsupervised denoising deep learning algorithm, which basically allows for training without averaged images. And as a result, 2 Ross OCT scans of the same location are taken and used to train the deep learning model based on statistical reasoning. And the noise in the images is suppressed, whereas the signal is enhanced. And the best way I've tried to understand this for those of us that aren't data scientists is really when you think about being at a cocktail party and you're in a room that's full of noise and you're having a conversation, your brain is able to tune out and focus in on what it wants to hear. You're able to hear a specific conversation, but if you wanted to hear the specific music or lyrics that are playing in the room while you're in a noisy environment, you're able to single them out. And this is how this software effectively works. It's trained on noisy images, but it's able to pull out the signal from each of those noisy images. So how does this technique compare to what we've been looking at now? On the far right, you can see a patient with DME and a raw unaveraged OCT. And on the bottom, you can see the denoised image below. And so basically, this CNN model is designed to help improve medical image quality and of course, separate the signal from the noise without getting a perfect image to work with at start. So when we capture images at the point of care with our technicians, those images are noisy and they're not perfected and potentially unaveraged. And we take a large number of these raw images so that the software can learn from the noise in each of the various types of images to help improve its denoising capabilities. And effectively, these separate CNN models are trained for different retinal layers to help provide better accuracy. What about OCTA? I think this is one of the areas where we feel that denoising and image quality is of paramount importance, particularly because we're trying to get to a point where we can use the metrics from perfusion density maps to help predict response to therapy, help predict prognosis for patients. So here on the left, you see a normal eye. The superficial and deep capillary plexus are provided from the machine directly, web source OCT. And then these layers were denoised. And you can see that there's a significant improvement in clarity and vascular detail in both cases, including in the foveolovascular zone. And here's another example of a patient with a branch retinal vein occlusion. As we know, in retinal vascular conditions, we're trying to get better information for a wider field perspective. We're trying to measure a non-perfusion area. There's been some great work done on this already, where the non-perfusion area is actually being used to predict response to treatment and obviously visual outcomes. And on the left here, we can see the raw OCT scans taken from this patient, and then the denoised images on the far right. Just looking at the activity that we can apply this to, we decided to look at what are the real world applications for this. So if we took this denoising approach and also a machine learning approach to segment out fluid volumes, could we obtain a meaningful information on the effectiveness of this technology? Presently, intraretinal, subretinal fluid volumes obviously are being measured automatically using AI. Manually doing it, as shown here, of course, is time consuming, it's inconsistent, prone to error. Many of aspects have already been presented. So we tried to combine both approaches in machine learning as well as denoising. Here's an example of a raw OCT scan on the left, which is quite complex for wet AMD. And on the right, you can see machine learning segmentation from the Retina AI model. Here's a more complex version of that. And you can see, of course, that having this type of technology at our disposal, as presented earlier, could be very helpful. But can we improve the quality of images that are going into these algorithms at outset? And does it impact the output that comes from these segmentation models? So that was a part of our goal with this study that we're going to present. Here's an example of the fluid segmentation maps that, of course, come from this, and this has already been shown earlier. So the study that we set forth to do, which was looking at utilizing image denoising and machine learning segmentation to quantify fluid volume in eyes with retinal vascular disease, and this was a static study. And again, the purpose of it was to determine the effect of denoising on intraretinal fluid and subretinal fluid volume measurements, evaluate the utility of combining this approach to image processing, and investigate it across several disease states, including DME and RVO. This is a pilot study, so I'll be presenting the DME data only for the time being. And this is how it was set up. Baseline and follow-up OCT scans of 40 patients that were followed over a period of 6 months were collected and retrospectively analyzed. These were 200 by 200 3D macular volume scans of Topcon Triton in patients with DME and RVO. The raw original scans were pushed through machine learning OCT algorithms made by Retina AI, and the intraretinal fluid and subretinal fluid was segmented. Then we took that same data set and we denoised it using the RTB toolbox from Topcon, and then went and pushed that same data set through the Retina AI segmentation platform to see if we would get a noticeable difference in the fluid volumes. So here are some examples. This is a patient with a raw OCT scan on the far left. Figure A and B, A and D is segmented for you. And then the denoise scans for the same patient, which is seen here in B and E, and then the corresponding fluid maps from those different data sets. And you can see here in this singular example, less fluid is seen when the denoised images run through the same Retina AI platform. Here's another example. And again, another patient with DME. And again, these types of eyes can be quite hard to segment because of the nature of the layers becoming difficult to discern. Drill, we can see lots of factors that can make it harder to set out intraretinal fluid. So when we looked at our results, what we found was that the denoised versus raw intraretinal fluid volumes in DME patients were statistically significant. That is, the denoised images, when they were ran through the Retina AI segmentation platform, the intraretinal fluid was statistically significantly different than the raw images going through the same segmentation algorithm. When we looked at subretinal fluid in patients with DME, we did not see a statistically significant difference. And this is preliminary data from this particular study, but interesting to note that are we getting the best information from our existing scans that we capture on a regular basis? We did take it a step further and see, did this fluid volume have any impact or correlation on the visual acuities of these patients? And in both cases for intraretinal fluid, denoised and raw, it did not. And the same was true for subretinal fluid. What about those images that were low quality index? Of course, your images have to be of a certain quality to be in a study, to be analyzed. We had, fortunately, a very high quality data set, which I think was mentioned earlier, that sometimes these data sets, because they're performed in academic environments or in environments where people are trained to do research, are already higher quality than a real world setting. The number of scans that were of poor quality, of a quality index of less than 40, was only 5. And for those poor quality images, there was not statistically significant difference in the raw and the denoised images in terms of intraretinal fluid metrics. So what is the utility of combining this approach in this small early pilot study? You know, in DME, denoising statistically significantly changed the intraretinal fluid measurements, but not subretinal fluid. Why would this be? And we know intraretinal fluid, as mentioned earlier, is an important biomarker in looking at patients' response to therapy as well as their prognosis. But it may be that intraretinal fluid is more obvious in denoised images because of the reduction of signal to noise, although there remains a risk of over smoothing or over averaging or over denoising the image. Subretinal fluid is generally much more distinct on OCT, and that may account for the fact that we did not see a difference between denoised and raw images in our segmentation. And of course, the subgroup with poor quality images did not have a substantial benefit. So what are the conclusions we can take from this technology as an early entry point into our imaging world? AI processing of ophthalmic images obviously is rapidly progressing in the field. The amount of time that it took for the AI to denoise the image was a fraction of a second, which is much longer than it would take to do averaging in the clinic, as we saw with the 128 line average imaging or 16 line. AI-based denoising, of course, should shorten clinical times in the office for patients as well as for our staff. If we can combine machine learning with denoising, we can potentially get high quality images and additional quantitative information. And intraretinal fluid at this point versus subretinal fluid, we did see a difference between these two types of biomarkers. And again, it may be due to the nature of where the fluid is located and the readiness with which we can actually differentiate the two layers when it comes to denoising and segmentation. I think when we look at future directions, we'd like to see more images like we see on the far right, where we have a volume rendered image here, which is able to look at web source OCT and look at CNVMs in a very detailed way. And this is a denoised OCTA. If we can look at our applications for denoising in the context of OCT and geography, we may be able to obtain better metrics, better perfusion density maps. And if we can integrate this with machine learning for segmentation, we may be able to begin doing much more extensive work at the point of care directly with little time for the patient and the staff that's involved. I'd like to thank my research team and my co-authors who assisted greatly, specifically my fellow Samantha Orr, and thank you for the opportunity.
Wonderful talk, Nitin. We're going to bring everyone back here to the stage for our panel discussion now. I guess my first question will be for Eddie. You know, I was having a discussion yesterday actually on a panel with the chief architect at Microsoft, specifically about model drift. And I think while you did call out the FDA for being very forward-looking with their guidance for SAMD and AI, you know, I think some of the regulatory input is obviously a little bit behind on what's happening in real time. But you know, one of the discussions I was having with Pam Nesbitt was that populations do change over time, and so there actually should be model drift over time to accommodate for that change. You know, we all change as humans over time, animals change over time and evolve. So do you have an opinion, this is a tough question, of how often we should be retraining our algorithms and re-releasing them into the wild to accommodate for that drift?
Thanks, Ted. I mean, I don't know if there's necessarily an ideal cadence for retraining, but I do think that there's a ideal cadence for re-evaluation. And for that, I think it's constant. If we think what is ideal, I don't think anyone can argue against constant evaluation. And one of the models for this I look for is the company with the best real world AI data engine and pipeline, and that's Tesla. So Tesla essentially has these pods, which are in the real world at all times, which are your cars, which are constantly recording, and they're constantly sending data back to evaluate the effectiveness of their models against the ground truth of the human inputs. And as they see dips in performance, they can selectively pre-specify substratified parts of their data sets that they want to enhance and get more data on. And so they can say, we have poor performance on stop signs in the snow. The next day, when you're driving around in the snow, you are going to selectively record those more. And so they have the next day 1 million stop signs in the snow coming in, and they retrain their models. So long story short, no ideal cadence for retraining, but ideal cadence for validation is constant.
Great points. For Manoj, I think you've touched on a very hot topic, which is federated processes in AI. You know, what is the biggest challenge to implementing these approaches, and why aren't we all using it like today?
I think implementation is always difficult. For example, I can give you one example. Say, even if you're not sharing the data, still, if we want to train a local model, that's still difficult because there's not a really standardized way of storing those data. So even if you have like MRN and you want to collect a lot of data, and then you can potentially face many challenges actually organizing that and strategizing that within the institutions. In terms of framework, the challenges that I mentioned are also, I would say, reasons that it's still not in the implementation, but a lot of exciting work going on. Dr. Keen, did you have a comment on that?
If I can butt in, I think there's a lot of really good work on the sort of science of federated learning, the machine learning aspects. But actually, I think the really hard parts, there's probably three really hard parts that we haven't really touched on. So first is, I think we're mainly talking so far about research data sets that have been kind of curated in some way, but actually what would be really meaningful is proper integration with the ophthalmic imaging databases in our institutions. The second thing is, my experience with going to the IT professionals in the National Health Service, the hard part is you have to do all the other paperwork, the data protection impact assessments, information security checklists to prove to them that what you're doing is okay. And then the third part, which could be slightly intractable in some scenarios, is what about the intellectual property aspects of this? And in my experience, as soon as IP comes up as a possibility, then it's like you're wading through molasses to try and get the permissions to make something happen.
Yeah, I think currently we're at the first stage where the preliminary study that we have shows the potential of federated learning, but we only use available online data source. So the consortium that I mentioned at the end of my slide, the different collaborators that I'm working on, now we're at the stage where we're facing a lot of challenge, like kind of really getting those data set up and then having the local models set up. So it will take some time, but yeah, I think I have talked to more IT people and technical people regarding this data collection, I think, in the past couple of months than I have ever done it. So that's definitely, yeah, but I totally agree with your 3 points. And about the IP stuff, I'd love to know more about it, because that's going to be one of the potential challenge of implementation of federated learning for sure.
Yeah, no, I think that is a major challenge. Thank you both for your comments. Nitan, I think using AI to help with denoising is a great approach. We have a question from the audience, and I also noticed this in one of your images on the OCTA. It seemed like one of the vessels disappeared in the center of the image in the inferior macula. And so, do you see downsides on using machines to denoise, and is there like an Instagram like filter effect that could impact clinical care as well as research?
That's a good question. And I think that particular example did bring that to light as well. That's why I included it. I think what specifically we see this with OCT and geography, because there's so much more data there. I think validating this technology with fluorescent angiography overlays is one avenue to ensure that we're not ending up with missing data or imputated data, as you mentioned. But I think from a point of care perspective, before we take it into the world of starting to use it for metrics, we took it to that step to see, does this actually have any meaningful benefit? But I think before we take it at large in our large clinical trial data sets to looking at metrics, being able to use it in the clinical setting to confirm that we are not missing the data is going to be important. But I think fundamentally getting the most out of all the bad images that come in our office so we can actually make clinical decisions without relying on metrics per se, just the qualitative assessment of a patient's fluid, no fluid, structural damage, no damage. I think that's the first entry point to where we can find benefit.
Wonderful. We're running low on time here in our panel, so I'm going to leave the last words to Dr. Keen. I have a question for you. You did mention at the beginning of your talk how everything is accelerating, and generative AI is definitely taking the scene by storm. So I want to ask you, what's your prediction a year from now about the state of generative AI, and what's going to be the most exciting thing on the scene at that point?
So I'm not sure. So I think what's the quote? We overestimate what we can do in the short term and underestimate what we can do in the longer term. So I guess my prediction for maybe 2 or 3 years from now is widespread use of foundation models in ophthalmology, in retinal imaging, in all of healthcare, linked with federated learning, and I just imagine, I imagine a situation where we're talking to like new residents in 2030, and we're saying, telling them about the days when we used to do studies with 200 patients or 2,000 patients, and that was like regarded as being a massive study. And they're going to look at us and think we're like dinosaurs from the black and white movie era or the silent movie era, because all of the work will be on every patient in a region of the United States with the disease, or every patient around the world with the disease, combined with these foundation models.
Well, that's an exciting world that you're describing there. So thanks to all the speakers and the panelists for session 3 here. We're going to move into session 4. And our first speaker is going to be Elliot Dow, who is currently at Duke University and will be moving to California this summer. And he'll be speaking about the AI human hybrid in a tele-ophthalmology setting for DR screening. Elliot.
Okay, so thank you very much. Today I'll be talking about an AI-based screening system for diabetic retinopathy developed at Stanford University to improve access to eye care for diabetic patients in the San Francisco Bay Area. I'm going to start by giving an overview of the program, which we call STATUS, as well as the outcomes from the first 2 years of the program. Then I'll discuss an AI human hybrid workflow that we implemented to enhance the performance of screening. Finally, I'll discuss an analysis of patient referral behavior after AI screening. But first, I want to give a huge thanks to everyone who's made the STATUS program a success. I want to give special acknowledgement to STATUS program founder and director, David Myung, as well as Ted Lang, who's the director of the Stanford Reading Center. So thank you so much to everyone featured here. I don't have to tell this audience about the public health crisis of diabetic retinopathy. We have about 30 million plus patients in the United States who need an annual diabetic eye exam, and many health systems report less than 50% compliance with this metric. At Stanford, we're a bit above the mark, but still have room to go. About 42 to 76% of diabetic patients in our primary care clinics receive an annual eye exam. So to address this gap in care, the STATUS program was founded 3 years ago. It offers AI-based diabetic retinopathy screening at primary care locations around the Bay Area. The program started with 5 locations, expanded to 7, then 9, and in 2023, we'll open the 10th site in the STATUS program. The program uses the FDA-approved IDXDR device, which was recently renamed to Luminetics Core. As many of you know, the device involves a medical assistant obtaining 2 fundus photographs from each eye. The images are uploaded to a cloud-based AI algorithm that first assesses the images for quality. If they pass the quality check, then an algorithm assesses the images for ETDRS 35 or greater diabetic retinopathy. And if it meets that criteria, the patient is referred to an ophthalmologist for in-person exam. Over the first 20 months of the program, about 2,400 AI-based screenings have been performed. And the patients served have been extremely diverse in terms of their geography, self-reported race and ethnicity, as well as age. For something on this scale to be successful, a system-wide driver has to be in place. Our driver in the STATUS program is the HEDIS measures. These are primary care metrics set out by the NCQA that determine in some part reimbursement to primary care clinics for their services. And a diabetic eye exam is one of the HEDIS measures. We tracked HEDIS fulfillment over 2 years at clinics that were participating in the STATUS program compared to those that were not, and found that the STATUS clinics steadily tracked upward in HEDIS compliance, whereas the non-participating clinics steadily tracked downward, with the biggest downward trend during the coronavirus pandemic. Perhaps more importantly, about 12% of all of the patients screened in this program were found to be more than mild diabetic retinopathy positive. These are really the patients that you want to pick up in a screening program, the ones that you want to have plugged in for ophthalmic care. So how did the AI device perform in our program? Well, in our hands, IDXDR had extremely high sensitivity, missing almost no true positive cases, somewhat lower specificity around 60%. We, in parallel, had retina specialists evaluate the same images on a consensus basis in a traditional store and forward teleophthalmology workflow. And those retina specialists had very high specificity, somewhat lower sensitivity. In a screening program like this, having high sensitivity is essential. You want very few diseased patients to fall through the cracks. But it's important also to have high specificity. If a lot of the patients who are being referred for in-person examinations are actually diabetic retinopathy negative, this very quickly overwhelms referral pathways, discourages referring primary care doctors, and confuses patients about their diagnosis. So we wondered if there was a way to combine the sensitivity of the AI device with the specificity of the retina specialists. And we did this by something we call the AI human hybrid workflow, where in the first instance, all of the patients who were found to be more than mild diabetic retinopathy positive after screening with IDX were overread by retina specialists. And with this two-step hybrid workflow, the sensitivity and specificity were extremely high, both above 95%. We faced another problem in the status program that we wondered if it could be solved by this hybrid approach, namely gradability. So in the IDX-DR pivotal trial, gradability was above 90% for images. In status, we're not pharmacologically dilating pupils, so all images are non-mydriatic, and as a result, about a third or more of patient encounters are considered ungradable by IDX-DR. So for those ungradable encounters, we also sent them to the retina specialist and found that in many cases, the retina specialist could render a diagnosis of diabetic retinopathy even if the IDX-DR was unable to do so. And we increased the gradability from about 63% to 92% of the program. So altogether, we've implemented this three-tier system in which the AI system first assesses the patient. The positive and ungradables that come out of that initial screening are overread by remote retina specialists. And only then the positive and ungradable patients are seen by an in-person retina specialist. So I want to take the last minute or two to shift gears and talk about an analysis of patient follow-up behavior after a positive screening result. This is really the important metric in a screening program. You can identify a lot of diabetic retinopathy patients, but if those patients aren't following up for eye care, that's what's essential in the program. 73% of our patients who tested positive in the program followed up with an ophthalmologist, which is a very high rate. And we wondered why that was the case. Previously, during the first year of status, we operated a traditional store and forward teleophthalmology program that returned results in about 2 to 5 days. With IDX-DR, it's directly integrated to Epic, and patients receive their results the same day. So we wondered whether this improvement in time to result also affected patient follow-up. We did this by analyzing 3 conditions in the status program and ultimately found that the patients who received a positive result from the AI-only workflow were 3 times more likely to follow up the University Eye Center compared to those patients screened in the human teleophthalmology workflow or the AI human hybrid workflow, which is essentially a sham AI workflow. They undergo AI screening, but receive their results on the human timeline. These results were also supported by surveys showed that patients who did follow up chose their ophthalmologist based on a referral by their primary care physician, really highlighting the importance of the interaction between the doctor and patient at the point of screening. So in the interest of time, I'm just going to wrap up there and say we've learned a lot during this first phase of status. HEDIS measures have been improved. Gradability has been enhanced by the AI human hybrid workflow that we've implemented, and patients are following up at a higher rate because of AI screening. So once again, thank you. We look forward to using these learnings to further improve the program to benefit diabetic patients in the Bay Area. Thank you.
Thanks, Elliot. Again, just a reminder, please enter questions into the Q&A button at the bottom of your screen. Our next speaker is going to be Yasha Modi from NYU, and he'll be speaking about leveraging simple AI algorithms to augment DR screening. You can see the theme for this session is screening.
All right. Well, thanks, Dr. Lang, and that was a really great talk, Dr. Dow. So kind of carrying out on a theme here, these are my financial disclosures. see, but my real disclosures is that most of my interest is in teleretina and learning about automation of teleretina. And I am a complete amateur in AI, but I do work with way smarter computer scientists to help me with this. And, Piers Keene really highlighted the reason for why it's so important that clinicians become educated in this editorial, and I would encourage you all to read it. So the simple teleretina perspective is accurate detection of referable diabetic retinopathy. Dr. Dowd talked about the value of IDX in its applications within the Bay Area, and then also macular edema detection. So, and of course, it's also valuable if we can identify other salient disease at the time of screening, like AMD and glaucoma. And at NYU, we have sort of a telescreening initiative that sort of seems like it belongs in the dinosaur ages. We essentially have a semi-automated capture of a fundus photo at a primary care visit. This then goes to a retina specialist and is reviewed, and then the patient and the PCP get notified if there's an issue. And the area that we're talking about, is sort of the area, if this is Manhattan, the sort of peninsula of Manhattan, we're looking at the southwest portion of Brooklyn, where we have a relatively high poverty rate, and we're screening about 100 patients a week. And of course, as this program gets larger, there's a lot of value in the autonomous screening because that allows for scalability of the program. And so when we think about scalability and the AI applications within teleretina, obviously we want autonomous capture with a send of images with high readability. We saw about a third of patients probably were not able to be read by IDX. But then it's also the ability to accurately identify referable DR. And I think we probably all remember this paper from 2016 by Varun Gulshan that really showed this proof of concept that we could identify disease with high readability. And then also there's the commercialization of this. And this is the same system we just heard about, which is IDX-DR, and then there's iNOOC IART. But this has some limitations in the sense that it's hardware dependent, meaning if you already have cameras, this is maybe something that's not viable from an economic standpoint to implement within your institution. So some of the other goals is for an ability of an AI algorithm to grade image independent, the image independent of the camera used, whether it's a 45-degree camera, a 50-degree camera, or ultra wide field image. And then also for the ability of the AI algorithm to accurately identify level of DR in the background of other retinal diseases, because a lot of these proof of concepts involve excluding other diseases. Very commonly in practice, patients can have more than one disease. And so this was actually proven to be the case by Daniel Ting, who looked at nearly a $500,000 patient image set and identified high accuracy for detection of not only just diabetic retinopathy, but glaucoma and AMD. And these were also images captured from different cameras. But one of the major limitations, one of the things that I'm interested in is that detection of DME using teleretina is oftentimes suboptimal. And this is likely due to the limitation of a two-dimensional photograph and then trying to make a determination of a three-dimensional disease. Now, obviously, integration of OCT technology would be beneficial, but it drives up the costs. So what if we could just use OCT to screen DME and DR? You have a cross-sectional OCT that makes DME detection quite obvious, but we also know that DR detection is much harder on OCT, and this is where AI-assisted analysis of OCT images can be really helpful, and this has been done. And so I want to highlight two studies. This one really looked at a convolutional neural network essentially on two different databases, one that had 2,000 OCTs, one that had about 84,000 OCTs. These are publicly available image banks. And what they did was they only labeled 80 of the OCTs. So this is a semi-supervised learning program. And what they identified was that with relatively high sensitivity and specificity, they were able to identify diabetic retinopathy. And this was looking at just any diabetic retinopathy. But the question is, could we also identify detection of early diabetic retinopathy by OCT? And this was a group out of Louisville that looked at this. And what they did was they looked at the input OCT, and then they actually carried out a layer segmentation, and then did feature extractions, maybe things that we wouldn't otherwise necessarily look at, looking at reflectivity, thickness, and curvature, and then put this through a convolutional neural network. And so I just want to sort of show you what that output may look like. So here on the left, we have normal images. On the right, we have mild to moderate NPDR. And then in the middle, we have what they call subclinical diabetic retinopathy, where there was a normal fundus exam, but OCT features demonstrated somewhere between normal and mild. And so I would argue that probably the retina specialist would not be able to make this clinical differentiation, yet the algorithm had greater than 90% accuracy at distinguishing between normal and mild or moderate NPDR. But when we have an OCT, we actually have two images. We not only have the cross-sectional image, but we also have the near-infrared image. And if you were to just look at the near-infrared image, this may seem somewhat more identifiable to us because we can see these dark areas or these hyperreflective areas that have microaneurysms and dot plot hemorrhages. Here's another example of what that may look like. So here we have a readily identifiable feature that we could potentially use to quantitate. And so we actually asked that question, and the question was, does the number of hyperreflective spots correlate with disease severity? And we also want to know, can we reliably identify moderate NPDR or worse, which would be essentially referable disease, by quantitating these hyperreflective foci? And so this is not an AI study, but rather just a proof of concept where we looked at 195 patients. We had 2 graders, and we excluded patients with low quality OCT scores. And the nuanced approach was that we only identified hyperreflective foci with discrete margins. And so we essentially broke down the categories so that they were all evenly divided between no diabetic retinopathy all the way to proliferative diabetic retinopathy. And it was a relatively diverse group of individuals. And what we had identified was that really the threshold takeoff point is really when we get to moderate or worse disease, we start to see a number of hyperreflective spots. But it's not really good at differentiating between moderate and maybe proliferative diabetic retinopathy. And so when you actually say, well, what defines moderate disease, the AUC was only about 0.85. So this is sort of laughable compared to these AI programs that are developing really, really robust AUC values. But this, again, is a proof of concept on under 200 patients. And if we add in, if we look at near-infrared imaging, we also know that we can identify all of these vascular abnormalities. And if you add in, you say, hey, let's go back and just binarize this function. Do they have vascular abnormalities or do they not? We can identify high rates of at least moderate disease. And the question is, when you combine that with hyperreflective foci, we can see that this helps us identify disease of greater severity, severe NPDR or PDR relative to the earlier stages. And so when we look at diabetic staging by fundus photography, this is really intuitive to us. This is all how we became educated. But if you look at near-infrared imaging, maybe this is not so intuitive. Maybe we don't have the ability to decipher and say, hey, yes, that's mild on the left, and that's proliferative diabetic retinopathy on the right. And that's obviously much easier to do by fundus photography. But this is where assistive AI technology with training of a fundus photo and a near-infrared matched data set certainly can be very helpful. So near-infrared imaging certainly can differentiate levels of severity without AI integration, but it may not be intuitive to our own sense of understanding. And this is where I think AI integration may improve accuracy. And if we use the near-infrared image as opposed to the cross-sectional image, we have some supervised input features like hyperreflective foci and vascular abnormalities to choose from. So I do think OCT does have the potential to autonomously screen both for DR as well as DME. Thank you.
Thanks, Yasha. Our next speaker will be Divya Rao, who will be speaking about the use of smartphone fundus photography and its diagnostic performance.
Hello, everyone. Thank you, Dr. Leng and the OIS team for this wonderful opportunity to present at this forum. And on behalf of my team and collaborators, I'll present our early work on a prospective validation of an AMD AI solution that is integrated on a smartphone fundus camera. Here are my disclosures. Having a little trouble with my slides. Okay, so as we all know, AMD is a leading cause of blindness in the elderly, in the developed as well as in the developing world, and it's projected to affect 288 million by 2040 due to exponential population aging. And screening can enable early detection and timely management. Given the low doctor population ratio the world over, to optimally screen, we need to get closer to where the patients are and potentially go outside of the clinic to primary care and even beyond. And for this, the technology needs to be appropriate. It needs to be effective, it needs to be affordable, and needs to be portable as well. While there has been promising work on developing AI solutions for AMD screening, there's been a lacunae of novel deployment strategies to allow for scale for the screening. So an AI integrated, say, on a portable validated fundus camera can potentially allow AMD screening to scale and could be a potential solution. So the purpose of this study was to evaluate the performance of a new artificial intelligence system deployed on a smartphone-based fundus camera for screening referable AMD in a South Asian population. The study device consisted of, as I mentioned, a smartphone-based fundus camera with an integrated offline AI that does not require internet for inferencing. And this algorithm was developed using over 100,000 images from the ARED study, as well as the target device from Asian Eyes. A deep learning efficient net classification model was developed to distinguish between referable and no referable AMD. And referable AMD included those with intermediate and more advanced disease. And on an independent retrospective test data set, the sensitivity was found to be 91% with a specificity of 84%. But as we all know, on well-curated data sets, AI algorithms tend to do well. So the objective was really to see how would this algorithm perform in a prospective study. So in a more controlled setting, we conducted a cross-sectional study at a retina clinic of a tertiary eye hospital in southern India, included patients over 40 years, excluded those with acute vision loss due to other pathologies, those with active infections, those with advanced cataract or significant media opacities, or those who could not be dilated, and our estimated sample size was 545 in order to detect a sensitivity of 85% with a precision of 10%. So this is the workflow. All of those who are enrolled underwent a comprehensive eye exam, and along with that, underwent an undilated fundus imaging with the smartphone-based camera system. An image quality check alerted the operator whether the image quality was sufficient or not. And when it was sufficient, the algorithm would run offline and give an output of referable or no referable AMD. When it was insufficient after 2 attempts, the patient was dilated, and the fundus and the same workflow was repeated. And the patients were also imaged on a standard desktop system, a Zeiss Claris, and also underwent an SD-OCT macular line scan in both eyes. Slides appear to not move. Okay, here we are. So a predefined AMD grading criteria was used using both the color fundus images as well as the OCT by 3 blinded retina specialists. And for each image, both the color fundus photograph as well as an OCT, the gradability of the image was recorded. And the color fundus images were graded according to ARED's 4-step clinical classification. And the OCT was categorized based on a scoring system from 1 to 4, based on the presence of AMD, presence of 1 being no AMD, 2 being early to intermediate AMD with changes in chorioretinal changes, and score 3 was advanced AMD, either neovascular or geographic atrophy. And there was a final scoring grade that was made, and those with intermediate or advanced AMD were considered to be referable. And this was used as the reference standard for comparing the AI output. So the mean age was 65 years, and as you can see, the agreement between the graders were pretty good, ranging between 0.7 to 0.94. But what was interesting was because we conducted the study in a tertiary center, out of the 84 patients that were analyzed, we had 43 patients with advanced disease, 21 with intermediate AMD, 9 with early, and 11 with no AMD. And interestingly, the sensitivity of the algorithm was 96%. It was able to detect 62 out of the 64 cases, and the false negatives included those 2 eyes with intermediate AMD. And out of the 20 cases of no and early AMD, it detected 10 eyes to be referable, 5 of them being early AMD and 5 of them being no AMD. These are some representative images. As you can see, the class activation maps pointing to the areas that led to the prediction of the AI being positive. So as you can see, the interim results of this AI are promising in identifying those with referable AMD with a good sensitivity. However, a further evaluation is required on the false positive cases because the sample size for those with no referable disease was much smaller. And we need to really look at the final diagnostic ability of the AI at the end of the study. There are several algorithms out there showing robust performance, but these are mainly on retrospective data sets. So I think the strengths of this study would be that it is prospective in nature. It is in a more controlled setting in clinic with a large proportion of disease cases, indicating good sensitivity. And the offline nature of this algorithm not requiring internet could be a potential advantage. However, the current limitations are the small sample size of no referable group, given that this was in a tertiary institute and the true specificity is to be determined. And another potential limitation could be the use of a single OCT line scan across the fovea, which could miss out the lesions in the surrounding areas. Of course, the next steps would be to complete the study, look at the final results, and obviously the next step after that would be to go out into the population and do a real-world study where you could look at true prevalence of disease, include all patients with other diagnoses, as well as images of varying image quality due to varying degrees of cataract or pupil sizes. And to also look at validating this algorithm across other ethnicities to look at the generalizability of this model. Thank you so much for your patient listening.
Thank you so much for that talk. Our next speaker will be Leila Vazovic from Duke University, who will be speaking about the evaluation of pediatric wide field fundus photos using AI. Leila.
Thank you. Thank you, Ted. It's a pleasure to be here with all of you. What an amazing morning. I've definitely learned tremendously, and thank you for including me in this screening session. I'm privileged to work with an amazing pediatric retina group at Duke, and I would like to acknowledge a few individuals, particularly my amazing fellow Nita Valakrodad, who is really the power behind this presentation today, but really the work as well, including some of my collaborators, Cindy Toth, Shi Chen, and our biomedical engineering team led by Sina Farsu. These are my disclosures, and really none are relevant to this presentation today. I think we all have heard already about some of the amazing efforts that are happening in screening for patients with various diseases. And I think diabetic retinopathy is definitely on top of the list, one that patients would benefit the most, but definitely other diseases such as glaucoma, macular degeneration, Alzheimer's, for example, are definitely gaining traction. I know Sharon Fackert has done amazing work in that arena as well. Hypertension, stroke, and cardiovascular. Well, we hope to kind of employ these or get this more in the pediatric world. And there's been an amazing group done in ROP screening with telemedicine and AI inclusions there. But we hope to include this along the broader network or other patients in retinal diseases. We all know that it's a challenge to examine pediatric patients. This is definitely a well-behaved patient who's following direction, but often the challenges where you cannot really approach them much with a slit lamp, yet alone interact with a bright light. I find myself, along with my colleagues in our pediatric retinal clinic, using ultraviolet digital fundus photography as a way not only to document things, but really to identify pathology and screen patients when we cannot get a good look of the back part of the eye ourselves. So we find that there's a need for pediatric retinal screening for certain. And why is that? While the pediatric retinal diseases are rare and may not be as prevalent as diabetic retinopathy, as AMD, there's definitely a need for it. And I feel like with wide field imaging, we can diagnose things earlier and potentially refer these patients for further management and to prevent vision loss. And more so in pediatric patient population, I find that if we identify things early on, we're really saving vision for them for the rest of their life. So our efforts for that reason have been very much in the screening of pediatric patients. And our hypothesis is that an AI algorithm can accurately identify pathology on fundus photos and aid in early pediatric retinal disease screening. The purpose of our project, the very early project that we have ongoing currently, is to develop and evaluate AI algorithm for screening of these patients. The methods thus far have been retrospective study review from our pediatric retina clinics at Duke Eye Center, and the images thus far that have been used are from 2014 to 2020. And we're particularly using the opto-subdane images. The exclusion criteria has been very much systemic diseases, so other pathologies that may be contributing, and poor quality of images. And unfortunately, this is not an unusual story for pediatric patient. They're moving targets. The lid definitely will be in the way, and images can be of poor quality as well. We have reviewed all the images and data collection and labeled them as present of artifact, whether it is pathology in the posterior pole, and what abnormalities were seen, whether it be that retina, optic nerve vessels, or media itself. The reference standard diagnosis as a result was made from interpreting the images, but also very much from chart review and what the intending physician was labeling those images, what the dilated fundus exam was labeling, and then finally matching that with clinical diagnosis. We use the kind of standard methods to develop a novel convolutional network to help us really identify and screen these patients, and this is the output that was generated. Thus far, we have used 89 eyes for 71 patients, generating really quite a few images, 239 for this pediatric patient population. And you'll notice that most images were abnormal, 70%, 74% of them were, given the fact that these are the patients coming to pediatric retina specialists. And some of these images were normal with screening pathologies. And we had a very varied pathologies that were included, from retinal detachments to congenital conditions that patients present to our clinics for. And this is a preliminary analysis that we have for our algorithm. You'll note that it's performing quite well, not only in encounter, but also a specific image encounter. And this is not only specifying for specificity, but also precision overall. These are examples of some of the heat maps. Now, we would all love to have beautiful images in pediatric patients, but clearly that may be a challenge when we are imaging a 7-year-old or even more so a 3-year-old. But here's an example of a history of ROP patient, family history of fever, status force laser, and the heat map, according to our algorithm, you'll notice that it very much identified the pathology, the laser treated areas in this example. It also helped us identify other examples of, for example, Stickler's patient, identify pathologies, all that were present diffusely throughout the posterior pole. So in conclusion, we have very much a preliminary algorithm to help us identify and classify images as abnormal and what pathologies may be there present. And we hope to use this or demonstrate this as a screening tool for pediatric retinal diseases. What is some of our next adventures? Well, first, I want to mention what are the limitations of current algorithm is that there definitely are potentially discrepancies or missing data in the medical record. It is very much a small sample size. approaching the patients. Lots of these patients are being referred not just for retinal diseases, but systemic disease as well that may be contributing. There's a one grader, and quality of images are definitely a challenge. The future directions, we're increasing the number of graders and validating that for certain, approaching it with a blinded grader as well. We're working on increasing our sample size and collecting images not only from our clinics, but other clinics as well. And we are hoping to improve the quality of these images as well. The future directions and our ongoing research currently is to hope to apply this algorithm in screening, not only in ophthalmology offices, but actually pediatrician offices as well and schools. So that's our next step, is to really validate this algorithm in a real world setting for screening. I want to acknowledge everybody that's been involved in this project, and thank you so much for including me today.
Thank you, Leila. That was a great talk. Our final speaker in this session will be Dr. Darius Mashfigi at the Byers Eye Institute at Stanford, who will be speaking about scoring in ROP and other pediatric retinopathies to guide AI. And just as a reminder, please enter any questions into the Q&A below, and we will be moving on to the panel right after this. Darius.
Thank you, Ted. Good artists borrow, great ones steal, according to Picasso. And so from the ROP crowd, we look at the diabetes and all the data that's been out there and understand that to a large extent that this has been, I can't make it, there you go, driven by the ability to come up with scoring systems. I have numerous financial disclosures in this space, and at Stanford for the last 22 years. Do I drive up by the screen? I apologize. I just can't, I have a huge lag here. Okay, so at Stanford for the last 22 years, we've had no blind babies. And this is important because we're controlling 2% of the NICUs for ROP screening in the United States. And it's worth asking, is this by technique or expertise? And I think it's the technique overall. And the technique involves telemedicine, which is objective, longitudinal comparison, and a mandated screening interval on a weekly timeframe. And the question then becomes, is this teachable and is it scalable? And so one way to get to that is through an ROP scoring system. And one of the classic scoring systems is diabetic retinopathy scoring system. And in the diabetic retinopathy scoring system, they have scores ranging between 10 and 90 as the disease is getting worse. And it's based on photographic images that are standardized. And can someone tell me how to advance these slides? No. Okay. One of the beautiful things about the DRSS is it takes disparate features and it assigns them a point, and then those points result in tiers such as moderately severe, severe, and high risk over time. And that allows us to watch as the disease gets worse, and then as the disease improves or responds to treatment. In ROP, we have an activity score, and that uses a bundled approach where it takes zone, stage, and plus, and it gives you a tier value, but that leads to this counterintuitive situation where plus may have varying points depending on whether it's bundled with stage 1 or whether it's bundled with zone 2, and the same thing with stage 1. And this is kind of hard for us to overall conceptually understand. And it's not possible to unbundle the the ROP activity score. So one of the things that we wanted to do was develop a specific photographic ROP severity score for telemedicine use, and then ultimately as the backbone for an artificial intelligence model. And there's two differences between DRSS and a photographic score. One is features. In DRSS, they're either present or absent, whereas they're scaled in ROP. You can have zone ranging 1 to 3, stage ranging from 1 to 5. And then the second difference is the timing. In DRSS, it ranges anywhere from months to years, and in ROP severity score, it can be days to weeks. And then when we look at it, what are the features that we want to emphasize? We want to emphasize the features such as zone 1, plus, and stage, because those are the things that result in treatment warranted interventions. And so we gave them disproportionate values on our points and set up the whole scale such that anything 56 and above would result in a treatment warranted intervention on this scale. And we created tiers that correspond to levels of severity of disease, analogous to what we see in the photographic in the DRSS. We then studied this in the Sundrop cohort, and we were able to return a score 100% of the time using the photographic ROP score, but only 81% of the time using the ROP activity score. And then when it came time for identification of treatment warranted, again, 100% with the photographic score, but only about 70% of the time using the ROP activity score. And so as we're moving ahead as physicians, another thing we like to do is talk about, is my patient getting same, better, or worse? And we're dealing with 5 different retinal images from the back of the eye. And when we compare them, we say, is it same, better, or worse? And so one of the things that we did was set up a study with the hypothesis, the long-run study, that we make a direct image comparison with telemedicine is superior to drawings and recollection for the assessment of overall tempo. And we had numerous pediatric retina specialists from around the world. And then we gave them this very complex looking graph of 2 grader cohorts, 2 techniques, 2 patient sets with a crossover. So you were doing either simulated binocular indirect ophthalmoscopy or telemedicine side by side. And we were assessing for tempo on a very granular level for all the image sets. And this is what the image set looked like online when we were grading this. And overall, at the granular level, the hypothesis was rejected. And this may be because the graders were so good at grading. But when we looked at the pre-specified subgranular levels, such as within an image or features within an image, it was quite clear that telemedicine and binocular versus binocular indirect ophthalmoscopy was superior at identifying image and feature change on a very granular level. The next thing, when we looked at techniques, we saw that they were less likely to get fatigued over the 12 weeks using telemedicine. And interestingly, as we saw that as disease got worse, the disagreement worsened until it started to get really worse when we saw that they coalesced around treatment warranted intervention and started to agree again. Similar to what Pete and Paul have previously shown, there was extensive heterogeneity amongst the graders. And we saw that even within the techniques, there was extensive heterogeneity. So for AI, where numerous grading mechanisms have been approved for retinopathy, diabetic retinopathy, we're trying to look ahead and see what would be applicable for retinopathy of prematurity. It's a good target because we have to screen, and we know we have good treatments currently for this. And then we also know that what the triggers are for treatment, zone, stage, and plus. We have standardized photographs, very similar to diabetes. And then similarly, we have different approaches: predictive, a vascular severity score, an ROP activity score. And I'm going to kind of go right over the predictive scoring because it's not clear currently that using the totality of the data for screening that won't have a regulatory pathway. The vascular severity score only looks at the plus component of this, so it makes it very difficult to duplicate what a human is doing, which is assessing for zone and stage and plus in order to determine an intervention. But it would be very useful for guiding people towards detection of plus. I'm going to skip over my fever panel here and go all the way to my conclusions because I'm running out of time. And basically go back one slide here. I apologize for that. I can't go back 2 slides. In conclusion, say that the ROP screening is rapidly changing. Telemedicine allows for objective assessment, scaling, and normalization. and that a scoring system analogous to DRSS that incorporates all the features and that can be replicable by a human is important to get inside the black box of zone, stage, and plus and what the algorithm is doing. And then we will have something that could become commercially viable and potentially useful for our patients. Thank you for your time, and I apologize for my inability to run the slides.
Thank you very much, Darius, for that talk. Obviously approaching a very challenging area of teleretinal services. Let's bring everyone back to the virtual stage here for our panel discussion. I guess my first question will be for both Elliot and Darius. I think you have both been very successful in getting a retinopathy screening program off the ground, and you should be commended for that. And the performance is great, and the impact has been great. But with all the need out there for these types of services, what do you think the challenges are going to be for more widespread adoption of these services, Elliot?
Yeah, thanks a lot, Ted. Once again, I just have to give credit to so many people involved in this program. I wish I could say I single-handedly created Status, or maybe I don't, because it's great people that I've been working with. And David Myung, of course, was founder and architect of this program. But yeah, I think what's it going to take to have wider adoption? So like I mentioned, we have sites all over the Bay Area. So we're in a lot of locations. We're probably within 10 to 15 miles of most of the population of San Francisco and the surrounding neighborhoods. But at the primary care clinics where we're featured, about 5 to 10% of diabetic patients are screened with our technology. So there's a huge, 90+% that still haven't adopted that method for their diabetic retinopathy screening. And I think there can be a lot of reasons for that. I mean, one, not every area of medicine has as many early adopters as ophthalmology. I think we like new technology, working on adopting it, and also, diabetic retinopathy screening is within our wheelhouse. We've heard a lot of really advanced technologies today, but some of the issues that we face in the program are, really low tech issues. So I had mentioned that all of our photographs are non-mydriatic. We're not doing pharmacologic dilation of pupils. That comes from a few issues. One is the lingering concern about inducing angle closure from dilation, even with 1% tropicamide, which in very large studies has by and large been shown not to occur with 1% tropicamide. But there are other smaller issues like simply not having space in the clinic to have patients sit and dilate, not having the staff to monitor the patients while they're dilating, and also take care of the other tasks around the clinic. Then other scope of practice issues for the medical assistants, not being able to apply dilating drops, and not being concerned about releasing patients to drive home after dilation. So there are a lot of kind of very non-technical issues that get in the way of implementing this very advanced technology. So issues like that can be solved by education, just by sort of the technology baking in the community a little bit longer, and improving as the accuracy goes up. Patients believe in it more, and they ask for their doctors for it. Doctors believe in it more, and they feel good recommending it to their patients. And so I think a lot of it is just continuing to make a good name for the technology, and to meet doctors and patients where they are with this technology.
Yeah, I think a lot of those local level issues are barriers to adoption of technology. Darius, do you think there are any kind of like larger, bigger picture issues that prevent adoption?
Yeah, I mean, clearly the biggest problem is you have to be offering a turnkey solution. Like for ROP screening, a plus detection tool is not commercially viable product. They want something that replaces the grader. If they're paying for the camera, which is $100,000, they're paying for a photographer, which is $132,000. They're paying for a software package, which is $50,000. Now you're going to get an AI on top of that. The AI has to be a pass-through. In fact, the cameras have to be a pass-through. The camera price right now has to drop 90% to make it scalable on a much larger level. You know, the average contract right now takes about a year to sign. And this is, you know, I have 20 years of experience of signing telemedicine contracts, and that has not moved in the last, 20 years from the beginning till now. And the reason for it is that there's so much infrastructure that you have to front end in order to make this work. AI in a socialized medicine status, such as the United States, for a very specific indication, autonomous for ROP in the United States, is many years away, because the hurdles are too large commercially. Not forget the regulatory viewpoint, forget the camera viewpoint, just how do you get that out there and scale it? It's just not feasible today.
Yeah. We'll shift gears a little bit, Divya. I was really interested in seeing that the class activation maps that you put up earlier in your talk, and I think that's potentially another hurdle to adoption, is just the explainability of these, supposed black box solutions. And can you talk a little bit about what the response has been to having those images available to the people who are using your device?
Yep, great question, Dr. Leng. I think class activation maps are really useful, take us one step ahead to understand to some extent the black box nature of the algorithms. I think there are, one is explainability of the model to some extent, and two, we have also seen that using class activation maps with patients is some form of education, especially with an AI that can give an immediate response, just turning the camera around, showing the patient, these are the areas of abnormalities, sort of reinforces to them the importance of further management and referral, compared to what we have seen with without these class activation maps. I guess one part of the problem is screening. The next part of the problem is how do you actually move the patients from the place of screening into the ophthalmology care. So this sort of helps that way as well in reinforcing the areas of abnormality to patient to improve adherence to next steps in management.
Yeah, Yasha, I saw that you had some green highlighting of those OCTs, and to be honest, I couldn't tell which one was a normal eye and which one had moderate DR. What did you see from your studies as far as like the features on the OCTs that were being used by the machine to find, the delineation between different stages of DR?
Well, I think that's exactly some of the problems, right? Is that the algorithm can pick up something on the OCT, but we just don't know what exactly it is. And this group in Louisville used features that were really not intuitive to how we think about diabetic retinopathy. And so, in order for this to have explainability, in order to have application, we probably want to use some features that we can see. And that's why I think near-infrared imaging provides a much more explainable model for understanding diabetic retinopathy by OCT. Now, these other algorithms also, it's incredible. They're taking all the slices and they're putting them through, and they're identifying subtle features on sort of cross-sectional imaging. But I think there's probably a slightly simpler way by just using the on-FOSS image as the alternative.
Thank you, Yasha. We're running short on time, so my last comment will be from Leila. I think working with pediatric images is difficult inherently because of the image quality. And I applaud you and your team for trying to train models and do work with real world images, which is, was addressed earlier in this meeting as a huge need, and not just using really nice, clean clinical trial images for everything. Have you found that to be a large detractor in the progress of your work as far as getting good images, or are you actually finding that to be a resource to be using images that are not ideal?
Ted, you point out exact challenge that we face, especially in pediatric patients. Not only are they poor quality, but a lot of data points are potentially missing. So really training algorithms to read whatever information we have is really our goal, because we ultimately hope to, even if it's not most perfect image or most complete image, to at least gain some information from it to help us identify patients early on. I think in my pediatric retina clinics, I'm seeing more and more patients with earlier diagnosis, and it's because our community has wide field imaging out there that is being used in optometrist offices. And I'm always excited when the early diagnosis does take place of a patient, for example, with Coates disease. So I think all of the impetus has been related to that to really help us identify early, but it's the biggest challenge. And yes, definitely ongoing work, and we can hope to continue it.
Thank you so much. Well, I'd like to thank all of our speakers and panelists here from the fourth session. And before we move on to our fifth session, which will be moderated by Dr. Jennifer Lim, we'd like to have a quick word from one of our sponsors, Regeneron, and we thank them for their support.
Hello, I'm Kevin Clark, Vice President, Ophthalmology at Regeneron. For nearly 35 years, Regeneron has used the power of science to bring new medicines to patients. Our scientists build the medicines of tomorrow, marrying cutting-edge technology and biology to revolutionize how we target and treat serious diseases. At the heart of our science is a commitment to developing life-changing medicines for people who need them. Our ophthalmology franchise is the manifestation of our work towards that commitment. But we're not done. Scientists and researchers in our ophthalmology franchise continue to explore a broad range of therapeutic areas with a long-term focus on discovering and developing additional important medicines. At Regeneron, we follow the science to solve the human body's most complex mysteries. From our rapid response efforts to infectious disease, to the complex world of oncology. We've invented new technologies and pioneered novel approaches to revolutionize how we make medicine. I'm incredibly proud to work at a company who is continuing to innovate clinically and in new ways to support both patients and the retina community.
Welcome to session 5 of the OAI meeting. It's really my pleasure to have you here today. Our first speaker is a medical student, Dr. Abed Bayad, who will be speaking on applications of AI for the conduction of large-scale systematic reviews and meta-analysis. He's a medical student at McGill University. Welcome, Abed.
Thank you, Dr. Lim. So I'll get started. So hi, everyone. My name is Abed, and I'm a third-year medical student at McGill University. And today we'd like to present a study on the application of AI for the conduction of large-scale systematic reviews and meta-analyses. Just trying to switch to the next slide. Oh. So I have no financial disclosures to declare, which is not a surprise given my stage of training. So over the past few years, we have been seeing increasing use of AI in a variety of medical settings and clinical applications. We sought to explore the diagnostic accuracy of AI in ophthalmology through a systematic review and meta-analysis involving a large number of articles. And we thought, why don't we use AI to help us screen through thousands of articles? So we used Distiller from Evidence Partners in Ottawa, Canada, to assist us with this task. Distiller is a systematic review software that is widely used and that can utilize machine learning to automate part of the screening process as adjunct to human graders. In Distiller, machine learning can be utilized to automate screening of articles, and its sensitivity and specificity have been demonstrated in studies published previously in the literature. So the aim of this study is to develop a protocol for the application of AI in systematic reviews and meta-analyses involving large volumes of articles. So we searched the literature on Medline and based on Cochrane libraries for articles that report on the diagnostic accuracy of AI in various diseases in ophthalmology. We included articles that compared AI performance to human graders, and we excluded reviews, case series, abstracts, etc. And due to the large number of anticipated studies from a search, we aim to use Distiller to aid with screening. We would start doing this by creating a training set where 2 reviewers manually screen at least 1,500 articles. Then Distiller AI software will recognize the patterns and keywords used for screening that can be applied to the remainder of articles that are yet to be screened. Once we have that training set, a relevance threshold can be set to control the strictness of screening while we conduct manual checks to ensure that the AI is accurately including or excluding the articles. So to illustrate this, 2 human reviewers would screen about 2,000 articles to make up the training set. And then for the test data set, we'd have 1 human screener screen 500 articles with Distiller AI serving as the second screener. Then we would look at the agreement rate and the threshold between the AI and that human grader. And then based on that, we create a second test set and evaluate the performance of AI screening through those test data sets, and then decide if you would like to apply AI to the remainder of the 12,000 articles or so to aid us with the screening. So when we come to our results, when we did the literature search, we identified 15,346 articles with 2,000 articles comprising the training set. Now, when we did round 1 of applying AI to the test data set of 500 articles, there was an agreement rate of 90.2% between the AI and the human screener. And when we ran the AI for a second round on a test set of 500 articles, there was an agreement rate between the AI of Distiller and the human grader of 95.2%.
Webinar.
So when we applied the AI to the remaining 12,000 or so articles, we had this distribution of the threshold scores. So Distiller AI trains itself using a percentage of manually reviewed references. Then it applies this learning to unreviewed references and makes a prediction. Distiller AI will attribute a score to each reference based on how likely it thinks it is to be included for each article. So when the AI is run, scores will be generated that will range from 0 to 1. 0 indicates a high confidence of exclusion, where 1 indicates a high confidence of inclusion. The closer the score is to 0.5, the less confident the prediction is. So we set a more generous threshold of 0.2, and this decision was balanced by a fact that we wanted a conservative threshold, recognizing that AI would not be perfect, or otherwise a perfect algorithm would have a 0.5 threshold and we would choose a lower value. So when we applied AI with a threshold that was manually imposed at 0.2, it identified 2,236 articles that were classified as included. And then, so to kind of as an overview of the 15,000 or so articles, 3,000 were manually graded by humans, and the remaining articles were graded by AI, which included 2,236 articles. So after the application of AI, 2 reviewers will screen 2,236 marked as included by the AI. Meanwhile, 10,110 articles were automatically excluded by the AI, which would translate to 15,165 minutes, or approximately 252 hours saved, thanks to the use of AI. So in terms of the next steps, a human grader will screen 2,236 Distiller AI included articles based on the new 0.2 threshold that we set. Then we will run the AI again to see any difference in the threshold, aiming for a score of above 0.2, which is based on the score of the included studies. Or in other words, if all of the studies included in our review get a score of above 0.2, we will not need to update that threshold score, and we can fairly trust that the AI made the right decision in including these articles. So in conclusion, the study establishes a protocol and parameters needed for using AI to screen a large number of articles. And our findings highlight that the potential value and feasibility of implementing AI in conducting large-scale literature review studies, such as systematic reviews and meta-analyses. Thank you.
Thank you so much, Abed, for that fascinating talk. We'll discuss it shortly after we hear the rest of the talks for this session. It's my pleasure now to introduce our next speaker, who is also a medical student, Jonathan Zhao from the University of Toronto, and speaking with him is Dr. Patathil from Queen's University. They will be presenting a talk on randomized controlled trials of AI applications in ophthalmology. Jonathan?
Hi, yeah, thank you so much for that introduction, Dr. Lim. Once again, my name's Jonathan. I'm a second-year medical student at the University of Toronto. Today, I'm joined by my colleague Nivi, and we are super happy and thankful to be here today, and we're excited to talk about some of the work that we did with Dr. Sam Oyurende and Dr. Tina Felfeli. Nivi, take it away.
Awesome. Thank you so much, Jonathan. And thank you everyone for being here with us today. We're excited to tell you about our study. So I'll get into our introduction here. Right. So as we all know, within ophthalmology over the past decade or so, there has been a significant interest in exploring the potential of deep learning and artificial intelligence, which has led to a variety of AI-linked RCTs being produced across various fields in ophthalmology. And this is, of course, because RCTs are the gold standard for assessing new interventions and for studying their efficacy and safety. However, the level of the quality of the RCTs that are currently published on the efficacy of these AI-driven interventions is not quite known. And this is where Concert AI comes in. So Concert AI is a set of guidelines that provides a checklist of recommendations for high quality reporting for RCTs, specifically looking at AI. And it has a set of domains across title and abstract, intro, methods, randomization, results, discussion, and then other certain topics. And it helps people within this field sort of adhere to a set of reporting guidelines, ensuring high quality reporting. So if we look at why we should even follow Concert AI, it's for four main reasons. It allows for transparent and consistent reporting across RCTs. It helps to minimize potential bias, promotes trustworthiness and therefore the generalizability of results, and allows for easier comparison between studies, which helps facilitate critical appraisal as well as greater evidence synthesis within the field. So with this project, our aim was to conduct a systematic review to evaluate the reporting quality of RCTs on AI and looking at what the field has so far, sort of mapping out what is there, and then also looking at how well these RCTs adhere to the Concert AI reporting guideline.
Yeah, so in terms of methods, we did a comprehensive search of Medline, Embase, Cochrane Central Register of Controlled Trials, and Cochrane Database of Systematic Reviews. We looked for English articles that were published between January 1st, 2010 and February 5th, 2022, that were RCTs that used AI in their main intervention in the setting of ophthalmology. And we assessed these final retrieved articles using Concert AI as well as the Cochrane Risk of Bias tool.
So after completing our initial search, we had 2,973 citations. After completing all of our screening, we had 5 articles included in the final review. So looking at these 5 articles, they were across multiple fields within ophthalmology. We had papers looking at diagnosing childhood cataracts by Lin in 2019. Wu 2020 looked at comparing AI problem-based learning versus traditional didactic lectures on pediatric cataracts. Xu 2021 evaluated a CNN-based AI for assisting ophthalmologists in detecting fungal keratitis. And then our last 2 papers here looked at diabetic retinopathy screening, Noriega 2021 and Matenige 2022. So looking at the overall adherence to Concert AI in our 5 papers here, the range was from 37% all the way to 78%. And the mean overall Concert AI score in our review here was 53%, with a median score of 49%.
Okay, so in this slide, you'll see a breakdown of the Concert AI domains for each of the 5 articles that were retrieved. So you can see that for the title and abstract and introduction sections, most of the items were very well reported. Starting in the method section, some of the items that were commonly missed include the version of the AI algorithms that they were using and details of human AI interactions in the handling of input data. Regarding randomization, how randomization was implemented, who did the randomization, and reporting of who was blinded to the assignment of interventions were also very commonly missed items. And finally, in results, some of the most commonly missed criteria were harms or unintended effects in each group and analysis of performance errors.
And then looking at the risk of bias in our studies using the ROB2 tool. So all of our included articles had an overall moderate risk of bias. All of the articles scored moderate risk for selection of the reported result, as well as deviations from the intended interventions. And all of our articles were low risk for the domains of outcome measurement, as well as missing outcome data and reporting here. For the randomization process domain, 80% of our articles were moderate risk and the remainder were low risk. And none of our articles scored high risk in any domains.
Yeah, so next I want to go over some of the, I'm just going to go back to the previous slide. We're going to go over some of the interesting observations that we made as we conducted this study. So the first is that we think that the Consort AI guidelines are somewhat limited in the sense that not all criteria are applicable to every study. So for example, in 2 of the RCTs, they compared ophthalmologists without AI assistance to ophthalmologists with AI assistance. So in this setting, it's not really possible to blind the ophthalmologist to what the intervention is. And in these papers, the blinding items were not reported, but that's not necessarily an indication of a limitation of that RCT or of that paper. Other interesting things we noticed were that none of the papers actually included links to the trial protocols, and we think this is important because it could indicate a potential source of bias if analysis decisions were made after outcomes were measured. And another trend that we noticed is that none of the papers actually included links to AI code. And so open access to code, obviously, we think is very important in terms of helping other research groups to reproduce past research and to be able to build on what's being done. So that could be an important barrier. And finally, there were criteria that concern the generalizability of these studies that were generally well adhered to, but not perfectly. And we still think we wanted to highlight this because we feel like these criteria are just so important because these are the criteria that clinicians would probably look to when deciding whether or not an AI intervention applies to their practice. So we think that these criteria should ideally always be reported. And so in conclusion, just waiting for the slide, but in conclusion, this study found that there are very few RCTs that investigate AI in ophthalmology. All the papers that we found have some concerns regarding risk of bias, particularly resulting from the 3 domains of randomization, deviations from intended interventions, and selections of reported results. And finally, adherence to Consort AI is suboptimal. Like we mentioned in the previous slide, it's not always a bad thing, and there are nuances to this, but in general, low adherence may hinder reproducibility and future progress in the field.
So just to end off here, these are our final recommendations for people conducting RCTs within AI and ophthalmology. So to register your protocols and provide information about this, and providing information about blinding procedures, as Jonathan described, to help reduce risk of bias. To improve reproducibility, we recommend including information about the AI code and where this can be found, as well as software version information. To improve generalizability, including information about sample size calculations, the baseline demographic data, and where trial data was collected. Overall, when in doubt, follow Consort AI. So thank you so much for having us. Thank you for your attention. We want to thank our supervisors, Dr. Felfelli and Dr. Samuel Yorinde, for their support and guidance. And thank you again to the organizers for having us.
Thank you so much.
Thank you so much, Jonathan and Dr. Patahill, for that very insightful presentation. Our next speaker is Dr. Laura Gallego from the Universidad Nacional de Colombia in Bogota, and she'll speak on biomarkers of RVO using a deep learning strategy applied to images obtained by OCTA. Dr. Gallego.
Thank you. Hello, everybody. My name is Juliana Gallego from Bogota, Colombia. It's a pleasure and a great honor to participate in this wonderful summit. My talk title today is Biomarkers of RVO using a deep learning strategy applied to images obtained by OCT and geography. I would like to present my group and express my gratitude for their hard work and dedication in this research. I have no conflict of interest. Let's start the discussion of venous occlusion. The venous occlusion is of paramount importance due to the significant impact. This particular retinal vascular disorder represents the second most frequently encountered condition of its kind, following only diabetic retinopathy in terms of prevalence. This condition is known to result in diminished visual acuity, often accompanied by complications such as macular edema, retinal ischemia, and secondary neovascularization. In general, several risk factors are important. The prevalence of this disease is very important. The branch retinal occlusion is more frequently compared with central retinal vein occlusion. In Japan, the prevalence is higher. We don't have sex predilection in this disease. In this systematic review and meta-analysis, we see an important number of people that have retinal vein occlusion. The branch retinal vein occlusion is more frequently. And the incidence of this disease, we can see in this image, in this systematic review, is important at 5 years and at 10 years of accumulated incidence. Several risk factors include age, above 40 years, atherosclerosis, systemic arterial hypertension, and diabetes have been described. Certain factors have been found to be more commonly associated with central vein occlusion, while others with branch occlusion. However, further investigation and discussion are necessary in this regard. The significance of the association with cardiovascular events and mortality is noteworthy, as evidenced by a statistically significant relative risk observed for all-cause mortality. There is a higher risk for stroke, myocardial infarction, heart failure, and peripheral arterial disease, as we see in this on the next slide. To continue, optical coherence tomography and geography has emerged as a non-invasive imaging modality. And the research on RVO is quite minor compared to the abundant studies on diabetic retinopathy. Some good things of OCTA is non-invasive imaging modality for visualizing the microvasculature of the retina and cortex. In the context of venous occlusion, certain qualitative and quantitative changes have been reported. We can see some general explanation how OCTA works. We can continue to the next slide. The investigation in RPO with OCT, we can see some important qualitative and quantitative information like macular edema, intraretinal fluid, subretinal fluid, and is ideal in diagnosis and follow-up. And we can see, as in the slide, the therapeutic guidance of this study. In OCTA, we can see some qualitative and quantitative change. The qualitative change include no known perfusion areas. There are regions with no visible perfused capillaries. In RPO, they are more extensive in the deep capillar plexus than in superficial capillar plexus, and are more visible with OCTA than with classic angiography. Vascular tortuosity includes twisting, angulation, and or spiraling of the vessels. Tortuosity is observed in both central and Brachian occlusion. Systolic space are more frequently seen and may have a prognostic value. This phenomenon manifests as long vessels traversing the perfusion blocked area, or as a group of tortuous vessels in malignancy of the perfusion block area. The perifoveal capillar plexus is distorted in ischemic maculopathies, including RPO, and we can see some disruption of the foveal avascular zone is common. Other change like microaneurysm and neovascularization is important in the study of RPO in OCTA. Some quantitative change like avascular zone metrics like the area and the index of acircularity have been described. We can see some measures in health individuals, and in persons with RPO, these measures change. We can see here the difference of a good circularity and a bad circularity. And non-perfusion areas, the quantification of this is a factor associated with visual acuity and macular sensitivity in microperimetry in eyes with RPO. Lack of perfusion in both plexuses was significantly correlated with lack of peripheral perfusion. You can see the percent of vascular density. It's too important, the calculation of level of the two plexus, superficial and deep, and the quadrant reporting is classic report, as we see in the next image, in the report of OCTA. This is an example. It's a revolutionary tool in diagnosis and treatment of retinal vascular disease. It's rapidly growing clinical research impact. And with the artificial intelligence, we pose to develop a project to create an automated algorithm for the detection of biomarkers in retinal vein occlusions in OCTA image. The scans were obtained from data repositories of ophthalmological centers in the country. Image of superficial, deep, and phase choriocapillary and outer retinal choroid plexuses were taken from 254 patients with retinal vein occlusion. Inclusion and exclusion criteria were considered. The biomarkers were coded as labels, and using label box digital segmentation, the findings were marked with different colors for each of them in each image acquired and destined for this phase. Finally, in the test phase, the performance of model was estimated by calculating the detection rate and the Jacquard index, we see in the next slide. Here, the detection rate is defined as the fraction of all images who have disease and are called positive by tests. And the Jacquard index compares members for two sets to see which members are shared and which are distinct. It's a measure of similarity of the two sets of data. For the first biomarker, an alteration of the peripheral capillary plexus, the detection rate was 93%, and the Jacquard index 0.85. We see in the image examples of OCTA image, its initial mask and the one predicted by the algorithm. The areas of no perfusion, the detection were 92% with a Jacquard index of 0.70. With systole space, the detection were 84% and a Jacquard index of 0.73. And finally, for vascular tortuosity, the detection rate was 91% and a Jacquard index of 0.72. At this graphic, we can see the measures of central tendency and dispersion of the Jacquard index for each one of the biomarkers, noting that they all achieve a good performance. We consider in this project some limitation. First, relative new imaging mode. There is a limitation in data sets available of OCTA. We need an external validation. It's essential to assess the performance of the model on a new previously unseen data. And the data set of a single demographic group may introduce bias, and therefore it's necessary to collect multi-center data to ensure a more diverse and representative sample. As conclusions, the performance of algorithm based on the percentage of alteration detection and Jacquard index are comparable with the current state of art, with limitation given the scan information. And we highlight this work as one of the first to make use of artificial intelligence in retinal vein occlusion since OCTA image. This work offers an initial architecture that can be fed by representing multiple multi-center centers, feeding with a great number of images and expert readers, so it can have better diagnostic behavior and be more easily extrapolated to different population groups. Thank you.
Thank you, Dr. Gallego, for sharing your model with us and reviewing the OCTA biomarkers. Our next speaker will be Dr. Zineb Farahat from the National Mining School of Rabat, Morocco, and she'll be speaking on DR screening using AI. Dr. Farahat?
As Dr. Lim said, my name is Zineb Farahat. I'm a PhD candidate in the Mine School of Rabat, and I'm head of technical department of the Medical Simulation Center of Sheikh Zayed Foundation. So, excuse me, can you hear me?
We can hear you.
Yes. So I'll talk about diabetic retinopathy screening using artificial intelligence. I'll first start by an introduction where I will talk about my problematic, and then I'll present to you results obtained using image segmentation techniques and image detection techniques. Okay, so 422 million of people worldwide suffered from diabetes in the year 2021. And according to the latest statistics, 537 people suffers from it in 2023, and this number will increase to 600 million of diabetics by the year 2040, according to the World Health Organization. Oh, sorry. So our study was applied to Moroccan population. So again, according to the World Health Organization, the prevalence of diabetes in Morocco is 12.4%. And this percentage continues to improve due to different factors, such as sedentary and lifestyle of citizens. One of the main applications of diabetes is diabetic retinopathy. So it is responsible for 2.6% of global blindness, since it affects the eyes mainly. 30% of working age adults with diabetes suffer from diabetic retinopathy. And for all of these reasons, a routine screening and annual surveillance is mandatory in order to avoid blindness. So here we have two color fundus images. The first one is a normal or a healthy color fundus image, and the second one is an eye affected by diabetic retinopathy. So as you can see here, we have hemorrhages and exudates. So the problematic of our project was that several remote areas suffer from a lack of ophthalmologists. I think that I have a small problem with animations, but no problem. So as I said, several remote areas suffer from lack of ophthalmologists, and for this reason, the Sheikh Zayed Foundation organized generally different caravans in order to help patients or to screen diabetic retinopathy and other ophthalmic pathologies. But with all of these efforts, or even if they make all of these efforts, the number of ophthalmologists remain very insufficient. And for this reason, our main objective is to propose an appropriate solution for the automatic screening of diabetic retinopathy. And that's why we decided to use artificial intelligence. So we used both machine learning and deep learning. And finally, we chose to work with both methods that are image segmentation and image detection. So I'll show you later on the results obtained by both of them. And in order to train both image segmentation and image detection models, we use the local data sets of 1,000 color fundus images. And I would like to precise that our study is approved by the Ethics Committee of Sheikh Zayed International University Hospital. So using image segmentation, or using specifically the unit architecture that is presented in front of you. So as you can see, we have different layers of max pooling and convolution. We started by creating masks, which are labels. So in order to make the computer learn more about the disease that we're trying to detect, we had to give him or to give it questions and answers. So for each of the diabetic retinopathy signs presented in the 1000 color fundus images, we created manually labels. So as you can see for example, for specific spots of hemorrhage, we created a white spots on a black background. We did the same thing for the other signs. And then we obtained different masks for all of the images used. So what we did is that we created a model that receives as an input a fundus image, and then with the multi-class segmentation model, it gives us either a no answer, which is an output that is in grayscale, or yes answer, which means presence of diabetic retinopathy, which is a grayscale image with green spots or red spots, which means that on hemorrhages, we will have green spots, and on exudates, we will have red spots. I'll show you examples in order to make it very clear for you. So for the first case, which is a healthy color fundus image, when we give an input of color fundus image, we will have a grayscale image. For case 2, which is color fundus image affected by diabetic retinopathy, you will have exudates highlighted in red and hemorrhages highlighted in green. For the third case, which is the novelty of our project, is that the model can also recognize the laser impacts. So as you can see, it will only detect the exudates and highlighted them in a red color, and the hemorrhages and highlighted them in green color. So the second technique that we used is image detection. Here again, we created masks manually, as you can see, but this time in a text format and not image format. And as results, for healthy color fundus image this time, as an output of our model, it gives the same image that we have in the input without any changes. For the second case, which is color fundus image affected by diabetic retinopathy, we will have as an output pink bounding boxes around hemorrhages and red bounding boxes around exudates. And for the color fundus images with laser impacts, here again is only the text, the exudates, and hemorrhages too. So in order to summarize the work done using image detection technique, this created model receives as an input a color fundus image. Using a YOLO V5 model, which is an image detection model, it will either show the same image with the absence of bounding boxes in case of absence of diabetic retinopathy, or it will show the same image with bounding boxes or with red bounding boxes around exudates and pink bounding boxes around hemorrhages. So in order to make the use of the created models easier for the medical team, we created a graphic interface in order to have a full software. So we called our software Abulqasis DRAI detection software. So as you can see on our software, you can put the patient name, the date, you can add comments, and then the software automatically detects, as you can see, the signs and puts bounding boxes around them. And after this, you can download your full report. It can also add the comments that you put and count automatically the number of hemorrhages and exudates too. So to conclude, with the increasing of diabetic population and the growing gap between demand and supply of trained resources, AI is the future for early identification of diabetic retinopathy and reduction of blindness. So here we aim to use this tool in caravans in order to improve telescreening, optimize patients' flow within healthcare buildings, and help patients who does not really need to see an expert doctor to save travel expenses. Further investigations are being carried out in order to create a DR severity classification system.
Thank you for sharing this model with us, Dr. Varahat. Our next speaker is Dr. Rita Vaught from Rutgers, New Jersey Medical School, who will be speaking on retinal sheen impact on AI readings in type 1 diabetic retinopathy. Dr. Vaught.
Thank you, Dr. Lim. Hello, everyone. Thank you all for being here today. My name is Rita, and I'm a third-year medical student at Rutgers, New Jersey Medical School in Newark, New Jersey. So my project is on the retinal sheen impact on artificial intelligence readings in patients with type 1 diabetes and who have retinopathy. So type 1 diabetes is a chronic disease that leads to retinopathy when glucose levels are not under control. And I want to highlight the prevalence of diabetes in the United States. In 2019, almost 2 million Americans had type 1 diabetes, and this is increasing every year. I also want to highlight that patients who are diagnosed with type 1 diabetes are usually diagnosed at a much younger age than type 2 diabetes. The most frequent age at diagnosis is 13 to 14 years old, whereas type 2 diabetes is mostly diagnosed after the age of 45. And if left uncontrolled, diabetes can lead to diabetic retinopathy, where high glucose levels lead to damage that damages vessels in the retina. So the American Diabetes Association has recommendations for retinal screenings in patients with type 1. They recommend that at the time of diagnosis that patients undergo a dilated exam or retinal imaging. And after the initial diagnosis, they are recommended to go either annual screenings if there is retinopathy, or biannual screenings if they have DR, but they are under good glycemic control. And the goal of this is to have early detection and also to intervene in disease stages that are early and to provide treatment early. So due to the increase in prevalence of type 1, as well as the early age of onset, there is an increasing demand for artificial intelligence that can detect diabetic retinopathy. And one of these artificial intelligence softwares that are available is iArt, which is developed by iNook in California. And it is an FDA-approved artificial intelligence that can detect DR. Some benefits of this artificial intelligence is that it can generate a report in less than 1 minute. It also classifies the presence and severity of the diabetic retinopathy, and it doesn't require dilation for the exam. Some limitations are that it only detects DR and does not detect any other pathologies. And it also requires 2 images per eye, 1 macula-centered and 1 optic nerve-centered, in order to generate the report. So the reason why this project came about is that individuals with type 1 often have retinopathy as early as 10 years post-onset of their diagnosis. However, young patients' eyes also are known to have ocular sheen, which may be confused by artificial intelligence as retinal hemorrhages. And so the purpose of this study was to evaluate the impact of retinal sheen on the AI detection of DR in these patients with type 1 diabetes. So the way that iArt is deployed is that it requires a device that is compatible with the software. And the one that we use is the Canon non-mydriatic retinal camera. These images taken from the camera are uploaded to the iArt cloud-based server, and it generates a report without an ophthalmologist needed on site for interpretation of images. So here I have two examples of an output from the iArt software. On the left, this is an example of a patient who does not have retinopathy. And on the right, it detects the presence of more than mild DR as well as visioning threatening DR. And this is how the output would look like, which we would provide to patients. So each year, Rutgers, New Jersey Medical School sends a team of medical students and physicians to Florida to attend the Children with Diabetes Friends for Life conference. And here are some images from the most recent screening in July of 2022. Many individuals who attend these screenings have been attending for many years since they were children and are now adults. At these screenings, patients will undergo imaging as well as telerobotic consultations with a physician from Rutgers if they have retinopathy or need any type of consultation. So we provide those on-site from Florida so that they are able to see a physician from New Jersey. And so the way that we did the study is that we retrospectively reviewed these images from attendees of the conference who had type 1 diabetes. We excluded patients who had co-occurring vision-threatening diseases or any other type of pathology. And we also only looked at patients who were over the age of 18 since iArt is only FDA approved for individuals over 18 years old. We generated the reports by uploading images to iArt and excluded images that were ungradable, and then we independently had those images graded by a human grader. And so for our referral criteria, we had a human grader either determine whether or not the patient needed to be referred or not. And we equated these to the following statements that were generated from the iArt output. So more than mild DR or vision threatening DR was a referral, and any negative for more than mild DR or negative for vision threatening DR was considered not a referral. And we used the free marginal kappa analysis to determine if there was concordance between the referral by the human grader as well as the AI. So in 52 eyes, we identified 34 patients who had retinal sheen and 18 individuals who did not have retinal sheen, all of which were over the age of 18. The average ages were 23 and 50 years old, respectively. So we determined that when retinal sheen was present, the kappa value for concordance was 0.76, and the overall percentage of agreement was 88%. When retinal sheen was not present, the kappa value for concordance was 0.89, and the overall percentage of agreement was 94%. And out of the disconcordant cases where the AI disagreed with the human grader, we found that there were much more false positives when retinal sheen was present than without. And we wanted to also compare this to the iArt reported accuracy on their website, which is 91.2%. And this is consistent with their findings that when retinal sheen is present, it decreases the overall agreement. And when retinal sheen is absent, the overall agreement increases. So we found that AI has an overall high agreement with the human grader in the presence of type 1 diabetic retinopathy. Accuracy does decrease in the presence of retinal sheen, and the majority of misdiagnosis cases are cases where retinal sheen is present and there are false positive readings. So this does agree with our objective in determining that retinal sheen could have an impact on the AI's ability to detect DR. And we do find that AI has tremendous potential in aiding physicians in detecting DR, especially in patients with type 1, and it is very critical for patients to have this available so that they can undergo counseling and treatment when necessary. We do want to point out that reports for young patients with type 1 diabetes may need to be interpreted with caution. So for the future directions of the study, we want to further implement AI in community-based screenings as we have done thus far. We also want to expand artificial intelligence to other clinical settings such as the emergency department and Department of Endocrinology, where an ophthalmologist may not be available. This would allow patients to have the opportunity to have a consultation or with an ophthalmologist, or to have a artificial intelligence outputted reading of their images without an ophthalmologist present. We also want to highlight that there can be improvements made to current AI systems. One example is to detect multiple pathologies, which this current AI system does not do. Again, I want to thank you all for being here today. Thank you.
Thank you for sharing your nice work with us, Rita. Our next speaker is Dr. Xincheng Yao from the University of Illinois, and he will speak on data fusion in deep learning OCTA, segmentation and classification. Xincheng?
Hello, can you hear me, Jenny?
Yes, we can hear you.
Great, thank you, Jenny. Today I will talk about the data fusion in deep learning OCTA segmentation and classification. How can I control the slide?
Arrow right.
Yeah, control. Okay, so we did some practice for machine learning and deep learning for OCTA classification, particularly for diabetic retinopathy. So as we know, OCTA, consists of multiple layer information as provide 3D image information. That means can provide depth resolved information. For example, like the superficial retinal layer, deeper retinal layer, and also choroid layer. How to combine the layer information, for the deep learning, can be important because different layer can reflect different aspect of the eye condition. Next one. Okay, we use the well-established CN classifier, for DR detection and classification. First, we try to use the individual layer input, like superficial layer, deep layer, and choroid layer for the DR classification. So from the table, we can see basically, the classification performance using the individual OCTA layer. If we pay attention to the number, the superficial retinal layer show the best performance if we compare, 3-layer information, for the deep learning classification performance. If we pay attention to the activation map, show the right part, we can see the 3 different layers. If we pay attention to the spatial pattern, they show different. So that means there is the spatial sensitivity, for the DR detection and classification. So how to combine the spatial, information from different layers together, can be interesting and important, for the deep learning, performance of the OCTA classification. Okay, go next. Yeah, in order to check, the fusion option, we test the early fusion, interfusion, and later fusion. For the early fusion, so we combine, the 3-layer information together before the feature extraction. For interfusion, the feature extraction was conducted, separately from 3 layers. Then, after the feature extraction, 3-layer information will combine together for following classification performance. For later fusion, the classification can also be conducted separately with 3-layer information, but at the decision level, we combine 3-layer information together. Next one. If we pay attention, to the performance, we can see interfusion show better, performance compared to early fusion and later fusion. Again, if we pay attention to the activation map, the top, 3 images show the early fusion, middle one show the interfusion, and then, later fusion. If we pay attention to the spatial pattern, we can see for interfusion and, later fusion, the activation map at the superficial layer and deep layer, they are very similar. For the choroid layer, they show some different, but still reasonably similar. But if we compare the activation maps at the early fusion layer, we can see they are very different from interfusion and later fusion. For the early fusion, we combine the 3-layer information before the feature extraction. Because the different layers, they may have different, vascular structure that will reflect the different information of the eye condition. Probably, before feature extraction, if we combine 3 layers directly together, the spatial correlation might be lost. That means there's some confusion for deep learning algorithm, to effectively use the spatial information at the 3 different layers. So that, may be the reason why early fusion is worse compared to interfusion and late fusion. Go next one. Okay, this is the comparative illustration of the multiple fusion option, including individual layer input and early fusion, interfusion, and later fusion. So we can see again, interfusion strategy show the best performance for deep learning detection and classification. And then later fusion is slightly worse compared to interfusion. For the individual layer input, superficial layer is the best. Next one. In addition, to the deep learning classification for the DR classification using OCTA, we also try to build an AVNet for differential artery and vein classification. So differential AV analysis can be important because the arterial and venous system can be affected by different disease or even different states of the same eye condition. For this, we also test the different fusion strategy to check the AV segmentation performance in OCTA. We tested OCT only input, OCTA only input, early fusion, and later fusion, so that we combine OCT and OCTA information together for the AV segmentation. If we pay attention to the example outcome, we can see for OCT only input, we can only segment large branch. That's readily reflected by the OCT image itself. In OCT, we can only see large branch without the microcapillary detail. If we use OCTA as the input or early fusion, later fusion to combine OCT and OCTA, we can get more detail of the vascular structure. If we pay attention to the overall accuracy for different input strategy, the OCT only input, we can achieve like 88% accuracy. OCTA early fusion and later fusion, we can get 95 or 96% accuracy. If we pay attention to the detailed number, we can see OCTA only input is only slightly worse compared to later fusion and even better than the early fusion. So that's the suggests the OCTA itself can already show the high contrast image of the blood vessel. Probably OCT input is not necessary. So that's when OCTA itself may provide sufficient information for reliable AV segmentation. Okay, go next one. Okay. So we also checked, 6mm OCTA, 3mm OCTA, to check the AV segmentation quality. Using 3mm OCTA, we can offer the better, sampling resolution. So we can see, using the 3mm OCTA, we can segment the AV systems, up to the microcapillary level nearby the, macular region. Okay, in summary, the layer fusion option can affect the deep learning performance for DR detection and classification. For single layer input, The superficial layer, show the best performance for their detection and classification. For multi-layer input, the interfusion shows the best performance. For AV segmentation, the later fusion show the best performance, but the OCTA only input, is only slightly worse compared to the later fusion. That means OCTA only input may provide enough information for reliable AV segmentation in the OCTA. Thank you for your attention.
Thank you so much, Sunshine, for that wonderful detailed presentation. I'd like to invite back now all of our speakers who did a great job, and we'll go ahead and start our discussion. So while everybody's turning on their camera, Sunshine, since you just finished, how soon do you think this is going to be available for clinicians? Is this something that we're going to be able to do in the clinic? How long does it take? What is your thought on that?
Yeah, that's the good question. We can, like, for this project, we have been, closely working together, right? I mean, my next plan is just, in fact, we already, when we published the data or result, we already keep it, at open access, algorithm. So that's mean, if any people interested, if they can access, to the code, we can help, for other people to use. Yeah.
Okay, so we'll see if people listening on this call today will email you at xcy@uic.edu and try to use the open source and see how applicable it is. I'd like now to ask Abed a question. Abed, you gave a very interesting discussion of how AI can actually help review data in terms of studies for inclusion and meta-analyses or review articles. Have you looked at it specifically with, say, like a Cochrane analysis for proliferative diabetic retinopathy, say, or diabetic retinopathy, and look to see what articles the AI would have picked in comparison to actually what was done in the Cochrane analysis?
So thank you for this good question. So we haven't done that yet because we started with a general search, really looking into a variety of diseases within ophthalmology. And once we're done with screening and we have all the articles that decide to include, then we're planning on looking into sort of specific diseases and comparing the performance of AI in, let's say, diabetic retinopathy, also glaucoma, for example, also in pediatrics, retinopathy of prematurity. And then we would classify the performance of AI further into these subspecialty diseases.
And based on what you've seen, are you comfortable then having the AI review the articles for you and pick them out? It certainly would save a lot of time and thousands of reviews of articles.
So far, yes, as long as the AI is used as a adjunct to a human reviewer. So as opposed to having two humans or two reviewers screen, from what we've seen, we'd be comfortable having the AI serve as a second reviewer. So not completely relying on AI, but using that as a tool to assist in screening the articles.
Thank you. Jonathan and Navi, very nice presentation on applying the Consort AI. As one of the editors for a journal, I think this is wonderful because for randomized trials, we always want the Consort diagram and the flow. How do you think we can best get people to go ahead and do this use of it?
Yeah, that's a great question. I think a lot of it is just something we noticed when doing this study is that I think the paper that was published most recently in 2022, that was the paper that actually had the highest adherence. So I think we're hopeful that, just as time goes on, there's more awareness that Consort AI is out there and it's a good guide. Yeah, maybe also if people read our publication, then they would again maybe be more motivated to follow these guidelines. Yeah, Nivi, what do you think?
I completely echo that. In defense of the articles we looked at in our review, 3 of them were published the year before or the year of Consort AI coming out. So I don't want to judge them too harshly. So I think the main thing here is just sharing the knowledge and making it more widespread, just like Jonathan said.
Absolutely. Thank you for raising the awareness, and hopefully going forward, everybody will go ahead and follow that because it really is very important to standardize these. Dr. Gallego, you presented biomarkers in RVO, and you presented a very nice model that you're using to pick up RVO using AI. Are you going forward and going to look at what the actual outcomes are in terms of a predictive model for this?
Yeah, we need more information. Is something new? The OCTA image in my country are not so available. So we need some image from the center, other countries, and we need it. We are going to work in this with some contacts. Is the next step.
It's really exciting to have international representation, with you from Colombia and with Dr. Farahat from Morocco. It's really great that we're all collaborating internationally. Now, a question for you, Dr. Farahat, with regards to the DR screening. You showed a nice program where you can detect the microaneurysms, hemorrhages, and hard exudates. Going forward, is there any possibility of using, say, one of the AI algorithms that's already out there to actually help screen the diabetics in Morocco?
We are thinking about it, but we just need to have more ideas about what are the features that we need to use in order to train our models. So as I said, now we are working on a very interesting project, which is the staging of diabetic retinopathy. And then, as you said, we had also the idea of screening the source of diabetic retinopathy, which is diabetes. So it is a project that we can develop later on, yes.
Yes, thank you. And Rita, a question for you. The SEE study used the IDXDR machine in young diabetics, and they similarly found that the ILM machine really led to a lot of false positives. So with regards to the information that you found also in the IART program using their study, using their machine for the study, is there anything that you can recommend to decrease the sheen that's visible? Would decreasing the illumination help, on the flash that's taken in young patients? Did you look into any ways to alleviate this false positive?
Yeah, sometimes we use like red, blue, and green filters. We haven't tested whether or not there is higher concordance. It doesn't decrease the accuracy that much, but it is something that we want to take into consideration. We used a small sample size of only 52 eyes, so we also want to expand our study to include more patients to investigate this further.
Great. Well, I applaud your work on that. It's very important to apply these screening tools to younger patients as well. And it just goes to show you that, whatever you use to train the algorithm also affects the output. And of course, children were also used to train it, but perhaps more is needed in both machines in there as well. So I thank you all for your wonderful presentations. We're a little bit short of time, so we're going to move on. And thank you again for all the work you're doing to push the AI field forwards. We'll move on now to our next speaker, who is Dr. Zhongji Chu from Verana Health, who will speak on automated identification of geographic atrophy secondary to age-related macular degeneration using deep learning and multimodal real-world ophthalmic images in the IRIS registry. Dr. Chu.
Thank you, Dr. Lim, for the introduction. Hi, everyone. My name is Zhongji Chu. It is my great pleasure today to present you our study, Automated Identification of GA Secondary to AMD using Deep Learning and Real-World Multimodal Images in the IRIS Registry. Here are my disclosures. Before we jump into the study, I would like to start with the take-home messages of this presentation. First, GA secondary to AMD is underdiagnosed in the real world. Second, AI/ML algorithms using ophthalmic images could be used to identify GA patients in the real world with high accuracy. And last, AI/ML combined with ophthalmic images could provide insights of GA incidence and prevalence. As many of you all know, GA is the end stage of non-exudative AMD and one of the leading causes of blindness in the US. GA is characterized by the loss of outer retina, RPE, and choroid capillaries. Since 2016, ICD-10 codes have been introduced to specifically diagnose and document GA, but it is still commonly believed that GA patients have been underdiagnosed and underdocumented in real-world settings. Therefore, we set out to develop a ML pipeline to automatically identify eyes with GA secondary to AMD using real-world OCT, fundus autofluorescence, and IR images linked to the American Academy of Ophthalmology's IRIS registry. For those of you that are unfamiliar with the IRIS registry, it is one of the largest medical registry and the largest registry in ophthalmology. It covers almost 80 million patients in the US with up to 10 years of longitudinal data. With the map on the right side, you can qualitatively tell how many practices are in the IRIS registry and their corresponding geographic diversity. With a small subset of all patients in the IRIS registry, we have multimodal ophthalmic images available linked to the EHR data. We went through a rigorous process to de-identify this linked dataset following the expert determination process defined by HIPAA regulations. Using this de-identified clinical imaging dataset, we built a machine learning pipeline to automatically identify eyes with GA secondary to AMD using OCT, FAF, and IR images. Our pipeline includes a rigorous image quality assessment process where we assess image quality as gradable as well as non-gradable. We also identify images only centered on the fovea for further analysis in GA. We have built 3 sets of training and testing data, all labeled by 2 fellowship-trained retinal specialists with a 3-round consensus workflow to ensure that all labels acquired are of high accuracy. Using these label training data sets, we built 3 different models to identify GA using 3 types of images. For 2D images like FAF and IR, we built 2 modified VGG19 deep learning models for the classification tasks of GA and no GA. For 3D images like OCT, we built a modified ResNet50 deep learning model to also perform the same classification task of GA and no GA. In total, we have 265 volumetric OCT images in 597 pairs of FAF and IR images that were labeled to use for model development and model testing. The training, testing, and validation sets were randomly split on the patient level, meaning that no patients were included in more than 1 set. For the test set, only 1 image per patient were included. You can also see the breakdown of number of patients, eyes, images, as well as the class distribution for each train and test set in the 2 tables below. Our testing data set is relatively balanced between GA and non-GA classes. Overall, all 3 models all achieved satisfactory results. FAF and IR images share the same patients during model development, and you can see the FAF model outperformed the IR model in the testing data set. The OCT model was trained on fewer patients, but achieved similar model performance compared to others. On the right side, I also have 3 pairs of examples of both correct and incorrect model predictions. On top left, the 2 images are examples from the FAF model. On bottom left, the 2 images are examples from the IR model. And on the right, the 2 images are from the OCT model. Lastly, we deployed our machine learning pipeline to 5,900 dry AMD patients from 2016 to 2020, identified through ICD-10 codes in the IRIS registry. Compared using just ICD-10 codes alone, the machine learning pipeline identified an additional 92% more GA patients. Specifically, around 1,130 GA patients out of this almost 6,000 dry AMD patients were identified using ICD-10 codes alone. However, using our machine learning pipeline, we identified a total of 2,170 GA patients from this over almost 6,000 dry AMD patients using multimodal ophthalmic images. Our results indicate that GA is underdiagnosed in the real world. As a conclusion, I would like to re-emphasize on the take-home messages of this presentation. As we have shown, GA secondary to AMD is underdiagnosed in the real world. AI/ML algorithms using ophthalmic images could be used to identify GA patients in the real world with high accuracy. AI/ML combined with ophthalmic images could provide insights of GA incidence and prevalence. Lastly, I would like to acknowledge my collaborators at Verana and thank you all for listening.
Thank you so much, Dr. Chu, for that very nice presentation. Our next speaker is Dr. Bilal Haj Najib from University of Vienna. And Dr. Najib will speak on a quantitative and topographical type-based comparative analysis of exudative biomarkers in neovascular AMD using AI. Dr. Najib.
Thank you so much, Dr. Lim, for the introduction. I'm Bilal Haj Najib from the Medical University of Vienna. At first, I would like to thank the organizing committee for giving me the opportunity to present the results of the 6th report of the RAP study titled A Quantitative and Topographical Type-Based Comparative Analysis of Exudative Biomarkers in AMD using AI. Here is my financial disclosure. Oh, yeah. I cannot move on with the slides, so I'll try again.
Try the right arrow.
No, okay, good. Here's my financial disclosure. So in the first 5 reports of the RAP study, we did a systemic analysis of eyes with type 3 derived from a pool of NAMD clinical trials evaluated at the Vienna Reading Center using fluorescein angiography, ICG, color fundus photography, and OCT. But in this 6th report, we introduced the AI methods just to add more qualitative information to our previous analysis for all 3 different types of NAMD. So the main types of NAMD were well defined in the Conan study, as you see on the left part of the slide, depending upon the axial location of the macular neovascularization. Later, we did a multimodal imaging to find out further characteristics which are different across all 3 main types of macular neovascularization, as you see on the right part of the slide. So, even there are more than 100 articles in the PubMed talking about AI in AMD, all of these articles pulled all types of macular neovascularization together to conclude about their results. Therefore, we wanted in this analysis to quantify the volumes of IRF, SRF, PED, and HRF in nanoliter, and retinal thickness and myochrometer in the central 1, 3, and 6 disc areas for each type and subtype of macular neovascularization using Vienna Fluid Monitor. As you see, we applied this fully automated AI-based image segmentation on the left for retinal thickness, in the middle for IRF, SRF, PED volume measurements, and for HRF, as you see on the right. I want also to draw your attention by HRF in NAMD. It doesn't only reflect the migrated pigments or microglia, but also, and to a great extent, the deposition of hard exudates, the lipoprotein, due to the exudation. So therefore, we included more than 34,000 OCTB scans from 457 eyes of the same number of patients with treatment-naive NAMD, consisting of 281 eyes with type 3 divided into unifocal and multifocal lesions, 55 eyes with type 2, 121 eyes with type 1 divided into polypoidal and non-polypoidal for further quantification of the subtypes. So now to the results for IRF. Type 3 presented with the highest mean of IRF volume. As you see in the table, for example, in the central millimeter, the mean of IRF volume was 66 nanoliter, about 10 times than that found in type 1 and 2 times more than in type 2. The corresponding heat maps showed the accumulation of the IRF in the central macula, which of course explain why patients with type 3 present with very poor visual acuity also at presentation or baseline, mainly due to the huge accumulation and the cystoid macular edema, as we have seen in the third report of the right of the RAP study, as you see on the right part of the scan. Now for HRF, again, type 3 presented with the highest mean of HRF, which mainly reflects the deposition of hard exudates, as you see on the right part of the slide. It was not only concentrated in the central millimeter as IRF, but distributed in the whole macular area. This also confirms our previous finding in the third and the first report, where we found that type 3 eyes presented in about 2/3 of patients of type 3 presented with very clear prevalence of hard exudates on the color fundus photography. By SRF, type 1 presented with the highest mean of SRF, whereas type 3 had the smallest mean of SRF, and SRF was also distributed in the whole area of the scanned macula. Now, PED in type 1 and 3, there were no difference in the mean of the volume, mainly because in type 3 eyes, the patient, even at presentation, they have already advanced stage, which is stage 3, where the PED is relatively big and is well established and comparable to that seen in type 1 eyes. Now to the retinal thickness, as you see here, type 3 again presented with the highest mean of retinal thickness, which took this mountain shape on the retinal thickness map, mainly due to the huge accumulation of the intraretinal fluid, whereas type 1 and also type 2 had this volcano shape, mainly due to the lack of intraretinal fluid and the preservation of the normal configuration of the foveal depression. Now to the subgroup analysis of type 3, IRF, HRF, and retinal thickness were significantly higher in the multifocal one, which also get in line with our previous finding in the fourth report, where we found that type 3 likely have more angiogenic activity compared to the unifocal subtype. And at last, in the subtype analysis of type 1, almost all parameters were higher in the polypoidal one. For example, in PED, the mean of volume, if PED was 1,000, about 1,000 nanoliter compared to about 500 nanoliter in non-polypoidal, except for IRF, which was not significantly different between both groups, mainly because IRF is rather a biomarker of retinal, not choroidal neovascularization. So to conclude, this is the first AI study provides clinicians with quantitative and topographical details of each type and subtype of MNV. These pathomorphological differences allow a better understanding of the clinical manifestation, natural course, and prognosis of each type and subtype of MNV. And in this slide, I would like to thank my colleagues at the Vienna Reading Center and Optima Lab, whose contribution was essential to conduct the RAP study. Thank you so much.
Thank you so much, Dr. Najib, for sharing this groundbreaking work with us. We look forward to the discussion. Our next speaker is Dr. Adriana Whitby from RetinSight, who will present development and validation of a deep learning fluid monitoring tool using OCT in clinical workforce flows. Dr. Whitby.
Yes, hello. Thank you very much. It's an absolute pleasure to listen and present today amongst so many interesting talks. I'm just trying to get the slide to move. Oops. Sorry. I will present today on the RetinSight Fluid Monitor, a software tool with integrated deep learning model, which allows clinicians to accurately quantify fluid volume in NAMD patients. The benefit of this tool lies in the reproducibility and time-effective way that quantitative measurements can be generated. Such tools must be robust, consistent, and trusted by the user to be clinically useful. The field of deep learning is still developing at an incredibly fast pace, with new methods and concepts arising across a multitude of fields in pure and applied research. Tools are quickly adopted into research, but adoption into clinical practice is typically much slower. This could be due to access, integration, the burden of paradigm shifts, reimbursement, and trust in AI. Today, I want to focus on a couple of key points regarding development and transparency in commercial AI. So 3 points: data, development, and documentation. Data, this is not a new concept. I think everyone is aware that we need suitable representation and diversity in training and validation data. Rather, the problem is in solving this problem without prohibitive costs or long lead times while maintaining the quality of the algorithms that we generate. In development or model selection, there are a wealth of architectures and optimization methods to try. How can we arrive at optimal models without wasting precious compute resources and choosing the best models which are clinically meaningful and show clinical improvements, and justify how we came to those models in a transparent way so users who are not technical experts have confidence in our tools? And this leads me to the point on documentation and regulatory processes. How a model is developed needs to be clearly documented in a comprehensive manner. In medical device software, we have clear ISO guidelines and standards which we can follow, and we followed for our MDR-CE marked fluid monitor software. Guidance in AI is less clear. It's been mentioned earlier today in a really nice talk. Last year, there was an ISO standard for machine learning published, and there have been various guidances from FDA. But standardizing best-in-class practices is an important part of being able to deliver trustworthy models to users. We can't expect general clinicians and users to be experts in the nuances of how to develop an AI model. But if we are working towards trusted regulatory frameworks, we can report on how the model works, what is important, the limitations, training and validation data in a standardized way, ground truth used, and the performance. And I think if we move towards taking away the technical and non-standardized language burden and formalizing best-in-class practices between AI developers, clinicians, regulatory experts, then we move some way to clinicians being able to use their expertise and knowledge to assess how and when to use these AI-based softwares and how to deal with the potential risks associated with using these tools. So if I go back to my other 2 points, first on representative data and how we did this in the fluid monitor. So, I mean, the idea of representative data, we want to have good representative coverage of patients with a specific disease as imaged by a specific device. And there are many potential axes of variance in these data. It could be the disease stage, pixel representation, associated features, pathologies, gender, race. I think everyone is aware, and these are usually disease specific. So we need clinical guidance on these things. In the fluid monitor algorithm, we trained and validated our algorithm data from both clinical practice and clinical trial data from multiple sites and sources. In our kind of effort to do this, we are building up also a large internal data repository with over 18 terabytes of data, with data management practices via data lake and database, which are GXP and HIPAA compliant. So with all this data, we have to have a kind of way of managing it and sample tractable amounts to annotate and stratify appropriately. In our current fluid monitor algorithm, actually, all data was very painstakingly manually selected and annotated by our dedicated reading and clinical team. But not only fluid regions were annotated, as is typical in these semantic segmentation models, but additional disease labels and OCT relevant labels such as low contrast labels, shadowing, presence of HRF, SHRM, and so on were added to the data sets. In the future, we will leverage these labels with semi-supervised and unsupervised learning methods to build models to automatically screen and label new data which comes into our pipeline, providing automated methods to generate data sets for training and evaluation in future iterations in a time and cost-effective manner. In addition to the variants that we tried to introduce manually with clinical expertise, we also developed dedicated augmentation techniques, which are disease and device specific, to further increase the variance in the data during training. These were developed closely with clinical experts. We would ask them, oh, sorry, I don't know what happened. We would ask them for feedback on how does this annotation look? Does it look realistic? And implement them when they were. Our model was trained on over 6,000 B scans from over 200 OCT volumes with over 150 eyes, deliberately including challenging cases and stratifying over clinically relevant features. We train models in an iterative hypothesis-driven approach. We start with many models, narrowing down broad range of options with systematic approaches of hypothesis testing, guided by an understanding of what benefits a specific architecture might bring. We started with over 100 models, eliminating those with low performance based on classical imaging metrics such as DICE score, benchmarking against our previous best performing validated model. We ensured robustness in our algorithms by pressure testing candidate models with cross-validation and reinitialized model variants to make sure that we weren't just overfitting on a small test data set. In the final evaluation stage, we go beyond quantitative evaluation, asking what is a clinically meaningful change. With similar models and performance at the DICE score, for example, we look at distinguishing features which might rank one above the other, looking for additional metrics such as individual fluid cyst detection, sensitivity, specificity, linearity analysis, and segmentation bias. We also did extensive qualitative evaluation, showing examples of predictions from multiple models to clinical experts and readers, and asking for ranking and clinical insights. Our current fluid model is a 3-model ensemble comprising of UNet-based models with a vision transformer encoders. It's combined as a soft voting ensemble and has been validated internally on 2 independent test sets and used by collaborators in research settings, and is now deployed in a number of European clinics where we will be collecting data on usability. Reporting performance, we use classical image segmentation metrics and see strong performance across all fluids and across different fluid volumes. We also looked at correlation-based metrics, and in this case, the performance is evaluated on Spectralis OCT volumes with 97 B scans. The scan density impacts the sensitivity of fluid volume captured in the OCT data, and we took an empirical approach using sampling methods to evaluate the amount of fluid volume missed as a function of B scan density. While our fluid monitor algorithms are trained at the B scan level, in theory, we can apply the model to any OCT with any number of B scans, but if you want an accurate characterization of fluid volume behavior, especially in cases where we want to detect small changes, we currently recommend a minimum of 49 B scans for tracking fluid volume dynamics. Thank you very much for your attention and the opportunity to present this work, and my thanks to the AI team, software team, and clinical team at RetinSight for their work in developing this algorithm and product.
Thank you, Dr. Whitby, for sharing this really important work. We look forward to the discussion. Our next speaker is Dr. Cornelia Kutzer from RetinSight, who will speak on the value of AI-based reading in prospective and retrospective clinical studies in neovascular AMD and geographic atrophy. Dr. Whitby, oh, sorry, Dr. Kutzer.
Thank you very much for giving me the opportunity to speak here. It's a special pleasure to talk right after my colleague Ariadne Whitby, who's heading up our AI department in RetinSight, and is one of these fantastic brains behind the work we do. Have I control over it?
Right arrow, please.
Doesn't work. Now we go. Okay. As my talk is concerning the value of AI-based tools in clinical trials, let us start in having first a look into how the full picture looks like for us when we look into eye care. When we start from the left-hand side on drug development, we see that from clinical studies over launch, we go into therapeutic monitoring, be it through observational studies or real-world evidence. And here we already have AI tools that are currently already working or will have in future. On the right-hand side, however, we see also diagnostic screening. That means coming back to the lady that was talking before us here in the faculty, that we need to make sure that people are not undertreated and not seen so that we bring all the patients back into therapy. They're not working. Thank you. This is the reason why Red Inside recently founded CARE, the Center of AI-Powered Reading Excellence, where we want to efficiently cooperate with pharmaceutical companies, academic researchers, and manual reading centers by providing AI-based image analysis to improve the performance and quality in clinical trials, also offering real-time solutions. Red Insight over the last years has developed and validated a variety of biomarkers. You see on the left-hand side the validated biomarkers in NAMD that also Ariadne touched shortly based on. Subretinal fluid, intraretinal fluid, PED, HRF, or on the right-hand side, the ones that we were recently developing for GA, like photoreceptor thinning loss and localization and RPE loss and localization, growth towards fovea, or the prediction of conversion and progression. So this means that the validated algorithms provides you tools to identify, localize, and quantify clinically relevant biomarkers. Looking now into clinical studies, where do we see the value? I have been splitting this up into prospective and retrospective clinical studies because both have different values by themselves. Looking into prospective clinical studies, we look into patient enrollment and data collections where we see positive impact on cost reduction, timeline acceleration, and the increase in success rates of your clinical studies. Looking into patient enrollment, what you could do is pre-select suitable patients based on real-time feedback right at the study site, or enhance your patient population with the most promising patients identified, for instance, as progressors for GE. On the data collection side, real-time AI allows you to continuously gather information during your clinical trials, like optimal dose treatment successes early. And of course, it offers you also the possibility to add additional biomarkers to further substantiate your product profile. What does this mean now, for instance, with regards to eligibility at the site? We all know when you go into clinical trials that you need a big number of people to be screened before you can include them into the clinical study. AI-based tools now offer you the opportunity to do this real-time on-site by one mouse click, like looking into GA lesions and identify your patients before you can further use this for further eligibility determination later on. In addition, this here is a nice work by my colleague Wolf-Dieter Vogel on the prediction of topographic disease progression, which means that you can see here a combination of what you can do when you look into a retrospective analysis by giving you the chance for your next trial to use it in a prospective trial, like doing prediction modeling that allows you to select your optimal study participants. For GA here, we were looking into this, and you could see that it was possible by using GA at baseline and GA at 1 year follow-up to calculate local progression rates or show the direction of progression. I would also like to turn your attention to E, photoreceptor thickness, where you see the dark blue area behind the light blue EGA lesion. The dark blue area, as you can see, is photoreceptor thickness here at level 0. So that means you don't have any photoreceptors left at that part of the retina, meaning that the blue, the light blue, is always following the dark blue, which we could see by the retrospective analysis, and which gives you a hindsight on what is a progressor and how slow or fast will it be progressing. This nice work also was able to give you a lesion progression heat map for follow-up over 12 months. Like you see here on the right-hand side, if it's moving, let's try it again. Usually it should be working now. You see over 12 months how the lesions are growing. And if you remember the picture before with the dark blue area, you can see that this is all moving in the same direction. If there is no dark blue area that you've seen before, you cannot progress. But the one thing that we found out here is if you just have one OCT scan, it allows us to differentiate into slow and fast progressors. On the retrospective side, if you look at this, what it gives you is data substantiation. What you could do based on AI-based readings, you can demonstrate structure-function correlation. You can characterize your patients like I just showed you in the previous work from Wolf-Dieter Vogel. In NAMD, you could use retinal fluid analysis for comparing treatment efficacy, or in GA, you can detect subclinical biomarkers like photoreceptor integrity maintenance, thinning or loss, or RPE epithelium loss. This is simply done with AI, and you cannot see that visibly as a manual reader. As an example here, what we can see in NAMD, you can use OCT images, and automated fluid quantification will provide you insights into the structure-function correlation. And here you see the impact of IRF and SRF compartments on BCVA. To summarize, our AI solutions that we have been developing and validating over the last years provides you quantified analysis of clinically relevant biomarkers of the retina with a potential favorable impact on reduction of your overall study costs, acceleration of your study timelines, and increasing the likelihood of the success rate of your clinical trial. Thank you very much for listening.
Thank you so much, Dr. Kutzer, for sharing your wonderful programs with us, and particularly CARE program, which we'll discuss in the discussion. Our next speaker is Dr. Gagan Kalra from the Cole Eye Institute, who will speak on AI-based automated segmentation of ellipsoid zone at risk for predicting geographic atrophy lesions on spectral domain OCT. Gagan?
Thank you so much, Dr. Lim. It's such a pleasure to be back at the AI Summit. Dr. Rishi Singh, Dr. Ted Lang, and Dr. Lim. It's always a fortune to be in the presence of greatness here. So with that, I'd like to dive into this presentation. Thank you for this opportunity for presenting some of our work on predicting progression in geographic atrophy. And as was talked about in the previous presentation also, I think photoreceptors are a big component in looking at progression in these studies. So with that, I'd like to move on here to my financial disclosures, which I don't have any, but my team certainly has some. You can glance over them here. And geographic atrophy, as everyone knows, is a late-stage finding in age-related macular degeneration, and it's an irreversible atrophic change that happens in the outer retinal layers. And OCT, has been great in visualizing these changes, including hypertransmission defects into the choroid. And lately, there's been renewed interest. I would say it's not a new interest, but a renewed interest in detecting and predicting progression of GA using, artificial intelligence and computational, photography techniques. So consensus of atrophy, meetings, the classification of atrophy meetings, CAM consensus talks about this in their iAurora definitions, and photoreceptor loss makes it into that definition as well. And loss of EZ integrity has been shown previously to be associated with AMD progression anyway. And as I said, with the computational photography, now it's certainly possible to have automated segmentation methods, detection methods, and even prediction methods. With this analysis, we are looking at not only just localizing and segmenting areas of ellipsoid zone at risk for progression, but also then studying that progression over a longitudinal data set of AMD patients. So we started out with 100,000 OCDB scans from about 340 patients with dry AMD, with or without geographic atrophy. And we used a mixed data sets coming from both the spectralis scans and the Cirrus scans. And the thought was that we want to have a robust data set that would be a representation of what the real world data is. And since both of these devices are very commonly available in the clinical setting, we wanted to include them both in the training. And again, we have an automated machine learning enabled multi-layer segmentation method here at the Coli Institute, which has been previously validated. And we used the method to segment ellipsoid zone, Brooks membrane, and RPE. And here, the figure demonstrates the segmentation as well here. All right, so this automatic segmentation then undergoes a 3-stage expert grader review for correcting any segmentation errors. And this is really a pipeline that has been previously validated in several clinical trials that we reported on a COL as well. And going forward, areas of GA were defined according to the CAM consensus definitions, which basically takes into account the total loss of ellipsoid zone and total loss of RPE. So that would be the zero thickness of those bounding lines, the EZ and the RPE and the RPE in the Brooks membrane. And the areas of EZ which had less than or equal to 10 microns of thickness were identified as areas that were at risk of progression to GA. And this excluded areas that were already segmented as GA. So the hope was the model should look at only areas that have the potential to progress. And this is what went into the training for this model. And we used a modified UNet architecture to create the training for this model. And we had an 8:1:1 training test validation split as well. And then going into the longitudinal testing part of this analysis, we had 120 independent eyes that were intermediate AMD, and we wanted to assess over a 5-year period how the progression of geographic atrophy or AMD in general would happen with this analysis, now that we have the ability to quantify area of the macula that is occupied by ellipsoid zone that's at risk of progression. So it's a novel biomarker. We wanted to test that. So here are some results from this study. The automated segmentation of ellipsoid zone at risk achieved a high accuracy with an AUC of 0.97 and with a very high sensitivity as well in the holdout test set. So these are images that the model has not seen before. And in the independent longitudinal testing set, we were able to show that percentage area of EZ at risk shows significant positive association with the growth of GA at year 5. And that result was very significant. Here in the figure, we can see the panel A shows the raw image and panel B shows the deep learning grayscale output of the ellipsoid zone at risk model. And the thing I want you guys to focus on is the fact that it's in one step, it's not only identifying areas of EZ that are atrophic, but also at the same time, it's excluding any areas that are already at GA. So it's able to merge that approach of what is already at GA and then look at areas which are at potential for progression. Here's the receiver operator curve for the results that I just talked about in the previous slide. So with that, what about how we take a peek in the future? So here's a patient case that we are presenting here, where we look at the same patient at year 1 and year 5. So panel A and B actually show the on-fast map of that OCT on-fast map of that patient. And you can see in figure A, there is some hypertransmission, but no areas of GA were segmented based on a ground truth segmentation. And figure B shows the areas of GA that were then segmented using the ground truth segmentation as well. But panel C shows what the deep learning model of the ellipsoid zone at risk could see at baseline. So at baseline, that is the level of disease that was present, but was missed based on the clinically accepted endpoint at the time that was GA. So we are talking about the subclinical biomarkers as ellipsoid zone attenuation. And panel D then shows areas that would have successfully been predicted using just ellipsoid zone as a biomarker. In green, you can see the areas which it would have predicted, and red are areas which in future will likely progress as GA. Here, I talk about another example of how, at year 0, year 3, and year 5, ellipsoid zone at risk is able to not only just predict where GA is going to be, but also exclude areas that it already knows are atrophic. And cannot progress further. And eyes developing GA within 5 years had a 3-fold higher baseline EZ at-risk lesion burden, and that result was also significant. So in conclusion, automatic segmentation of ellipsoid zone at risk was achieved with a reasonable accuracy, and this novel biomarker showed positive association with growth in GA area. Assessment is currently ongoing in larger longitudinal data sets looking at 2, 5, 7, and 10 years of follow-up of patients, and assessment of this biomarker in association of previously prescribed biomarkers such as drusen burden is also currently underway. With that, I'd like to thank my team here at the Tony and Leona Campaign Center of Excellence in Image-Guided Surgery and Advanced Imaging Research under the leadership of Dr. Justice Ehlers and the AI Summit panel for this opportunity.
Thank you so much, Dr. O'Carroll, for sharing this groundbreaking work with us. We look forward to the discussion. Our next speaker is Dr. Dimitrios Damopoulos from Roche, who will be speaking on predicting 5-year progression to vision-threatening complications using machine learning. Dr. Damopoulos.
Hello, thanks. I'm Dimi. Yes, I'm working for Roche. I'm based in Basel, and I'll be talking about predicting the progression, predicting the risk for progression to a vision-threatening complication of DR in a 5-year window using machine learning. These are, I'm trying. Okay, cool. These are in more detail my financial disclosures and those of my co-researchers and authors. This audience wants well what diabetic retinopathy is, or DR. It's a complication of diabetes that can lead to further vision-threatening complications such as center-involved macular edema, clinically significant macular edema, or proliferative diabetic retinopathy, CIME, CSME, or PDR. This progression can be slow. It can take several years after the initial diagnosis of a mild form of DR. I have here a visualization of DR based on DRSS, the Diabetic Retinopathy Severity Scale. So these are example color fundus images, F2 images from its stage. So in a nutshell, here, our objective is to develop and evaluate a method for predicting the 5-year risk of progression to a vision-threatening complication in diabetic patients who either did not have DR or had a mild form of DR at baseline. For that, we used a dataset of 172 patients originating from a clinical trial, which was organized and conducted by the IBILI Institute in Portugal. What's important here when it comes to inclusion criteria is that these are diabetic patients, type 2, adult people with DR of 35 at most at baseline, so mild non-proliferative diabetic retinopathy at most, and a BCVA of 75 letters. Patients for which high-quality color fundus images could not be acquired or who had glucated hemoglobin of more than 10% at baseline were excluded. On this data set, on this set of 172 patients, 6 developed either PDR, CIME, or DME already within 1 year, and 27 did so within 5 years. So a progression rate of a bit less than 16% within 5 years. In contrast to everything we've heard today, this is a shallow-based modeling approach, one with an extremely high bias, which in my experience is what one first tries on such small data sets. So we have a linear regression trained with L1 regularization in a standard 5-fold cross-validation scheme. What I want to emphasize here is that we have a very rich feature set at baseline. So from laboratory measurements, OCTA, color fundus images, and demographics, we have a bit less than 90 potential features. It's infeasible to use all of them at once. We use 2 approaches for reducing this dimensionality, either simply selecting some of them based on domain knowledge, or using an automated unsupervised approach. In the former case, we used firstly 5 imaging-based features. That will be the number of MAs as measured in color fundus images, and 4 thickness-based features, namely the CST and the inner nasal thickness over 2 pairs of layers. In addition to that, 3 systemic features. Probably a misnomer because time since diabetes is not really a systemic feature. Anyway, so 3 extra features: the time since the diagnosis of diabetes, BMI, and hemoglobin levels. Alternatively, we used an out-of-the-shelf unsupervised clustering approach to get again 8 clusters of features from the original feature set. And at the end, the model sees the mean values of the normalized features of its cluster. I'm going to be reporting here the mean and the standard deviation of the area under the ROC curve over the 5 cross-validation folds. This is an overview of the performance. On the left, you can see the areas under the ROC curve when the features are specified in an unsupervised manner. So we get an area under the curve of 76% with, on average, with a standard deviation of 4%, rather decent, I would say, and very similar performance when the features are selected manually. A bit higher mean area under the curve of 78% and quite large standard deviation over the 5 folds of 9%. In this table, you can see an overview of the statistics of the features, of the manually selected features at baseline. I want to emphasize here the hemoglobin levels. They were 7.5% at baseline. If you recall, the inclusion criteria was that there should be other 10%. And here's an overview of some results with an even more reduced set of features. So we saw what happens when we use only 5 imaging-based features and only the 3 systemic features. In both cases, the performance drops, and much more so when using all the 3 systemic features. It's only 64%. Area under the curve, I think, just barely above the random signal. So in conclusion, in this cohort of patients with either not DR or a mild form of it, the models were able to predict the progression to a vision-threatening complication with a mean area under the curve of 78%, despite the low progression rate. Similar performance was achieved when the feature was selected manually or in an unsupervised manner. We observed that the imaging features alone were much more predictive than the systemic ones alone for predicting the progression to a vision-threatening complication. This is consistent with the results of similar studies. However, on that note, I have to emphasize that the patient population here is one from a clinical trial, and that means they had well-controlled glucose levels, they had the images, the CFPs were of high quality, and neither of these statements holds true necessarily on a real-world setting. Our hope is that we're going to have larger and more diverse data sets to develop such models, predictive models to a vision-threatening complication, which can inform personalized monitoring and follow-up in a clinical development or in a clinical practice setting. Thanks a lot. Thanks again to my collaborators, and thanks to the organizers here for walking us through.
Thank you, Dr. Damopoulos, for sharing this nice work with us. We look forward to the discussion. Our next speaker is Dr. Yannick Liederman from University of Illinois at Chicago, and he'll be speaking on feature tracking and image segmentation in real time via deep learning in vitreoretinal surgery, a framework for AI-mediated surgical guidance and assessment. Yannick?
Thank you so much, Jenny, and thank you for having me as one of the speakers. As the final speaker, we're going to be shifting gears a little bit from static image interpretation to some work in ophthalmic surgery. These are my disclosures. Of note, I'm the co-founder of Microsurgical Guidance Solutions, which holds IP for some of the technology that we'll be discussing today. So digital surgery has been defined as the use of digital technology for the enhancement of preoperative planning, surgical performance, therapeutic support, or training in order to improve outcomes and reduce harm. Let's begin with a working definition of surgical guidance from a surgical data science perspective. The first component is integration of information from imaging modalities, our instrumentation, and the surgeon. In our case, data analysis is executed using a deep learning neural network and computer vision, followed by output to the surgeon and instrumentation that must be able to enhance instrument performance or support surgical decision-making in real time. We're developing a digital tool set for ophthalmic surgery, and I'd like to share some of our work in pars plana vitrectomy and surgery of the posterior segment to start. This is an overview of our technology pipeline for VR surgery. Imaging is acquired from a commercially available digital stereo microscope or optical microscope with HD camera, and a neural network performs image processing. Then a set of phase-specific digital surgical tools is activated accordingly. The network output is then injected back into the surgical frame or relayed directly back to the instrumentation. So today I'll be discussing really mostly the first three categories: enhanced visualization, surgical templates, and tissue and tool tracking. Here's an example of image enhancement. The video on the left demonstrates suboptimal visualization from media haze. AI-mediated image processing yields an improved view of the surgical anatomy. Note the retinal vessel immediately proximal to the forceps tip. It's difficult to discern in the unenhanced image, representing a potential source of complication during peeling. Similarly, during cataract surgery, image enhancement shown on the right improves visualization of the margin of the capsular rhexis in comparison with the unprocessed view on the left. This is a sample of tool and tissue tracking. The locations of the vitrectomy probe, optic disc, and macula are being tracked in real time. The labels are shown only for network performance demonstration purposes. Instrument and tissue tracking is ideally performed in the background. This is a more complex scene in diabetic retinal detachment, where the macula, optic disc, the laser probe, and a retinal break are simultaneously being identified and tracked with the network. Laser spots at the margin of the break are also identified as they are applied, and this serves as a foundation for semi-automated delivery of retinal laser. And here's an example of image focus assessment. The network uses the optic disc and an area of approximately 1 diameter outside of it, including the proximal retinal vessels, as a reference point to anchor the focus. And lastly, AI-based collision avoidance methodologies have outstanding potential in VR surgery. The vitrectomy probe, detached retina, and an area of scleral depression are tracked, and a proximity alert is provided when the cutter is at risk of interacting with mobile retina. And while this kind of feedback may not be necessary for the experienced surgeon, the real value in these data is the potential for feedback directly to the fluidics engine and automated modulation of fluidic parameters to improve performance and reduce the likelihood of iatrogenic retinal breaks. The performance of our network for detection and segmentation is robust for a variety of features. And now let's conclude just a little bit with the discussion of surgical guidance in cataract surgery. Here's an example of surgical guidance during the capsular rhexis. Contrast equalization improves visualization of the surgical field and appreciation of the margin of the rhexis, and the faint inner yellow circle provides a template to facilitate the execution of a circular and well-centered symmetric rhexis of the desired diameter. And most importantly, this can be adjusted based upon how the rhexis is going in order to provide an optimal tool path. During nuclear disassembly, our surgical guidance tools track lens particle motion and other surrogates in order to indicate turbulent flow when present, project a tactical safe zone, and quantify the extent of exposure of the posterior lens capsule. Similarly, for cataract surgery, we have good performance during tools for the capsulorhexis, nuclear disassembly and phacoemulsification, as well as cortex removal. In summary, we've developed an automated pipeline that applies surgical guidance tools to facilitate intraocular surgery in real time using deep learning and computer vision. We've achieved effective instrument and tissue localization via regional-based convolutional neural networks, enhanced visualization of the surgical field, and implemented a set of phase-specific surgical guidance tools and achieved performance in real time. And I'd like to conclude by talking a little bit about automated detection and segmentation of a spectrum of tool and tissue features in order to help with performance evaluation. So convolutional as well as recurrent neural networks have been applied in other surgical disciplines using instrument movement detection to classify surgical skill as either expert or non-expert in a binary classification model. Robotic instrumentation, which of course we don't use in ophthalmic surgery, is particularly amenable to these types of analyses as instrument motion is measured natively by robotic platforms. Prior studies have corroborated something that we as surgeons understand, I think, intuitively, and that's that there are observable parameters that differentiate less skilled from more skilled surgeons. But we really have very little data to understand what those parameters are, again, other than just some of our own intuitive observations. One study found that attending surgeons make fewer attempts at initiating a flap during ILM peeling compared with trainee surgeons. And again, this was done with just manual annotation of videos without using AI. In addition to instrument handling, visual attention during surgery may differ according to surgical experience based upon differences in studies of diagnostic image interpretation, such as the study below for how novices versus experts look at the optic disc in glaucoma grading. So we hypothesize that there are differences in behavior among subgroups of retinal surgeons that correlate with measurable outcomes, and that identifying parameters, automating analyses, and quantifying divergences by analyzing surgeons' instrument handling and visual attention behavior will enable the identification of data-driven metrics, and that a subset of these metrics will yield actionable feedback with the potential for accelerating trainee learning and performance. In contrast to previous approaches in ophthalmic surgery, where a limited set of parameters amenable to manual annotation were assessed for differences among trainees versus attending surgeons, we've identified a host of parameters using AI-based methodologies that serve as objective performance indicators. We found significant differences in these parameters during vitrectomy, membrane peeling, and endolaser delivery among less versus more experienced surgeons over a spectrum from early trainees to quite experienced vitreoretinal surgeons. And we saw that these differences held up in our Chicago cohort, as well as a cohort of surgeons in Mexico City, representing diversity in terms of surgeon experience and training background, but also a significantly diverse patient cohort. Finally, we're using similar-based surgical performance to begin to correlate visual attention with analyses of instrument and tissue parameters. We're applying our tool and tissue tracking network to output from the IC surgical simulator platform in parallel with gaze tracking as a surrogate of visual attention in order to inform performance assessment and gain a deeper understanding of surgical expertise. So here's an example of tool and tissue tracking as well as gaze tracking simultaneously during simulated focal endolaser application for a retinal break. Network generated labels are shown, and the green comet tail indicates surgeon gaze, in this case, pretty well fixated on the retinal hole as laser is delivered. So in summary, we've identified a host of parameters using AI-based methodologies that serve as objective performance indicators in vitreoretinal surgery. Divergence among less versus more experienced surgeons was detected in multiple instrument handling and microscope-based visualization parameters. Identified performance indicators were assessed among surgeons representing several practice environments in the US and Mexico and tested on a diverse patient cohort. Visual attention in ophthalmic surgery is a significant performance indicator. And lastly, I'd like to thank particularly my current PhD student, Rogerio Nespolo, as well as the rest of our academic research group, our collaborators, and all those who have ultimately contributed to this work. Thank you.
Thank you so much, Yannick, for sharing this groundbreaking work applying AI to surgery. I'd like now to invite all of our speakers back to the panel. And while they're coming on here, Yannick, I'd like to ask you, how do you foresee applying this into the OR? Are you going to integrate it into the microscope, say, or within the vitrectomy machine itself so that we can use this?
Yeah, that's a great question, Jenny. And I think, ultimately the visualization system and our instrumentations like vitrectomy and cataract are going to have to communicate directly. And part of why I think that's a question of not if, but rather when, is there's so many parallels with the automotive space, right? And that's the way that our cars work now. If we're driving in icy conditions, you don't just get a prompt saying that your braking is affected, but all of our cars now literally thousands of times a second sense whether the wheel is slipping and immediately give that feedback directly to the drivetrain so that it happens more quickly than you can react and in a seamless way. And I think that's the way things will probably be headed with our fluidic parameters and vacuum during vitrectomy if you're in danger of cutting the retina.
I guess this is a first step towards truly robotic surgery in the future, maybe in our lifetimes. We'll see. Thank you so much. I'd like now to ask Dr. Chu a question, actually two questions. You had mentioned that GA is undercoded in the IRIS database, and I'm curious whether you actually looked at the clinic notes to see if the person who was doing the exam had actually noted an area of atrophy, but just simply forgot to code into the system. That's the first question.
That is a great question. We're actually have ongoing work right now to use NLP to look into the clinical notes to see if there's actual documentation of GA diagnosis. So this is ongoing work, and I look forward to be able to share the results we have once we have finished them. So we definitely suspect there is both undercoding and underdocumentation with a subset of patients that we have with both clinical records, medical notes, as well as images. We're hoping to be able to provide more data into this issue.
Thank you. And the second question is, I was surprised that the FAF and the IR were more sensitive for the detection of GA than the OCT. And I'm curious what parameters specifically you were looking at. Were you looking at the EZ? Were you looking at CRORA, IRORA, or what exactly was the AI looking at on the OCT?
Yeah, that's a great question. I think the difference in performance metrics likely mostly due to the different sample size we had in training. So with FAF and IR, we actually have almost double the size of OCT images we have in our development set. So I think the performance is likely due to the sample size, but you can see with the IR results and OCT results, even though OCT was only using half of the amount of images, it was the same level of performance. So I think that indicates that it's a little bit easier for the model to learn with smaller sample size with OCT images. But when we're doing the labeling, we follow the CRORA criteria following the CAMS3 study.
Great, thank you. So question for Dr. Geoghegan-Kalra. So Geoghegan, you heard Dr. Chu's response for the OCT detection of GA, and you showed a nice study where the ellipsoid zone was very predictive of future growth of GA. Do you plan to deploy this so that, when we have these treatments for GA, right, that can slow down the rate of GA, we can target these specific patients?
For sure. I think, thank you for the question, Dr. Lim. I think that's a great place for this to go. And we are literally exploring that now also with ongoing, data analysis here internally at Cole. We have found that in some of our data that patients who have high EZ at-risk burden would progress 2 to 3 times faster compared to the ones that don't have that. And these are just natural history studies. So I think certainly the question is that it can help us hyper-select for fast growers, because I think that's where clinical treatments can make the biggest difference. Otherwise, because if the patient isn't growing, you could imply that they were not going to grow anyway because they didn't have enough burden originally.
And with regards to visual acuity, saving visual acuity, did you look at the location of the segmentation loss of the EZ? Like how close was it to the parafoveal region, perifoveal, foveal area itself?
So that's certainly something that we are doing right now with a much larger data set, because we initially wanted to make a proof of concept to see if there is any signal there to double down on. But now that we have proven that that is the case, we have a lot more data that we are looking at now, as I said, 2, 5, 7, and 10-year follow-ups, and even beyond that with a lot of longitudinal data. And we are marrying that together with visual acuity and also phenotype patterns, how the macular distribution of lesion is. We are able to track that across time points as well with co-registration. So it's really exciting time to be in this space, and I'm certainly fortunate to be able to be a part of this team here.
Great. We look forward to those results. I'd like now to address a question to Dr. Najib. You showed very nicely the structural functional correlations, with the anatomy that you see on the OCT and with what we see clinically with MNV3 doing the worst because of the high volume of intraretinal fluid, intrarectal hyperreflective foci. I'm curious, did you look at these to go prospectively now, longitudinally, to see how predictive they are for visual outcomes in specific subgroups of these eyes, like MNV3, burden of these findings, and rates of progression?
From our data set at the Vienna Reading Center, all the data are actually prospective because they were taken from different clinical studies for evaluation of different anti-angiogenic agents. So the data are prospective, but we evaluated till now only the baseline visits. But currently we are going on another new type 3 study where we evaluated somehow long-standing eyes with type 3 just to evaluate the fibrotic tissue in these eyes, as well as the retinal choroidal anastomosis typically seen in these eyes. So for the baseline, we have already published a lot of information using multimodal imaging, but now we are working on, let's say, long-standing type 3 eyes just to find out what's going on in the RPE, in the sub-RPE space where the fibrotic tissue is.
Thank you.
It's very challenging, but we are still working on this topic. Thank you.
Thank you. I'd like to ask Dr. Whitby a question with regards to the neovascular AMD fluid analysis. I found that very intriguing. It's going to be very helpful, obviously, in clinical trials as well. Have you been able to identify a specific threshold where we would need to begin to worry about the amount of fluid that's building up and therefore trigger a visit, say, retreatment now is more important than when the volume is smaller?
Yeah, that's a really interesting question. And I think, I'm from the AI side, so I always tend to defer to my clinical colleagues and clinical experts for these kind of things. But I think one of the key interesting things is not just identifying a threshold of when the fluid comes back, but also looking at trends in the response to treatment over a longer period of time, and looking at the progression of the fluid changes, which fluids are actually responding to treatment, which are not. This can be the case, looking at that quantitatively, because we show both the change in the fluid volume, but also the representation of the fluid in the sort of on FAS and in the B-scan representation. So users can actually also kind of take that information and start to see, okay, what is changing for this patient? So it really comes down to patient-specific changes. And in terms of a specific threshold, I don't want to make anything up. I don't have a specific answer. I would defer to the clinical experts on that, and I provide the right tools to do it. But I do think it's a very interesting question. And I think more and more as you move towards personalized medicine and being able to treat the patient rather than just treat the disease, these kind of information for the clinical experts can be really helpful, and they can start to build up that body of knowledge for themselves. We can also see it in clinical trials. We can see it in research that comes out of universities and academic centers to identify what is the right way to improve treatment. How can you reduce the number of injections and reduce patient burden? How can you reduce costs to payers and so on? So I'm very interested to see how we can kind of capitalize on knowledge and benefits to patients and clinicians alike with these tools. Thank you for your question.
Yes, I think we saw from Dr. Lowenstein's presentation this morning too, that the rate of the fluid response with treatment is faster if you catch it earlier. So it will really be an interesting thing to monitor as we go forward. Dr. Kutzer, I have a question for you. I was very intrigued by the CARE program that you mentioned, the whole system. How soon do you think we can integrate this into clinical trials? And do you think this will help us get to the answers of clinical trials sooner because we're able to analyze the data so much faster?
Well, the good news is we are already integrating this into clinical trials because we are already working with partners out there where we are applying our AI tools in the analysis. I think, I mean, the beauty is here, especially when you look at the progression for GA, for instance, that will make the life much easier if you can just, nail down the population that is optimally responding to the treatment. So for us, it's really about, combining retrospective analysis and prospective clinical trial outcomes so that we can make sure that when we're working with our partners, that based on our retro analysis, we can make sure that for the prospective clinical trials, they have the right number of optimal subjects, reducing simply also the number of people that you need in there. And I just would like to come back to the GA progression and the discussion earlier in this faculty. It's based on the work that we were doing before on GA, we could distinguish between fast and slow progressors. So basically with one OCT scan, you can already see that because we nail it down on the photoreceptor versus RPE loss and the ratio thereby. And that way you can distinguish between fast and slow progressors, which makes it much easier than to go into prospective clinical trials and use the right people.
I think it's really exciting. I think all of these AI tools are really going to inform our selection of patients, our follow through the patients, analysis of the results, speed up the reading center, maybe replace reading centers. I hesitate to say that. And really,
we always will need people.
Yes, we'll always need people. I have one final question here for Dr. Demopoulos. You identified the PDR, right? You could pick out which patients were going to be at high risk for progression to vision-threatening complications. So I'm curious, in terms of trying to find this particular group, would you then target this group for prophylactic therapy?
So I'm a machine learning expert, and I think this expression was used earlier. I would defer to my clinical experts for that before I say something very stupid. Without exactly answering your question, I want to say on what I presented, as you remember, first of all, a small cohort. Secondly, PDR, the progressors to PDR were even fewer. So there's not much I think one can say from this small study, especially for PDR. And finally, it's a very difficult task to try to predict for this kind of slow progressing diseases what will happen in 5 years. So yeah, I don't know how much that answers your question, but
well, I'm really curious because, we do know that prophylactic treatment in high risk NPDRs, severe NPDRs, and, some moderates can delay the onset, right, and can decrease the DRSS score. So it'd be really neat if you had a program that could take a particular NPDR and not just look at it as group, but look at it for that specific patient and model out with high certainty, high REC, area under the curve, and then say, okay, for you, it makes sense to go ahead and use the anti-VEGF treatment. So we look forward to your continued work.
That's the ultimate goal and dream. Yes, absolutely.
Great. Well,
but one need way larger data sets for that. We hope we're going to have such a tool in the future. But yeah, absolutely, that's the goal.
Well, thank you all for pushing the field forward. This has been a wonderful morning. There were outstanding talks. Thank you for the discussion, for your erudite opinions. And I really look forward, hopefully, to the 4th OAI symposium next year. I'd like to thank my co-directors, Rishi Singh and Ted Lang, for helping me put this program together. Of course, iVista for their amazing coordination of everything. I'd also like to thank our wonderful audience today for sending in questions as well and for staying with us until the end of this program. Thanks also to the sponsors, who I'll name in no particular order, Genentech, Regeneron, Iveric, INAC, Apellis, Boehringer Ingelheim, and Regenx Bio. We couldn't have done it without you. So thanks again. Have a great rest of the day, and we look forward to seeing you next year. Take care.
Thank you so much.
Great job, everybody. Good to see you all.
Thanks.